Good morning to all our esteemed guests and a very warm welcome to the 8th West Bengal Pediatric Rheumatology Society Conference and Mid-term CME, Indian Society of Kawasaki Disease. Normally, this event is held on 1st May every year. But as we are also hosting the midterm KD-CME, we decided to hijack the weekend and convert it into an academic weekend wherein a wide variety of rheumatological aspects will be discussed by faculty both from outside and within the state. The essence of this annual event is to spread awareness about the ever-evolving yet so mysterious specialty. We encourage all to participate and ask your burning questions. Without any further ado, we will kickstart the scientific extravaganza with our first talk. I would like to call upon Dr. Kaushik Basu, Associate Professor of Rheumatology at Medical College, Kolkata.
Good morning, dear seniors and colleagues and juniors. A warm welcome to the West Bengal Pediatric Rheumatology Society Conference and Midterm CME of Indian Society of Kawasaki Disease. The topic we have right now is what we know already. But even if we know it, we need to go into the details. Rheumatology is all but about the joints. We do believe it to the core of our heart, but we'll know it in more details from Dr. Paramita Nath, who is a young pediatrician practicing at Manipal Hospitals, Kolkata. She is an associate consultant at the institute. Dr. Nath, please.
Thank you, sir. And a very good morning to everyone. I want to thank the organizing committee for giving me this opportunity today. So, what comes first to our mind? Okay, thank you. Okay, so when we think of juvenile idiopathic arthritis, what comes first to our mind? First thing that comes to our mind, be it clinically or be it in literature, that is joint count. But today I want to, in the next 15 minutes, I want to discuss why joint count is important, but it's not everything. So a brief introduction, we all know joint count is the traditional focus in juvenile idiopathic arthritis, and it has helped us for diagnosis, early diagnosis or assessment of disease activity or even during treatment assessment. But the growing understanding is the broader assessment, need for broader assessment like activity scores or involvement of lab or imaging or even composite disease activity scores. So first, the strength of joint counts. Yeah, it gives a snapshot of the active arthritis, which is very easy to perform, and we can evaluate the disease activity by only pointing out how many having swelling joints or tender joint count, and we can easily predict the joint damage risk in early disease. But now, what are the limitations? Since it's a very subjective method, human error is a thing which we have to keep in mind. And often, the examiner can miss subclinical diseases or enthesitis, which is not in the joints per se, or even it can miss systemic features. And also, it does not have a very good correlation with quality of life of the patients. So these I'll be discussing in details. So I'll discuss few cases with some examples. So our first case is a 4 years of female child who presented with a single joint swelling, right knee, along with limitation of movement. She had no fever, no rashes. Her CBC was normal, ESR was almost near normal, slightly on the higher side, 31, ANA was positive. So this child was diagnosed as oligoarticular JIA, ANA positive. Now she was started with conventional treatment, methotrexate and naproxen, and she did well. After 6 months, she had zero joint count. But what was missed? After few months, she landed up with this. So, what was the learning points? Uveitis can cause a silent damage in JIA. It can be insidious and initially it may be asymptomatic, especially in oligoarticular JIA. So, regular ophthalmology screening is very crucial for those who are having all these risk factors like ANA positivity, early younger onset of disease or oligoarticular onset. So to summarize, ANA positivity with those having age group of less than 7 years and those who are presenting with oligoarthritis or psoriatic arthritis, they should be screened once in every 3 months if JIA duration is less. If more, then once in 6 months, and after that, once a year. So coming to the next case, this is a case of 3 years old female child. She was having persistent fever since 3 weeks along with this rash. And on examination, she had hepatosplenomegaly, cervical lymphadenopathy. So CBC was hemoglobin slightly on the lower side, count slightly on the higher side with neutrophilic predominance. Platelet was 4.5 lakh, ESR and CRP both were on the higher side. So at this point, 2D echo was done and it was showing mild dilatation of left coronary artery. So any thoughts from the audience, what it can be? Yes. So this child was diagnosed as Kawasaki and she received IVIG, but unfortunately she was having persistent symptoms. So at that point we got a referral and we had to dig deep into the history. So this was the fever pattern when we asked for it. And the parents are very particular about the rash. They are coming and going with fever. So we had to revise our diagnosis and change it to systemic onset JIA SINE arthritis. So the learning point is systemic onset juvenile idiopathic arthritis may be absent in the beginning or it may be a late presentation. So we have to focus on we have to see the whole picture. Fever, rash, lymphadenopathy with organomegaly, and the lab investigations, we have to put the picture together and make a diagnosis. And in JIA, we have to be careful of MAS, macrophage activation syndrome. Usually the children of systemic onset JIA, they are not very sick. During the afebrile period, they are very active child. So in any change of pattern in fever or falling or trend of ESR platelet, we can think of MAS. So the inflammatory markers and biomarkers, I will not go in much detail because these biomarkers like CRP, S100 proteins or IL-18, these play a role to monitor the disease activity as well as to monitor the medication when to taper or we can stop. So coming to case 3, a 14 years old boy with history of trauma 8 months back. He had a low back pain with difficulty to sit cross-legged. He went to an orthopedician and the investigation has shown with high ESR was 72, HLA-B27 was negative. So he was given conventional treatment along with bed rest, but he used to have persistent symptoms. So again we had to revisit the history. He was having early morning stiffness of almost an hour with tender points around his knee joint. And when we asked for an MRI, it was showing sacroiliitis of one side. So the diagnosis was made as enthesitis related arthritis, HLA-B27 negative. So learning point is HLA-B27 negativity does not rule out enthesitis related arthritis. We have to see beyond the joints like enthesitis or dactylitis. Like dactylitis, which is a hallmark of psoriatic arthritis or enthesitis points. Now I'll be talking about the role of imaging. We all know musculoskeletal ultrasound is very helpful in diagnosing subclinical diseases. So in this image, grade 0 is no effusion, but grade 1 and grade 2, this mild and moderate effusion, this can be missed by clinical examination sometimes, which can be picked up easily. and also MRI, which plays a very important role in proving a child with sacroiliitis. So what matters beyond joint counts? Patient and parent perspective, emotional health, and most importantly, quality of life. So patient perspective, we use this pain visual analog scales, which is very convenient to use in our OPDs. And also this is a scale showing parent rating of child's well-being, overall rating, and also intensity of pain. And the other one is Physician Global Assessment Scale. This is a CHAQ questionnaire which also can be used to determine the quality of life. So this was a recent article which was done for initiation of validation of composite disease activity score. So these are the scores which are usually used. Most commonly used is JEDA score. So JEDA score is juvenile arthritis disease activity score, and it usually it's composed of Physician Global Assessment, which I have shown before, parent global assessment, active joint count, yes, it is a part of the score, and also ESR. So JEDAs can be 10 joint score, 27 joint score, or 71 joint score. And this is just a modification of the JEDA score. It's the systemic manifestation score. So it's used usually for systemic onset JIA. We have included the clinical and lab features here. So this is a very easy calculator which is used for enthesitis related arthritis or ankylosing spondylitis. It's known as ESDA score. And it directly gives you an idea if the child is having inactive or low or high disease activity. So this is one more paper which has been published recently, last year, which has evaluated the key performance indicators of the process of care in juvenile idiopathic arthritis. So here we can see the measurements which have been done for the key performance indicators. First is, of course, the joint assessment. But other than that, Physician Global Assessment of Disease Activity or Assessment of Functional Ability by using CHAQ questionnaire, or the most importantly is composite disease activity measurement like the JEDA score, C-JEDAs or S-JEDAs, which I have described previously, and also assessment of arthritis related pain. So the clinical practice implications which we have to keep in mind. So integrating the imaging, we have to track the patient reported outcomes. We have to use composite disease activity score to get an overall view of the disease, and also accordingly we can personalize treatment plan. So to summarize my talk, joint counts matter, but they are not enough. We should have a holistic and multi-dimensional assessment, which is the key to have a whole picture and a better outcome. Thank you.
Wonderful, Dr. Paramita Nath.
Thank you, sir.
We have completed well before time. So that leaves us with ample time to interact with the audience. To set the ball rolling, you mentioned that enthesitis is a very important component. We adults do keep check of a enthesitis count. So is it a common practice in pediatric rheumatology patients to count the sites and number of points where enthesitis is there? Is it common?
Yes, sir. If the child is an adolescent boy, usually, first thing we think of is with a lower limb involvement mostly. So first thing that comes to our mind is maybe we are dealing with an enthesitis related arthritis. So it's very important to check the enthesitis points also. Usually I do that
for every visit you
for
do that.
every visit I'll because sometimes joints are silent, but if the enthesitis points are tender, maybe we are having an active disease.
Anybody from the floor? Yeah, there are many. Ma'am.
You mentioned the case of Sogia which had a coronary artery.
Can we have a microphone?
So you mentioned a case about Sogia which had a coronary artery dilatation and many people thought it was KD. So
Yes.
is there a recommendation to do echo for all Sogia cases?
No. So initially, that was a learning point, ma'am. So initially the child did not have any arthritis. She had zero joint involvement. She was having almost a similar disease picture like Kawasaki. And for that only 2D echo was done. But The coronary artery dilatation, like it's not exclusively in Kawasaki is my point. Any inflammation can cause that. So we have to, again, we have to see the whole picture. The trick was lying in the history. I have shown the fever pattern. He was having a typical quotidian fever. And also the rash, the parents were particular, I said. The rash used to come and go with fever, which is seen only and only in that was later, ma'am. Initially, yeah, no. Echo is not required to, no, not recommended.
Hello.
Yes,
Yeah.
sir. Yes, sir. It can be. So, vice versa. Here, in this case, the child did not have any arthritis because it may be as late as 10 years. Arthritis, onset of arthritis can be as late as 10 years from systemic features. But yes, Kawasaki can have arthritis, but again, sir, we have to put the puzzle together to get
So,
a full diagnosis.
so can we summarize that in case of IVIG resistant Kawasaki, do search for other causes?
Yes.
Sir.
12 years old female child diagnosed as Soji 1 year back. Now presently not on any medication. Now admitted with history of fever around 8 to 9 days, 2 spikes per day around 102 degrees centigrade. Mother is very particular about 8 a.m. and 6 p.m. around. Sepsis screen is negative. Count is not raised. CRP is around 2.47. Blood culture yet to come. Clinically there is no focus. So how to approach? How to
So the child was diagnosed as Soji.
Child was diagnosed as Soji 1 year back.
So we have to see
It was fully
the,
evaluated at CMC Velo, now presently admitted here.
maybe it's a flare. We have to see the trends of the inflammatory markers and put it with
Inflammatory matter CRP is only 2.47. ESR is around, I don't remember. ESR is not too raised.
not too less.
Not too raised, I mean.
Not too raised. Okay. And also we have to think of mass in that case. If it's on the decreasing trend, macrophage activation syndrome is.
CRP is low.
Or it can be a superated infection, which is.
But almost 9 days has passed, 9 to 10 days has passed. So now I have to. Culture yet to come, madam. Now almost 9 days has passed, so viral fever.
No, a lot of viruses can have a prolonged fever. So parvovirus, infectious mononucleosis, even adeno, we have seen very prolonged fevers in adeno. So possibly if the child is otherwise stable, the counts are normal. So I don't think it's just a reactivation of SJIA for the time being. Possibly. Suma, your opinion?
No, I would be very careful before you start steroids. You have to be fairly clear what you're dealing with. And yes, many viral infections can last a long time. And sometimes naproxen is a good friend while you wait and watch.
Absolutely. So, naproxen, we did not forget. Viral infections are most common. Irrespective of where we stay, which part of the world, COVID has reminded us of that again. And we have just finished our time. So, thank you all for a lively interaction. Thank you, Dr. Paramitanath, for such a
Thank
good
you so much, sir.
presentation. We would move on to the next topic.
Thank you, sir. Thank you, ma'am. Up next, I would like to call Dr. Nandini Sinha Roy, Consultant, West Bengal Health Services, for our panel discussion. Our panelists would be Dr. Shudipto Roy, Dr. Dona Banerjee, Dr. Shumantro Sarkar, and Dr. Ravali Pratima. Our moderator would be Dr. Shuma Balan.
Hello? Hello? Good morning, everybody. Thank you, West Bengal Pediatric Rheumatology Society, for inviting us here. How do we sing the?
Good morning. Now, we have with us Dr. Shuma Balan, the professor, head of the department, Pediatric Rheumatology, Amrita Institute of Health Sciences, Kochi. She is a renowned pediatric rheumatologist and she has traveled all the way to join us today. And it's an honor and privilege for us. So we'll be having a wonderful panel discussion. And I'd like to request ma'am to introduce the panelists.
Thank you, ma'am. It's actually my honor and privilege to be here. I would introduce Dr. Sumanta Sarkar. He's a professor and HOD, Department of Pediatrics at Diamond Harbour Government Medical College and Hospital. Dr. Donna Banerjee. She is an assistant professor, DHGMCH in, again, Diamond Harbour Medical College and Hospital. Dr. Shudipta Roy is a senior pathologist from Kolkata. And Dr. Avali Pratima Gaud is just completed her pediatric rheumatology fellowship from the Institute of Child Health, Kolkata. So without much ado, let's get on. I've decided to keep it. Okay. So why do we do lab tests? In rheumatology is the last clinical bastion of medicine, if we want to put it that way. And history and examination really gives us a lot of idea what we are dealing with. And then we do targeted lab tests to support our clinical diagnosis, to monitor the ongoing disease activity, assess the efficacy of therapy, and monitor the side effects of therapy. Okay. So we would like a test which has only positive in disease, at least 90% specificity sensitivity, and preferably cheap and easy to do. But then we wouldn't exist if these tests existed. Patients can treat themselves, right? So we'll start with some cases and okay. So right to left. Okay. No. Okay. Okay. Yeah. So 3-year-old boy with an acute onset pain and right limp. There's no systemic features. He's not toxic. No history of trauma. He had a viral infection a week ago, and he has a limp with tenderness in his right hip. So what tests would you want for him? I'll ask Dr. Shumanta.
Yeah, thank you. Thank you all. Since a 3-year-old boy having acute onset pain and rapid limp, so viral URTI was 1 week back, so tenderness was there. Probably it could be, we should send some CBC. Only CBC will give us the idea because we can suspect a transient synovitis of the hip joint. And here we will get
seems to be blocked here. Yes, I completely agree. And the slide is not...
we'll send the initial investigations in the form of just routine investigation. That will give us the idea. And what we'll get, the point is that in this particular case, there will be no increase in neutrophils and others will be normal. Only the viral infection preceding that. So that could be a transient synovitis of the hip joint.
Perfect. And would you at all want in this acute presentation to do any immunological tests? Just yes or no?
I am so
no. Thank you.
Absolutely
no. We do get patients coming with that. That's why. So here's a 3-year-old girl and high fever for 4 days, toxic looking, with a limp right lower limb. So the big difference between that girl and the previous girl is she's toxic looking, limp, pseudoparalytic posture, tender right hip, and dislikes any kind of handling. So again, Dr. Shumanta, how would you think this child, the same, since you requested these tests, I've done the same tests for you, and what's the difference between that child and this child?
In this child, we have the high fever is there. One thing is high fever and there is a pseudo-paralytic posture. So there is a movement abnormalities also. And tender right hip joint. So probability of a septic arthritis should be kept in mind, and you should send the initial investigation in the form of the total count and the neutrophil. And you see the total count is high, neutrophil also in the higher side, and here the CRP is also high and ESR is also high. So it could be due to the septic arthritis, possibility of septic arthritis.
Absolutely, and this is an emergency that we can't miss. So you can see
And we
the
should
difference.
send blood culture also in this case.
And this is why we say history and examination, history and examination. And here is a 3-year-old boy. Now, he has a limp for 3 weeks. He's progressively refusing to weight bear, very irritable child, low-grade fever, poor sleep, mild ankle swelling, refuses handling of his right ankle. This boy actually was sent to me because he was ANA positive. It was done outside, he was ANA positive. Now, Dr. Donna, would you tell me what tests would you request for this child?
Ma'am, thank you, ma'am. First of all, from the history, what we are getting is this child is having a symptom which is progressively increasing. The child is not well. The child is irritable. Child is having disturbed sleep. The swelling, the examination shows the ankle is swollen, which is mild, but yes, the child refuses to handle the ankle. Going by the clinical picture and examination, the child is much more symptomatic as compared to that of the joint findings.
Okay.
Again, at the background of a low-grade fever, I would like to rule out some arthritis mimicas are there or not before jumping into anything, though he is NA positive, so I'd request for a routine blood, complete blood count with peripheral smear and the ESR and CRP.
What do you think this is telling? We have to go a little fast so that we can finish everything. So what is this showing you?
The platelets are coming down. ESR and CRP is not that raised. Total count is not raised at all, and lymphocytic predominance is there.
With a neutropenia. So that,
yes.
with all these, the red flag signs you see, poor
Yes,
sleep, irritable child, progressively refusing to weight bear.
So I'd request I'd go deeper I'd request a bone marrow for this child because I want to look, though
Stuck again.
I don't know the peripheral smear yet.
Ma'am, do you have a chest X-ray on this to see the mediastinal lymphadenopathy?
Wait. We don't have a chest X-ray. I'm just trying to. So here the peripheral smear was normal.
Okay, ma'am.
Would that dissuade you from doing a bone marrow?
No, sometimes in about 30 to 40% cases, the smear may be normal at the beginning. Platelet count is coming down, ma'am. And
Okay. So, no. Sorry, there was the thing got stuck a bit. So we'll just go fast here. So the fact that the peripheral smear is negative should not put you off this diagnosis. The history here, this is not arthritis. There was no indication for an ANA here. The counts are dropping. There is a relative lymphocytosis, and an LDH is a useful test. It shows increased bone marrow turnover amongst other things. And you have to go for a bone marrow, which proved the diagnosis here as acute leukemia. And
yes, ma'am.
Absolutely, yes.
And ma'am,
yes.
I'd also like to look for whether it is actually the joints or the bone pains are there for which the child is irritable. The child is much more irritable as compared to the findings.
Absolutely.
In this sort of a child, when you have a leukemia, you usually have a T cell with a mediastinal lymphadenopathy.
No, sir.
A chest X-ray was done or not?
No, sir. They don't actually. We get a lot of these patients coming through.
On bone
and they may not, that might devolve later if we leave them be, but not now at this stage. So here, we'll go very fast now. This is a 7-year-old boy who had a tonsillitis. 10 days later, he had a low-grade additive fever with joint pain and swelling. He had early morning stiffness, and you can see small and large joints were involved. What is a possibility here? Is this JIA, Ravali?
No, ma'am. Since the duration is just 10 days, I would like to do a routine CBC, CRP and ESR, and would like to think of post-streptococcal reactive arthritis. And we could do an ASO titer, but that has a limited value in our country.
So ASO 1600 in this background?
So I would still like to think about post-streptococcal
Absolutely,
reactive
yes.
arthritis.
So this is the indication to do an ASO titer. If this story was going on for 3 months, would there be value in doing an ASO titer?
No, ma'am,
No.
that comes under a chronic arthritis.
Absolutely. So ASO titer on its own doesn't give you any diagnosis, but in the right clinical context, it's a very helpful test to do.
Ma'am, there are 2 points. One is additive, one is a small joint involvement. These two are going against the acute rheumatic fever. These two are indicating of post-streptococcal rheumatic arthritis.
And the child doesn't have a fever at this time.
Yeah,
so
that's true.
Yes. So again, this is a very common scenario in a pediatric rheumatology OPD. 6-year-old boy, sore throat and fever 2 years ago. It was quite a nasty sore throat and fever. He had an ASO at that time, which was 2000, but he was given benzathine penicillin, which was stopped at request and moved on to pentids. And this child is continuing to be on pentids, and the parents check ASO every 3 to 6 months. It is always above 400. They're very worried. They want some treatment that will reduce the ASO titer. He examines completely normally. Dr. Ravali, again.
So there is no role of repeating ASO that serially, ma'am.
So what did this child have?
This child probably has a chronic arthritis rather
No,
than
he has no arthritis. He has no arthritis. He only has a raised ASO titer. Following
It's a normal child, ma'am.
He's a normal
There
child
is no need to.
who had a streptococcal infection 2 years ago. That's it. And it can take a long time for the ASO titers to come down, and it's not necessary to follow them to completion.
Ma'am, this is a very common practice. Whenever the child presents to a doctor, they advise ASO titer. On the basis of ASO titer, some rheumatic fever has been diagnosed. So this is quite a common scenario. But ma'am, one point is you have mentioned occasional non-specific arthralgia reported. Whether this arthralgia, since this country is a high-risk country for rheumatic fever, whether we should give any importance to arthralgia, we should investigate, or because polyarthralgia is a major criteria in case of high-risk countries according to the recent Jones update 2015.
I know that.
So I should be skeptical in this particular. I should take the history much more. Whether this arthralgia really is a problem to a child. Even if monoarthralgia, it could be a minor risk factor, minor criteria in recent Jones criteria. So that should be kept in mind. So one ESR and CRP I should advise in this particular.
Okay. But this is just a normal child. Many children have aches and pains.
But whether any other thing is there, because it's a high-risk country and many a time we miss those rheumatic fevers.
Unfortunately, there was no pediatric rheumatologist in that entire panel which created the modified Jones criteria, which might have changed the way that criteria has been structured.
That's true.
Okay. So we'll move on to the next. An elevated ASO titer on its own needs no treatment. Okay. Now we come, 3-year-old girl with 4 months of progressing limp, pronounced on waking from sleep, refusing to walk on waking, but she has no fever. She's well otherwise. She's better by mid-morning. She has a progressive swelling of the right knee. It's actually the left knee. And these are her routines, a word that examiners hate in exams. And Dr. Dona.
Yes, ma'am. From the history and examination, this is oligoarticular JIA, though we are getting only, there is changes in the left knee, fixed flexion deformity of the left knee joint. So
what immunological test would you want to do here?
Ma'am, as it is oligoarticular JIA, I would like to go for ANA testing by immunofluorescence.
Why do you want to do an ANA in this patient?
Ma'am, it is for prognostication. If
Yes.
ANA is positive, then we might, we have to think like whether we are going to have eye involvement or not in this child.
So every child with oligoarticular JIA needs routine screening for uveitis.
Yes,
the
ma'am.
child who's ANA positive has a higher risk of developing uveitis, so more frequent routine screening. And that's the only value it has. It does not diagnose oligoarticular JIA. In this age, Ravali, would you do rheumatoid factor anti-CCP, HLA-B27 with this presentation?
No, ma'am.
No. Yes. That is basically the point I wanted to make. So we're going to move on this way. So the routines help us, Ravali. Very quickly, tell us, what do you look at when you see a CBC? What do you look at when you see an ESR and CRP? And what are the other tests that give you some importance?
By looking at the CBC, the hemoglobin is usually low, anemia of chronic disease in case of a JIA. In case of a systemic JIA, we would be expecting a neutrophilic leukocytosis, thrombocytosis, high CRP, high ESR, while other types of JIA, these are usually normal. In case of a malignancy, you can expect a lymphocytic predominant leukocytosis.
When you have a patient who comes to you with anemia, leukopenia, and low platelets, what are the differentials in your mind as a pediatric rheumatologist?
I would like to think of SLE, ma'am, as my first DD, and then a macrophage activation syndrome if a child is sick looking, or a bone marrow infiltration.
Yes, malignancy, yes. Do you expect ESR and CRP to be elevated in all the arthritis patients you see?
No, ma'am.
No.
No,
Okay.
it will be elevated in a systemic JIA, while others it might be normal.
Okay. And Dr. Shumanta, SGOT, SGPT, common tests we do. We always call them liver enzymes. Are they always liver enzymes?
Actually, this is a routine enzyme test you should go for, but in cases of where there is a systemic involvement, multi-system disease, particularly in systemic onset GIA, and also in the JDM, also in the dermatomyositis, polymyositis group, we should send this.
Yeah.
Yeah.
So they can come from the liver, they can come from the bone.
Yeah.
They can come from the muscle, not the bone.
Muscles.
What about the LDH?
LDH is a very important investigation parameter, and it indicates the involvement. In case of dermatomyositis, if the myositis component is there, we'll get this. It also indicates the hemolysis, and there's an increased bone marrow turnover, then we can get the LDH level is high.
Yes, so hemolysis causes an increased marrow response. Again, malignancy causes
But it
increased
is
marrow
non-specific,
response.
rather
Yes.
non-specific.
But depending on the context, it's relevant. And the serum ferritin?
Serum ferritin usually is very high in cases of the, particularly in JIAs, where there is a, considering the mass, acute onset, because the acute inflammation markers, ferritin is the acute marker. So in most of the cases of systemic JIA, we may get very high ferritin, maybe in 10,000s.
Yes.
So that is the point.
So in systemic JIA, you get a high ferritin, which is helpful for you towards considering the possibility of that diagnosis. When they develop very high ferritin, you have to consider the possibility of going into mass. And this is roughly the picture of the acute phase reactants. You can see how the ESR is actually slow to rise and slow to fall. So chasing the ESR on a weekly basis makes very little sense. The CRP is fast to rise and fast to fall. Then transferrin and albumin are the negative acute phase reactants. Now, we just very quickly, I'm going to show pictures to each of my panelists, and they're going to tell me which serological tests they will order. These are all children with JIA. So this picture, very quickly, Dr. Dona, tell me, what does it tell you, and what serological test would you want to do?
This child is showing changes in the proximal interphalangeal joints, and in the first picture, the child is showing, most probably the child is having neck stiffness, maybe there is involvement of the cervical spine. So polyarticular involvement, age of the child is 4 years, so no point doing rheumatoid factor in this child.
Yes. So this is a young polyarticular JIA. She has wrist involvement, broad wrist with swelling, with multiple small joint deformities and cervical spine restriction. This is a polyarticular JIA in a young child. ANA is still the important test. They also can have uveitis. Rheumatoid factor and anti-CCP and HLA-B27 are not relevant for this presentation. Now, this is a 10-year-old girl I'm going to show you with, again, similar findings. What test would be useful here?
Yes, ma'am. Here, the changes are in both the wrist joints and in both the proximal interphalangeal joints, we can see the swan neck deformity also. And so here I'd like to go for rheumatoid factor assay in this child, because if it is positive, it indicates more aggressive disease.
And also anti-CCP could be one investigation we can send here.
Yes, so what is the question with, so 5% of children with JIA are rheumatoid factor positive. They are usually over 8 years old, symmetric polyarthritis, and females more than males. Okay, so about the anti-CCP, unlike in the adult patients where you have that window of early onset rheumatoid arthritis, in pediatrics, most of the patients who are anti-CCP positive are also RF positive. So the indications to do anti-CCP is very low in pediatric patients. Very quickly, you don't have to describe the findings. I mean, there's dactylitis.
One point I want to mention regarding anti-CCP, even in the JIA, when there is a polyarticular involvement, anti-CCP usually correlates with the radiological changes. That means prognostically it can show us whether this case is going to be having a worse prognosis.
More of
so only in the polyarticular JIA, that polyarticular JIA which can go into a adult RA later on, so that only subsets can show the anti-CCP positive.
To be honest, in children,
we don't usually send anti-CCP.
In children, they are often rheumatoid factor positive, which can give you the same information.
Yeah.
And anti-CCP costs 8 times
Very high,
that of a rheumatoid factor. So here is a child, she has small joint involvement, DIP joint involvement, dactylitis of a finger, and a skin lesion on her thumb. So what kind of arthritis is this, very quickly, Ravali? And would you do...
Psoriatic arthritis, ma'am.
Yeah, so would you find any of the serological tests useful here?
No, ma'am.
Well, it could be, depending on the kind of, like when you have asymmetric, sometimes rheumatoid factor and things can help. If the patient presents with enthesitis, then doing a HLA-B27 can be useful. But it's important to recognize that this is psoriatic arthritis and treat on those lines.
More of a clinical diagnosis.
Yes. And this boy is a 14-year-old boy with bilateral heel pain. And which test is relevant here?
HLA-B27. Because
So
I would like to think of an ERA in this child.
It's an ERA presentation, so you wouldn't waste their money doing RF and anti-CCP in these patients, right? So, and this child, I think Dr. Paramita has given us an exhaustive account. So, Dr. Donna, the diagnosis is clear here.
Yes.
We have an evanescent rash, we have high-grade fever, quotidian type with significant inflammation. You can see the fever chart. And would you want to do most of the autoimmune serology on this child?
No point, ma'am, doing the autoantibodies here. It's a disease of innate immunity, so no point going for the antibodies. And from the pattern recognition, it is systemic onset GIA.
Yes.
Dr. Balan, can I have when you ask for a HLA-B27, what is your practice doing for a flow cytometry or a PCR?
A PCR is what is recommended previously. Would you consider, Ravali, a bone marrow for every child before you would start on steroids?
If the clinical picture and the history is straightforward, I would not do it for every case, ma'am. If it is a dicey history with a nocturnal pain or any bone pain, non-specific fever with no quotidian pattern, I would like to consider a bone marrow.
Absolutely. So it's not a must that you have to do steroids before you do a bone marrow. Another thing you can remember is a mimic actually is lymphoma. You may not get anything from a bone marrow in a lymphoma patient. And it's basically looking at the disease pattern, looking at the ferritin, looking at so many things before you make a diagnosis of systemic JIA. It's a diagnosis of exclusion. You do have to think of ruling out many things, at least in your mind, before you would start these patients with arthritis. How frequently would you find arthritis at presentation in a child with systemic JIA?
15 to 20% might not have arthritis, ma'am. They can just have arthralgia. In fact, the new criteria even says that arthritis is not necessary to diagnose an
Absolutely.
SJIA.
Up to 40% actually may not have any arthritis in systemic JIA. Okay. Now, this child is a spotter. So, Dr. Shumanta.
It's a 9-year-old girl, pyrexia, 2 weeks onset, rashes, and also there is a ulcer, I think it's a painless ulcer in the palate. So it could be SLE, suspected SLE.
I've put the routines for you.
Routines showing
it
the
support?
hemoglobin is low, platelet count is a bit lower, ESR is high, and CRP is also 10 is not high. It usually indicates infection in case of SLE, otherwise usually gets low. And I think we should investigate for other, like I should send ANA in this patient.
Okay. So only ANA, or would you want
Also, can say complement C3, C4.
because they
and,
show
and
disease
APS also we should send.
Absolutely. APS workup. We'll come to that in a minute. And Dr. Sudipto has some slides to share. I'll share the slides. You can talk to us about the ANA test and how do you want to do it?
You have the slides or no?
Yes.
So this is what I want to stress on before you send on an ANA, your pre-test probability based on a clinical examination and your routine should be very high. A reflex testing does not really carry meaning for the patient management. This is what is the present status of the HEP2 cell patterns. What I want to highlight is that ANA in a HEP2 or a HEP20 cell line, the difference of HEP2 and 2010 is when we had HEP2 in the 1980s, you had still a seronegative lupus, and when we found that these were all SSA and SSB, the new cell line has come in, which is a transfected cell line with SSA, SSB. Now, therefore, you do not have anything called a seronegative. A positive ANA is a must for a diagnosis of a systemic rheumatic disease or an SLE. Now, internationally, about the 100 antigens, 31 has been recognized. Can we go to the previous slide itself? I'll just tell you. And see, you see, it's you have to have a nuclear or a cytoplasmic or a mitotic or an unclassified. But the importance is that it is just not nuclear. So the nomenclature is no more ANA, it's an ACA, anti-cell antibody. You're going to have cytoplasmic antibody, then various patterns has been described. And another important thing, because what Madam said in the first slide, any screening test should have more than 90% specificity and sensitivity. If you increase your dilution in more than 160, it becomes more specific on a platform which has got a screening thing. So with this present day practice, the carry-home message is dilution 1 in 160, HEP2 cell line is 2010 cell line, and the various patterns, and I want that we have to go to the practice of giving the patterns. What I've seen from the morning is ANA positive. I think we have to be more specific. What is the pattern positive? It does correlate to disease pattern because ANA does not mean reflex SLE, it means systemic rheumatic disease, and the pattern would help to the clinical thing. So next, see, this is the criteria, and ANA, C3, C4 has already been mentioned. This is important, and this is the first point of discussion on the ACR and the SLE criteria. Next slide, ma'am. These are just homogeneous pattern. What I want to stress is, you see the homogeneous pattern, you have to think about the antigens possible. Next. If you have a speckled pattern, you see the nucleoli is negative, those holes. So that's very important. Then homogeneous and nucleolus is positive. Next. Then you have the central, that corner there, anti-centroid, you don't have to do anything special. That is a diagnosis. See the multiplying cells, and because HEP2 is a carcinoma cell, human laryngeal carcinoma cell. So you have interface mitotic cells, and if you have mitotic cells with that number of dots, it is definitely a centromere, and the disease is Crest syndrome. Relatively others are there, so you have a nucleolar pattern also. See, this one over here is very specific. You have a nucleus positive and the nucleolar dots, which is very classical of scleroderma anti-SCL70. So what I try to say is, next slide, that from the patterns, you can come to a specific subtypes. And the cytoskeleton, you know, the actin is very specific for type 1 autoimmune hepatitis, but others are not very specific for disease. Next. The ribosomal protein and mitochondria, ribosomal P protein is very specific for lupus with psychosis, CNS involvement, and mitochondria pattern is very classical. You can see the nucleus is negative. This is for your primary biliary cirrhosis. Next. And similarly, the other pattern, we'll focus on this. These are the histidyl transferase group, which is JO1 and all this. And here, this correlates with your polymyositis and dermatomyositis group. Therefore, a pattern does have a correlation with the clinical spectrum, and so discussion is very important. This is one thing I want to stress on my cartoon is, see, a cell does either replication or a translation to make protein functionally. If you have a double-stranded DNA antibodies to that, you get a homogeneous pattern, and your disease is SLE. Now your double-stranded DNA twines around a protein called the histone protein, And 146 units of your DNA makes 1 unit of that thing. That's called the nucleosome or the chromatin. So you have an antibody against histone or that chromatin or the nucleosome, your disease is SLE. But on the other hand, if the cell goes on replication and you have that kinetochore proteins, then it's a CREST syndrome. And if it is DNA topoisomerase, as I showed you, in a multiplying cell, because the nucleolus is where you have a housekeeping genes, which helps the cell to multiply. If you have a complex of nucleolar with the nucleosome, your diagnosis is scleroderma. But if you have, when that protein is being translated, you have the nucleosome. Here you have the spliceosome, the enzymes which cuts the introns and adds the exons to form the protein from mRNA, and it goes on. This area of nucleoplasm is your two groups of protein. One is the URNP and SM, and S-Smith is a diagnosis of SLE. URNP is a diagnosis of Gordon-Sharp syndrome with pulmonary hypertension. So this is an area where you have RNPs, ribonucleoproteins, which are uridine rich. And the other spectrum is your Rho-La and your Rho52. So if you have this in an SLE, you can have a mixed connective tissue disorder, U1 RNP. Then you have a Sjogren's syndrome or a neonatal lupus with congenital heart block. If you go to the cytoplasm, the nuclear membrane has got a lot of other diseases, including liver diseases. But if you go to the cytoplasm, you can have, again, the ribosome. You know, once the mRNA comes in and it splits between the ribosome, the 60S and 80S, and the histidyl transferase protein, enzymes, transfers these codons to amino acid. You have an antibody against that, your disease is polymyositis, and you have a cytoplasmic granular pattern. Mitochondria have shown you. Similarly, you have diseases which are different at a different level. So the dermatomyositis, polymyositis group would be this. Nowadays, this is a very fashionable thing, but it's very expensive. What is now said is, recommended protocol for ANA testing is 1 in 160, IgG is your substrate, do a Hep2 2010 cell line. I always use a liver to have a negative thing because these are interface cells. After you have diagnosed a screening thing on a positive background, if you want to do for monospecific, you have either ELISA or you have the immunoblot or you have the clear. That is the present day.
Thank you very much. It's a very, very comprehensive overview of the ANA test.
No, ANA can be negative, but the clinical utility of the disease has to be there. You know, you just can't do a reflex fever and then do an ANA, you forget about things. That is not the test. You have to have a strong pre-test probability, then the significance is very much there.
Absolutely. So ANA has a high sensitivity, but not a great specificity. And complements are now included in the diagnostic criteria of lupus. We'll have to run fast now. Now, one question to Dr. Ravali. When we do antiphospholipid syndrome, I just want you to enumerate which are the tests we send. Because I'm aware that in the market, there is a blanket test which says antiphospholipid syndrome, IgG, IgM. Would you prefer that, or would you prefer to do individual antibodies?
We prefer an individual antibody test, ma'am. It is usually IgG or IgM and IgM against anti-beta 2 GP1, anti-cardiolipin, and lupus anticoagulant.
Yes. And the importance is that these are associated with increased thrombosis.
Ma'am, can I sort of point out? See, for a poor man's thing, a screening for APTT, if it is very prolonged, because then the intrinsic pathway, see, if it is APTT is prolonged, you have to have two things. One is deficiency, or you have an antibody. Because all the coagulation takes place on the surface of the platelet, which is phospholipid. So if you do a mixing with a normal plasma and incubate for half an hour, then do a APTT, if it is normalized, then it was deficiency. If it is still prolonged, then it's antibody. So based on the clinical thing, without doing much of the other things, that is a good way of a mixing experiment to diagnose a case of antiphospholipid antibodies.
So we have to go very quickly now. So I think there are no prizes for anybody in this audience who diagnoses dermatomyositis here. So the question really is, Dr. Dona, what is the next test you want to do for these children?
Yes, ma'am. Along with the routines, I would like to go for serum ferritin, liver, AST, ALT, LDH, and CPK, and also myositis-specific antibodies, and ANA by immunofluorescence. And also, there is a role of imaging in this child. We will go for MRI, that will suffice. to pick up, and if we are, muscle biopsy has also got a role, but we have to decide.
Okay. So, two questions, Dr. Rawali. Why did I put serum ferritin here? Was a child with clubbing. So what antibody would you expect here?
I would expect an anti-MDI5 antibody, ma'am. So
Yes.
the serum ferritin is usually associated
It's prognostic.
with...
Yes, it's suggestive of a rapidly
Rapidly
progressive
progressive
ILD. Yes. And when you do the muscle enzymes, which ones do you do?
We
Do you do
usually-
only a CPK or?
CPK, LDH and AST. Aldolase is usually not really...
Aldolase is the most specific muscle enzyme, but difficult to get the result back, bit more expensive. AST, ALT, LDH, CPK, and are all patients CPK? Will CPK indicate myositis in every patient with dermatomyositis?
No, ma'am. CPK can be normal in few cases, 10 to 15%, where there is muscle atrophy, and if it's a burnt out disease.
Not
you
only
can-
that, in about 40% of patients, it could be one of the other muscle enzymes that is elevated. So you do all of them at baseline to know which one you can use to follow up. Okay. Dr. Shumantra, myositis antibody profile, how has it helped us?
It's a wonderful investigation, and definitely it helps us. And problem is that in many centers it is not available but when it is available, it definitely it's an additive investigation to help us.
And it helps us to identify the phenotype that the child
exact
has.
phenotype of
and
the particular
and to
myositis.
know how to predict what could be the parts that we look for in these patients more specifically. Doctor, I think these are the muscle antibodies we will carry
Already
on
showed,
because we are short for thing. But this is the myositis antibody profile, and it comes up with a list of antibodies, and they help us to understand what subtype of myositis the child has, which will be important in the way we target treatment to these patients. Okay, muscle biopsy. These days, would you want to do muscle biopsy for every patient with JDM?
No, ma'am.
No. So
Unless-
atypical cases where there are no skin changes, or when there is only skin with muscle involvement, and these are all the situations where biopsies can help you. We do not do a muscle biopsy for every patient. So very quickly, in this presentation, the child with oral ulcer, genital ulcer, and an ulcer on the foot, would you want to be doing ANA? Would you want to be doing MSA? Would you want to be doing an ANCA, or would you want to be doing some other test here? What is the diagnosis here?
I would like to think of Behçet syndrome in this, ma'am. So it's a clinical diagnosis. I don't want to do any specific test.
Okay. So basically, the only one test that helps with Behçet is actually the HLA-B tissue typing, looking for a B51, but that's not there in any of the classification criteria. It's very much a clinical diagnosis, and we have classification criteria to help us make the diagnosis.
Do you do a biopsy for Behçet's?
Yes, biopsy is definitely important to show you the vasculitis in an accessible area. Pathogy is often negative in our kind of populations. In populations where Behçet is endemic, they get very high pathogy positivity. So we'll go, this is going to be the last case. I hope we can have 2 minutes extra. Now, this is a 9-year-old boy who looked like HSP, okay? But he was developing evidence of nephritis, headache, and ulceration of lesions. And you can see his counts are low. He's got leukocytosis, anemia, thrombocytosis with a high serum creatinine and very high inflammatory markers. So, Dr. Dona, is this HSP? Would you be happy to treat this child as HSP, or would you want to do more testing?
Most likely it's not looking like HSP, and maybe the child is presenting with some vasculitis. So this kind of presentation with ongoing crops of rashes, some ulcerations, some lesions, maybe there is some ANCA-associated vasculitis is there.
Yes, ulceration is unusual in HSP. I use the word unusual because nothing is impossible in clinical medicine, but a presence of ulceration should make you think about this being something else. Such high inflammatory markers are also unusual in HSP. So, as she said, we'll want to go for ANCA-associated vasculitis. And I think, Dr. Sudipto, could you just give us a quick overview of the ANCA tests?
Can we go to the previous slide if you would like to see the classification for them? The previous one. No, the Chapel Hill classification, just to put in the perspective. Go back, ma'am. Go back.
Oh, okay. I'm going forward. I'm going the wrong way. Okay.
Yeah, this is the vasculitis classification as per Chapel Hill. As far as we know that it is based on the diameter of the vessel. So you have the medium vessel vasculitis where you have Kawasaki and poly. Now we using this part, which is a small vessel vasculitis. It could be an immune complex where Henoch-Scholl and IgA group are there. But the ANCA associated this as MPA, GPA and ESGPA. So this is where we are dealing now. The question is, next slide, ma'am. What is the anti-neutrophilic? The basic thing is these are granules in the cytoplasm of the neutrophils, and you have these primary granules. To date, clinically, you have these antibodies to myeloperoxidase and proteinase 3. Suffice it to say the others, lactoferrin, lysozyme and others are also available for the clinical practice, provided again you have a pretest probability. So how do we diagnose in the lab? Next slide, ma'am. So basically in an this is a pattern of overview. What I want to stress in this slide is ANCA does not mean only vasculitis. The vasculitis are GPA, MPA, EGPA and the post-immune necrotizing glomerulonephritis, the crescentic glomerulonephritis. But you have a host of other diseases. We have the inflammatory disease, autoimmune liver disease, drug-induced and so on and so forth. So pattern-wise, immunofluorescence-wise, you have a P, you can see is a perinuclear staining. You have a C, which means a cytoplasmic staining. So that's on the morphology. And as you know that we have a host of disease, there can be an atypical, which is neither P or neither nor a C. So that's the background. Next. So you can have, once I said about lupus, in lupus you can have vasculopathy where you stress for Apla syndrome. You have a vasculitis where you go for a small vessel, it's ANCA. That's how you diagnose or come to a clinical thing. These are, you can see that photograph, it's a cytoplasmic granules with an accentuation in the segment, and the protein here is proteinase 3, but that doesn't mean that other diseases, vaginous is the commonest in 90% of the cases, but microscopic polyangiitis can also have in a small percentage. The criteria for classification for granulomatosis is very high given to your proteinase 3 or the cytoplasmic thing for the international thing. So that's very important from an immunofluorescence and immunoassay. P-ANCA, you have a perinuclear, but there is a whole group of diseases where you have a pre-ANCA. Like C-ANCA is very specific to a disease, more or less, but P is not. You have a whole lot of other diseases. And these are the other enzymes which can have a positive problem. And so lactoferrin is for chronic inflammatory bowel disease. So what is the practice now is, in autoimmune disease, like I said for ANA, you go for a screening by your granulocyte mosaic where you have a granulocyte substrate and a positive control or a negative control with HEP2. You have to exclude lupus being a very common thing. Then you can go to a monospecific by immunoblot, or you can do an ELISA, CLIA, and a FEIA. So that is the problem, and we can go to the next slide. The next slide is, this is what has been said. Now, what do you request for? See, one of the 2017, that paper on the consensus statement made a confusion, which said do only immunoassay ELISA. If it is positive, forget about it. If it is negative, repeat it. The problem is immunofluorescence, but this is a group of pathology in the international thing. They refuted that paper and said that you have to do both because ANCA does not mean vasculitis alone. You can have other diseases. So what I have been practicing in this city is I do indirect immunofluorescence with an immunoassay and then give them a report, talk with a clinician for the correlation.
So these are the clinical indications for an ANCA testing. You don't need to send an ANCA in every patient with IgA vasculitis, for instance, but when you have a patient who comes with a pulmonary renal syndrome, rapidly progressive glomerulonephritis, cutaneous vasculitis with systemic features, lung nodules, long-standing sinusitis, otitis, and upper airway disease, subglottic tracheal stenosis, or any mononeuritis multiplex, you have to consider the possibility of ANCA and do the testing as recommended. These days, it is true that we send for the ELISAs first, when we are clinically sure that's what we are dealing with. But Dr. Shudipto's point has to be borne in mind. With that, we'll stop. Thank you very much to my panelists. Just to reiterate the fact that serological tests for rheumatological disease are supportive rather than diagnostic. The history, objective clinical examination, and the blood routines are the most important part of the diagnostic exercise, pattern recognition for multisystem disease, and after that we decide which autoantibody, whether biopsy, whether imaging, what is going to help us. And we'll stop here. Thank you.
Thank you so much.
How many cases of rheumatic fever see in last 5 years in your hospital?
Very, very few, sir. Acute rheumatic fever. Real pakka acute rheumatic fever, I think we've seen 2 patients.
Yes, sir. You say how many cases in your hospital? Madam, how many cases in your hospital? Because I have to take class rheumatic fever in the next weeks.
No, actually, we are getting patients of rheumatic fever recently. We are getting patients of scarlet fever also.
Yes.
We are getting patients of rheumatic fever also. So if we are very much vigilant, we can pick it up. It is not that rheumatic fever is past. It is present still.
Yes, madam. No, I have seen in last 7 years only two cases. Both are female and adolescents.
No, I'm sure it's still around. Everything is still around. It's just do not dismiss off easily as rheumatic fever when it could be some other pathology.
Ma'am, can I tell that in ASO investigation, in the lab, it is almost dwindling. It is not being asked at all.
Thank you for the highlighting this point, sir. And basically, you have touched a very important point. Rheumatic fever we don't see. And I don't agree with you, sir, because rheumatic fever is, we see only one patient a year, and which is also very difficult to make a diagnosis. So I don't agree with that we are seeing a rheumatic fever. Whatever we are seeing is rheumatic heart disease or maybe a streptococcal scarlet fever. Rheumatic heart, we are mixing the things actually. That is, whenever we are talking the prevalence or incidence of rheumatic fever is that we talk about rheumatic heart disease and rheumatic fever. The established rheumatic heart disease is a different thing. But we don't see rheumatic fever nowadays mostly. And in PGI, where we are working, and we have shown that, we have published also recently that incidence of rheumatic fever disease is coming down like anything. And this is wherever we are seeing this remains same only. Because the problem is that the Jones criteria you were talking about, the Jones criteria is such a like non-specific thing. If you will start applying the Jones criteria in Indian setup, everyone who has a fever will be a rheumatic fever. That is a problem with Jones criteria. In a setting where, so we don't have an incidence data, clear-cut incidence of data of rheumatic fever in India. And if I can quote 2 studies from the Simla, they have done. One was done in 1992, the incidence figure was something there, and the school-based study they have again repeated in 2008, 7-8, and there were no case detected, and they have done school-based children's survey. So rheumatic fever is going into the death nails, and that we have to like now we should be focusing on the more common cause of acquired heart disease in children, and that is Kawasaki disease.
Of the housing condition in our country.
I just have to substantiate what you said is, in our
you
college
so
days,
much.
we had a post-streptococcal glomerulonephritis. Now it's called post-infectious. We have given up with these streptococcal, it's not been seen. So staphylococcal and others are more important nowadays than rheumatic.
Thank you, sir. Thank you, ma'am. Thank you, my esteemed panelists, for a wonderful and interactive session, taking up very interesting cases and giving valuable insights into the common lab tests done in pediatric rheumatology. Thank you.
Thank you so much, everyone. This has been a truly enriching experience. Gentle reminder, all those who have e-poster presentation, please upload your posters in the adjoining room. We have received over 50 abstracts which were blinded and sent to 3 judges, Dr. Avinash Sharma, Dr. Murugam Sudhakar, and Dr. Satish Langanathan. Up next, we have our paper presentation, and I would like to call on stage Dr. Geetabali Sarkar, Professor Clinical Immunology and Rheumatology, PGSSKM, and Dr. Suma ma'am.
Good morning. Yes, Suma ma'am. Good morning, everyone. Now we are moving on to very interesting section of the conference. So that is a competitive case presentation among the postgraduate students. So first of all, I would like to thank the West Bengal Pediatric Association for asking me to take part in this beautiful session. So, with me, Suma ma'am is with me. So now we will start the session. So first, I would like to invite Dr. Ritodev Nandi. He is going to present on immunologic disease involving 2 ANCA-associated vasculitis, a case series.
Immunologic diseases may evolve with time. Good morning, I am Dr. Ritodev Nandi from ICH, and I am going to present 2 interesting cases on this. My first case starts in 2020 when a 16-year-old boy presented with anasarca with multiple episodes of vomiting. He was a known case of rheumatoid factor positive polyarticular GIA, inadequately treated with methotrexate since the last 2 years. Investigations revealed hypoalbuminemia and nephrotic range proteinuria. So it was nephrotic syndrome, but what was the cause? Renal biopsy showed IgM nephropathy, and he was started on oral steroids and discharged on oral steroids, hydroxychloroquine, and methotrexate. On follow-up, the patient developed steroid-dependent nephrotic syndrome. So we planned rituximab. 2 doses were given in 2021, and the child was asymptomatic till 2024. When he now presented with multiple episodes of blood in sputum, there was severe pallor and bilateral chest infiltrates. So it was diffuse alveolar hemorrhage now. Meanwhile, P-ANCA and MPO came positive in high titers, and there was again nephrotic range proteinuria. So we repeated renal biopsy, which now showed membranous nephropathy. He was treated with methylprednisolone and rituximab, and he went into remission. Now case 2 starts in 2015 when a 3-year-old girl presented with bilateral lower limb weakness. MRI spine showed long segment myelitis. Serum NMO came positive. So the diagnosis was neuromyelitic optica spectrum disorder. She was pulsed with injection methylprednisolone, and the paraparesis improved. She was followed up, and this was the timeline of her. On 2015, she was diagnosed with NMOSD. Just 1 year later, she came with bilateral optic neuritis now. So azathioprine was added to oral steroids. Again, 6 months later, she came with transverse myelitis. So rituximab was planned now. Again in 2017, there was bilateral optic neuritis. So azathioprine was changed to MMF now. Due to the waxing and waning course, she received total 14 doses of rituximab, last in 2021. And she was asymptomatic till 2024. In June 2024, she presented with fever and respiratory distress. There was severe pallor and bilateral chest infiltrates. So it was diffuse alveolar hemorrhage. She was pulsed again with methylprednisolone. 6 months later, she presented with anasarca, hematuria, oliguria, and hypertension. Investigations revealed AKI, severe anemia, and nephrotic range proteinuria. So the diagnosis was rapidly progressive glomerulonephritis. Serum P ANCA and MPO came positive, and we did the biopsy which showed endocapillary hypercellularity with fibrocellular crescents and immune complex deposition. She was treated with methylprednisolone pulse, cyclophosphamide, rituximab, but there was poor clinical response and the creatinine was rising significantly. So we planned for a therapeutic plasma exchange, and then there was significant improvement in RFT. Now, both these cases illustrates how immunologic diseases may evolve from one form to another and how dynamic their relationship is. Case 1 shows a polyarticular GIA going to IgM nephropathy, then a DH, and then microscopic polyangiitis with membranous nephropathy. Case 2 shows NMOSD going to a DH to an RPGN with microscopic polyangiitis. The case reports about GIA and ANCA vasculitis are very scarcely reported, and NMOSD may be associated with SLE and Sjogren, but the association with ANCA vasculitis is again very scarcely reported, mostly in adults. There are very few pediatric case reports which make all the more interesting these cases. These cases were very challenging to recognize and manage because ANCA vasculitis is very uncommon in children. Thank you.
Thank you. That was very, very interesting pair of have you considered doing genetics for a COPA syndrome, especially in your case 1?
No, ma'am, we didn't do genetics.
Because that could be an explanation for that evolution. You, rheumatoid factor positive arthritis, and then you're seeing rapidly progressive nephritis with an ANCA pattern. So that is something to bear in mind. The other thing is with your case 2 as well, going back, did you ask the pathologist to look back at the previous biopsies and see whether they would think of re-looking at it from the ANCA perspective, the renal biopsies?
Ma'am, the first biopsy revealed IgM nephropathy, so it likely is rheumatoid factor, which is an IgM deposited in the kidneys, which cleared off when the JIA was in remission. And then it was a new thing, that ANCA vasculitis with membranous nephropathy. Both these cases illustrates that the primary disease was in quiescent stage when the ANCA vasculitis came, which makes these cases unique. Yeah. The JIA was not progressing all along, nor was the NMOSD.
That's a good hypothesis that you have, but I think these days with these kind of patients, we should think about doing genetics, and that might explain not just what is in the past, but also what might happen in the future for these patients.
And one thing about rheumatoid factor positivity and renal involvement, especially that to a short period, I would say, especially we see the rheumatoid arthritis basically when long-standing, which is properly not controlled the disease, then only we see renal involvement.
Ma'am, he was not controlled on methotrexate only, and then arthritis also was not controlled, so we added eflunamide for it. And then the arthritis and the renal part was controlled. And then after few days, after 6 months, he presented with nephrotic range proteinuria. So in between, he was asymptomatic, both joints and kidneys.
Okay, thank you. Thank you so much.
Thank you, ma'am.
So,
to all those who are presenting a paper in this segment, I would like to go through the rules once again. 5 minutes for presentation. First bell will be at 4 minutes, and the final bell again would be at 5 minutes. 2 minutes for question and answer. Please maintain your time. So up next, I would like to call on stage Dr. Shubham Kunti from Institute of Child Health.
Good morning, everyone. I'm Dr. Shubham Kunti. Okay. So, good morning. Today, I'm going to present my case on common bug, uncommon impact. So, we have a 5-month-old boy who is born out of non-consanguineous marriage, and he presented with fever and cough for 2 days and features of respiratory distress for 1 day. The on-admission child was tachypnic, there was tachycardia, peripheral cyanosis, and features of shock. The child was admitted directly in PICU and was started on HFNC. However, due to 2 episodes of convulsion and altered sensorium, he was intubated. The chest X-ray was suggestive of ARDS. The bronchoalveolar lavage PCR came positive for rhinoenterovirus, while bowel culture showed no growth. The count CRP was within normal limit. The CSF analysis was normal, and there was no growth on blood culture. The child required 17 days of invasive ventilation and was discharged in stable condition after 26 days of hospital stay. And he was on follow-up and was doing good, but after 8 weeks, he presented again with features of respiratory distress. He received multiple antibiotics and nebulizations in peripheral hospital, and due to further worsening of respiratory distress, was referred to our center. On admission, the child had severe respiratory distress with bilateral crepitations and was again admitted in PICU. On examination, the child had failure to thrive. There was tachypnea, intercostal and subcostal retractions, and presence of bilateral crepitations. Tonsils were not enlarged, and there was no lymphadenopathy. The child was initially managed on NIV, but later required invasive ventilation, which was later escalated to HFOV due to persistent hypercapnia. The chest X-ray was again suggestive of ARDS, and the bronchoalveolar lavage PCR again came positive for rhinoenterovirus. So what we have got an infant with recurrent severe infections. Each time we could identify rhinoenterovirus leading to ARDS. So we thought of an inborn error of immunity. So our differential diagnosis included a combined immunodeficiency, maybe a hyper-IgM syndrome, a severe combined immunodeficiency with both B cell and a T cell defect, and chronic granulomatous disease or Mendelian susceptibility to mycobacterial diseases. The investigation-wise, there was no lymphopenia throughout the admission, and the CRP didn't correlate with the severity of infections. The immunoglobulin panel showed low levels of serum IgE, IgG, and IgA, and the IgM levels were normal. The CD3 and the 19 cell cohorts was normal. The blood and the urine cultures were sterile, and the lymphocyte subset analysis was normal. HIV was negative. So a B cell defect and a combined immunodeficiency was provisionally diagnosed and was treated with high-dose IVIG for 2 days, and which was repeated after 7 days. The child was also given broad-spectrum antibiotics. He significantly improved and was discharged, and a clinical exome sequencing was done, which showed a hemizygous mutation in the CD40 ligand with X-linked recessive inheritance, making a diagnosis of type 1 hyper-IgM syndrome. The child was started on cotrimoxazole prophylaxis and monthly IVIG and was treated with allogenic hematopoietic stem cell transplant at 1 year of age. The baby is doing good and is follow-up on the transplant team. So review of literature, as we can see that ARDS can be a presenting symptom in an infant with CD40 ligand deficiency associated type 1 hyper-IgM syndrome. Now a bit about hyper-IgM syndrome. These are resultant of defective interactions between the T cells and the B cells, resulting in poor immunoglobulin productions and antibody functions. Classically of 2 types, the X-linked one and the autosomal recessive variety. In X-linked one, the IgM levels may be normal or elevated, and usually the tonsils are not enlarged. And in autosomal recessive variety, the IgM levels are usually elevated, and there is tonsillar hypertrophy along with lymphadenopathy. So my take-home message, the estimated frequency of CD40 ligand deficiency is approx 2 in 1 million males, And there are few cases of rhinoenteroviral meningoencephalitis reported worldwide. However, there is scarcity of data regarding the same causing ARDS. Cryptosporidium and CMV infections can occur at any age, and these childs are at increased risk of malignancy. So finally, any recurrent sinopulmonary infections in early infancy should always be worked up for inborn error of immunity. Thank you.
So in this case, you say like a patient was presented with the acute respiratory distress syndrome. So have you worked up any other infective causes and
Yes.
Yes, what are
We have
the
done
causes which you have searched for?
Ma'am, we have to first exclude other viral causes. So the respiratory PCR, the lower respiratory PCR biofire which was done, it showed rhinoenterovirus. We have done the blood culture as a part of the generalized sepsis, which came out to negative. And, ma'am, it was that.
Did you do your baseline immunoglobulin levels, serum immunoglobulin levels, and lymphocyte subsets here?
Ma'am, it was done after 6 months, the second presentation time, because by 6 months the maternal immunoglobulins, they persist. So we could do the test in the second episode at 8 months, which showed low levels of IgE, and IgM levels were normal.
And is that something you see with normal IgM levels in these patients?
Yes, ma'am. In the X-linked variety 1, which is associated with CD40 ligand deficiency, the IgM levels are normal, whether the autosomal recessive variety, which are due to AID or UNG deficiency, these presents with elevated levels of IgM.
Okay, good. Thank you.
Thank you.
Any questions from the floor? Well managed.
Again, I would like to remind all those who have e-poster presentation, please upload your posters in the adjoining room. Up next, I would like to call Dr. Nilabja Roy from RKM.
Good morning, everyone. I am Nilabja Roy. I'll be taking you through a gut-wrenching drama that started in our hospital, Ramakrishna Mission, which began with common symptoms and led to a critical lesson in pediatric care. It all started when an 8-year-old girl child with systemic juvenile idiopathic arthritis, arriving with 3 days of high fever, vomiting, and severe pain in the right part of the abdomen. These findings, especially the ultrasound, suggested of acute appendicitis, prompted an urgent appendicectomy. At this point, everything seemed straightforward. Fever, abdominal pain, and imaging all fitted acute appendicitis. However, after the appendicectomy, the expected recovery did not occur. The girl continued to have persistent high-grade fever, and the broad-spectrum antibiotic did nothing. The pain became diffused across her abdomen instead of staying in the right lower quadrant. In short, she was not improving, and it was clear something serious was wrong. This mismatch finding created a diagnostic. This mismatch of findings created a diagnostic dilemma. Repeat imaging, ultrasound, CT showed no abdominal showed no abdominal problem. Blood culture were negative. Meanwhile, her inflammatory markers were skyrocketing. The clinical picture was worsening despite no evidence of infection or surgical complication. We had to consider a diagnosis beyond this usual suspect. The laboratory data provided key clues. Her ferritin level was astronomical, over 24,000. Such extreme hyperferritemia is highly suggestive of macrophage activation syndrome or MAS. Life-threatening. The CRP was 209, the WBC count was around 28,700, and LDH was elevated. Now, all signs of intense inflammation. At the same time, test for EBV, hepatitis profile, influenza, dengue, and malaria were all negative. Effectively ruling out infection, in short, the labs were screaming inflammation, not infection. At this point, we made the key diagnosis of MAS. Macrophage activation syndrome is a severe potential fatal condition caused by runaway activation of macrophages and T cells. Essentially, the immune system goes into overdrive, a cytokinin storm, causing widespread organ inflammation and coagulopathy. MAS occurs in roughly 10% of Sogia cases. As you can see, now the management, we immediately instituted aggressive immunotherapy. We administered intravenous methylprednisolone pulse, cyclosporin, and tocilizumab. Provided supportive care, including inotropes for hypovolemic shock. The outcome was remarkable. However, there was resolution of fever. Fever subsided following immunosuppressive therapy. Abdominal pain improved. Marked reduction in abdominal discomfort. Inflammation marker decline, and significant drop in ferritin and CRP level. Now, what we have, the key lessons from this conclusion. The three critical points. Not all acute abdomen requires surgery. Persistent fever in Sogia requires evaluation beyond infection, and early mass recognition treatment saves lives. Timely immunomodulation and awareness are vital for patient survival, trust inflammation markers, and complex cases. Thank you. And I will also remind you, in a world of algorithm, be the glitch that sparkle changes. Thank you.
Thank you. Very interesting case. Can I ask if, was it that the child presented to the surgeons first that went for surgery straight away?
Yes, ma'am. It was presented with surgeon first. Our unit was in combination with their unit, surgeon's unit.
And what was the initial inflammatory markers and counts in that patient at that time, before surgery?
Before surgery, they didn't did ferritin level, but CRP was high. And it was according to the appendicitis where CRP can be high.
Usually in appendicitis, CRP is not that high actually, and if it's high, then there's a suspicion of perforation and other things that are there. So that is the question. How do you think this could have been, like if a second, looking back now, how do you think this could have been improved from the beginning? Like, you know, if it could have been any pointers to avoiding surgery in this child earlier on?
Yeah. Yes, ma'am. If presented with us first, we could have done a ferritin, and that could lead to a. From our side, we can then guess that if something's wrong with there, from GI inflammation cases.
So the message to the surgeons is that when the child has a chronic disease label, they should involve the treating doctors first before they do other things to these children, because their primary disease treatment as well as complications can very well impact the present condition of the patient. And that would be the change in practice that is required from this case. Very interesting case. Thank you. Any questions from the floor? Yes.
How common is acute abdomen in mass?
I have already told around 20%.
Number one. Number two is, do you use tocilizumab in every mass?
No.
If not, what do you use primarily, and why did you use tocilizumab in this case?
Due to time, shortage of time, I didn't discuss that. Our hospital is a charitable hospital, so it was constrained. There was constrained reasons for that we used tocilizumab. If it was a government hospital, we could have used anakinra.
Thank you.
Next, I would like to call Dr. Maria Anjuman from Apollo.
Good morning, everyone. I am Dr. Maria Arjumant, DNB resident, Apollo Multispeciality Hospitals, Kolkata. My topic of discussion is cytokine release syndrome in 2 pediatric cases, which was triggered by adenovirus. First case was 1-year-old male child who presented to us with high-grade fever and cough for 5 days and respiratory distress for 1 day. The child was hospitalized outside with complaint of fever for 12 days, where he was treated and the fever subsided, but the fever reappeared. On initial examination, the child was irritable, tachypneic, with increased work of breathing, bilateral V's present, not maintaining saturation in room air, and hepatosplenomegaly was present. So we started him on moist O2 inhalation, IV fluids, and IV antibiotics. But at day 2 of hospital stay, there was further increase in respiratory distress and fever spikes, and the support was escalated to humidified high flow nasal cannula. The lab parameters showed bicytopenia, marked transaminitis, increased LDH, triglycerides, and significant hyperferritinemia with low fibrinogen. Comprehensive respiratory panel detected adenovirus. The chest X-ray revealed bilateral patchy opacities, and the other causes of infections were ruled out. So the diagnosis was adenoviral LRTI with HLH. There was poor response to initial IV antibiotics, and the child required HHFNC support for 2 days, 1 dose of injection cidofovir, and injection dexamethasone was given for 7 days in view of the cytokine storm. The fever subsided in 24 hours, and the child was off respiratory support in 48 hours after initiation of CRS targeted therapy. Case 2 is very much similar in progression of the disease, but the difference is the age. The previous case was 1 year old, so we also suspected primary HLH in him, and we sent a clinicome sample for clinical exome sequencing. Here, this case is 15-year-old male child who presented to us with fever, cough, chest pain for 4 days, and loose stool pain, abdomen, and burning micturition for 3 days. On examination, he was also tachypneic, hepatosplenomegaly present, and there was tenderness in right hypochondrium. We started him also on moist O2 inhalation, IV fluids, IV antibiotics. The child showed some clinical improvement initially, but at day 5 of hospital stay, he became lethargic, respiratory distress worsened with increase in fever spikes, poor perfusion, and hypotension. So the respiratory support was escalated and inotropes was started. Meanwhile, the lab parameters showed falling trend in hemoglobin, platelet count, increased SGOT, SGPT, LDH, triglycerides, and increased ferritin level. Again, the comprehensive respiratory panel detected adenovirus. Chest X-ray showed right lower lobe consolidation. In urine, there was pus cells present, 20 to 30 pus cells per HPF, but however, the urine culture was negative and other sepsis screen were negative. So diagnosis was right-sided lobar pneumonia, adenovirus associated, and urinary tract infection with cytokine release syndrome. Initially, the child responded to IV antibiotics, but at CRS onset, he required HHFNC support and inotropes, and injection dexamethasone was added in view of the CRS, after which the child showed response. Fever subsided in 48 hours with resolution of other symptoms in 5 to 6 days after starting steroid therapy. So both the children were admitted in PICU with persistent high fever, progressive worsening of respiratory distress despite broad spectrum antibiotics. CRS was diagnosed following a change in clinical pattern of fever which became high spiking with worsening respiratory distress and development of encephalopathy which we saw in our cases also. This was associated with fall in blood counts compared to previous values along with new onset transaminitis, low albumin and hallmark hyperferritinemia. After intensive care management, which included IV dexamethasone, their condition gradually improved. They were discharged after 1 week and 2 weeks respectively. So cytokine release syndrome is not so rare. It is severe systemic inflammatory condition characterized by excessive immune activation. Adenovirus, a double-stranded DNA virus, has been increasingly recognized as a trigger for CRS. So to conclude, high index of suspicion is required when standard treatments fail, and early identification and prompt treatment with short course immunosuppressive therapies shows clinical improvement in these critically ill patients. Thank you.
Very nice case, but I would like to know, like, this case is especially infection-associated CRS syndrome, correct?
Yes.
So they did not have any immunological in the background, disease, immunological disease, I mean.
First case, which was 1-year-old male child, there was infection in him, adenovirus LRTI, but we can also suspect primary HLH in him. Some genetic mutation could be present, so his ferritin levels and everything was very skyrocketing.
So the patient did not have any other symptoms apart from the fever and any other immunological, like in the way of, say, rashes?
No, ma'am, no rashes, ma'am. Fever with respiratory.
On follow-up, any other like maintenance therapy the patient has been given?
On follow-up, we have found the children to be asymptomatic.
Okay. What are the other infectious causes which can give rise to CRS?
Ma'am, the other could be, dengue infection or CMV, or ma'am,
That
even
you have looked already.
Yes, ma'am, bacterial causes like streptococcus, staphylococcus, or parasites, ma'am, they can cause.
So when do we have to suspect like CRS, especially when patient presenting in such a serious conditions?
Ma'am, when we see that the pattern of fever has changed, after a clinical improvement, we are seeing that the fever spikes are increasing or the symptoms are worsening, and there is bicytopenia. In lab parameters, if we say, ma'am, bicytopenia, increased ferritin level, LDH, transaminitis, then, ma'am, we should always have in our mind that it is going towards cytokine release syndrome.
Okay, thank you.
Yeah, very, very interesting. And I was more interested to see that this was a recent adenoviral outbreak and not the big one we had 2 years back, where there were far more patients across the country.
And these patients were admitted in January and February only this year.
Yeah, we did not have a parallel adenoviral outbreak at that time in Kerala, but we had it 2 years back. Now, my question is, if dexamethasone had not been enough, what else would you have done?
Yes,
if dexamethasone was insufficient to control, what else would you have done?
We would have gone for, ma'am, etoposide, and ma'am, then we would have gone for cyclosporine.
Okay. So would you go down the etoposide pathway immediately for these patients? I mean, would you want to use the primary HLH pathway to treat these patients, or would you want to treat them a little differently?
So ma'am, here we found the cause of the HLH. So in cytokine release syndrome, first of all, we have to treat the etiology, and in primary HLH, if it's proven that it's a primary HLH, then stem cell transplantation is the definitive treatment.
Yes, for those patients, you need to go down the etoposide pathway, but here you would want to try and spare them of the drug if possible. So the question really would be, if DEXA didn't help, your next course should be ideally IVIG here, if not along with the DEXA, that especially when dealing with the infection-induced. The other question is very simple. Actually, on the whole, in a big pediatric hospital, if you were to look at all the cases of secondary HLH, what do you think would be the most common trigger?
Ma'am, big pediatric hospital?
Yes.
Ma'am, infection?
Infection, yes. The most, it's, though rheumatological diseases have a higher chance of causing HLH, infection is the most common of secondary HLH. So it is something that all of you should be thinking about when your child with infection is not getting better. It should be one of the differentials in your mind. Thank you.
Thank you.
Next, I would like to call Dr. Kiranmay Maji from AIMS Kullani.
Good morning, everyone. I am presenting an interesting case, recent case in our hospital. Introduction: autoimmune hepatitis and lupus hepatitis share overlapping features: elevated liver enzyme, positive ANA profile, hyper gamma globulinemia. Both can show interface hepatitis. So these can share overlapping features. So there is always be a diagnostic dilemma between this. AIH need long-term immunosuppressive therapy with corticosteroid, and lifelong treatment often required for preventing relapses. But lupus hepatitis is managed as a part of SLE, focusing on controlling overall disease activity. It responds to mild to moderate doses without need of long-term liver-specific immunosuppression. So accurate diagnosis is essential to avoid overtreatment of lupus nephritis and undertreatment of AIH, which carries a risk of progression to cirrhosis. 11-year girl child presented with earliest discoloration of skin and urine for 1 month, which is not associated with itching, associated with pale stool, intermittent low-grade fever for 25 days, no diurnal variation noted, intermittent vomiting for last 3 weeks, blood mixed stool for last 5 days. Initially, she was diagnosed as hepatitis A infection outside and treated symptomatically. Later, she was hospitalized due to persistent symptoms. There is no history of hematemesis, hemoptysis, hematuria, esophageality, joint pain, joint swelling, oral ulcer, or alopecia. On examination finding, the general physical examination, she was lethargic, severe pallor, icterus, bipedal edema present. Head-to-toe examination, there is no stigmata of CLD noted or no hemorrhoid or perianal tag present. Anthropometrically, she is within normal limit. BMI 21 kg per meter square. Relevant systematic examination: on abdomen examination, abdomen distended, umbilicus flushed with skin, shifting dullness present. On CNS examination, lethargic, inappropriate behavior noticed, disoriented for time. According to West Haven criteria, HE grade 2. Other cranial nerve, motor, sensory and cerebral examination within normal limit. USG whole abdomen done, it's suggestive of CLD with few feature of portal hypertension. Fibroscan done, it show severe fibrosis, no steatosis. Relevant investigation done. At first we ruled out TB workup done, it came negative. Wilson workup done, which came negative. And acute and chronic hepatitis marker are done, which came negative. These are the investigations which are suggestive of autoimmune hepatitis and lupus hepatitis. In AH panel, LKM positive, ASMA positive and ANA positive, 1:640 dilution, 2+ intensity, and pattern is nuclear speckled and cytoplasmic pattern. And IgG is raised. In lupus hepatitis pattern, ANA pattern, there is SSA positive and PCNA positive, low C3, C4, DCT positive, and 24-hour urine protein is high. According to the new ACR guideline criteria, this score is 12, and in autoimmune hepatitis modified criteria, it is coming as a score of 13, which is probable AIH. Managed one dose of IV methylprednisolone is given, then followed by oral prednisolone and azathioprine is given. The value I showed previously, the CBC is after getting the azathioprine. Previously, before getting azathioprine, hemoglobin was 9, TLC is around 20,000, and platelet is around 2 lakh. After azathioprine, pancytopenia noticed, so azathioprine toxicity suspected and replaced with MMF. Patient on hospital stay, cough developed, transaminitis worsened, diagnosed influenza B, hematuria treated conservatively, and hepatic encephalopathy managed by supportive care. Symptoms improved, planned for liver biopsy. Biopsy done, but report yet to come. So discussion, once a patient meet the newest ACR criteria and AIH criteria, AH-SLE overlap syndrome should be considered. It is estimated to affect 1 to 2% of patient with AIH and 1.3 to 4.7% with SLE. As serological pictures share overlap, so histological and clinical feature can differentiate AIH from SLE. But in our case, typical SLE feature is absent. The presence of histological feature support the diagnosis of AIH, interface hepatitis, but don't exclude the SLE. So the diagnostic dilemma continues. Thank you.
Thank you. And this is typically the kind of dilemma that often rheumatologists have to face. Can I suggest the possibility of a Sjogren syndrome here?
Yes,
primary Sjogren's or a secondary Sjogren? Would you disprove that possibility?
There is no clinical feature suggestive of the Sjogren there.
But you had a strong positive SSA antibody, you had hyperglobulinemia, you had many things. This could well represent a primary Sjogren rather than lupus in this case, which can actually coexist with an autoimmune hepatitis as well. So
it may be Sjogren, but there is very little study about the overlap of Sjogren with AIH.
Okay. What about the complement levels in somebody who has a chronic liver disease?
Complement level?
Which part of the body is the complements produced from?
Liver only.
Yes. So if you look at patients with liver failure, what is the trend of the complements that you will see in those patients?
Complement level will be
very low actually. So you cannot use that alone. In a patient with liver failure, you cannot use complement levels to make a diagnosis of lupus actually. That's a very important thing because they'll all have low complements anyway. The liver is not functioning. Your autoantibodies are important. Direct Coombs test, if positive, would also have been showing some kind of surrogate autoimmunity that is happening. The reason I ask is because from a treatment perspective, it could change the way you view the patient for further treatment. Okay.
Can I show the investigation slide again when you have separated these two? See, basically autoimmune hepatitis, what I feel over here is you have an ANA positive and you have an asthma positive.
Yes.
Anti-smooth muscle. Combination of this is a type 1 hepatitis.
LKM is also positive.
No, that's what, you have an LK which is liver kidney microsomal antibody. What is the basis that you have got an LK? Have you done a purified antigen on a blot or you have done on an ANA profile on an immunofluorescence? Immunofluorescence is not good for LKM. So therefore, LKM having all together is a question that I would sort of not accept it. What was your enzyme status? I believe on this you have a transaminase is more than gamma glutamate because your anti-mitochondrial antibody is negative. So it's not a cholestatic type of autoimmune hepatitis. It's a autoimmune hepatitis of the hepatocytic type. But ANA and SMA together is a primary liver disease, autoimmune hepatitis type 1. I am not sure about your LKM. And you also had, as Madam has pointed out, you have this as a extractable nucleantide in the SSA positive. Now this is a complicated thing. What is the method that you have used is very important. How do you do it? On PCNA, you might have used a blot. Now, PCNA is also seen in a PCNA is seen as a pleomorphic nucleus where it's not very classical, but a PCNA is not seen in autoimmune hepatitis. I think you need to sort of come to this. This is a very complicated sort of a thing. What was your method of doing LKM1?
It is by immunofluorescence only.
No, that's what is problem. LKM1, 1 in 40 is not a titer. When you do an autoimmune hepatitis profile, you use 1 in 100. So these are the sensitivity issues. You lose specificity with your low dilution. And your AMA is also has to be because you are looking for a cholestatic, primary biliary cirrhosis. Your dilution is 1 in 100. So this, if you have done on a screening immunofluorescence, then I would not accept this. You can't have an LKM with an ANH and an asthma. That's not the clinical picture. It's not being reported. So this to me would be a primary autoimmune hepatitis or type 1. But LKM is a question.
LKM is positive, sir.
That one used to say leukoid hepatitis, that's not being used.
Can I? Yeah, this is for you and other postgraduates, whoever be present here. Classification criteria is for the research purposes, and when you are conducting any research, planning any research to be done in the community, you have the checklist done. And when you are having an individual patient, you should have a diagnostic criteria, that is the older one, not use the classification criteria. Second thing is, I didn't find PTA-PTT.
PTA-PTT was initially was 1.5 to 1.7 range. Then after giving vitamin D, within 1.4
in liver
borderline.
failure, we do expect worse things. AST was more than ALT. Again, it could be impending liver failure, and I think you had that.
Yes.
So treat as the patient you get. So rather than trying to find out whether there is overlap and not, which we commonly get, that's okay. But do not try to name the disease right in an acute setting. Rather follow it and see how the things goes. Rheumatology is all about follow-up, mostly about follow-up.
Thank you, sir.
Very, very good insights from both of them, and we'll stop it here. Thank you.
Thank you, ma'am.
So the session will be closed, and now the next session will move on.
In memory of the departed souls at Pahalgaon, Kashmir, we would like to observe a minute of silence, requesting everyone to rise for this occasion. Thank you, everyone. I would request all e-poster presenters to proceed to screen 1 hall for their e-poster presentation. Up next, we would like to call on stage Dr. Shotobrata Roy Choudhury, Assistant Professor, SSKM Hospital, and Dr. Moushmi Nondi, Principal, Midnapur Medical College, for our panel discussion.
Good morning. I would like to thank the organizing committee of West Bengal Pediatric Rheumatology Society for inviting me to chair this session. Now this topic is it's a panel discussion on infection and inflammation and hyperinflammation, infection and hyperinflammation. Our moderator of this panel discussion is Dr. Priyankar Pal. Please come on stage. Dr. Priyankar Pal is head of the Department of Pediatrics at Institute of Child Health, Kolkata. And he's a consultant pediatric rheumatologist. Everyone knows him. He has many publications to his credit. And now I would like Dr. Priyankar Pal to introduce the panelists.
So I think the stage has been set by a previous presentation by Dr. Maria. I would request the 4 panelists to come and join me over here. So we have Dr. Madhumita Nondi. So Dr. Madhumita is HOD Pediatrics at the North Bengal Medical College. She is a pediatrician with an immense interest in pediatric rheumatology. We have the infectious disease specialist, Dr. Jogiraj Rai, who is an associate professor at the Department of Infectious Disease, IPGMR, Kolkata. We have the pediatric intensivist, Dr. Kaushik Mollik, who is a consultant pediatric intensivist at the Apollo Multispeciality Hospital, Kolkata, and an assistant professor at the PICO of the Institute of Child Health, Kolkata. And we have our own Dr. Vijay Vishwanathan, the rheumatologist, who is a consultant pediatric rheumatologist from Jupiter Hospital, Thane, and Apollo Children's, Navi Mumbai. So let us have an inflamed session, I think. So we have the whole team over here. So just over here. So as you can see, that sepsis is just not sepsis. It's basically a dysregulated host response to an infection. Right to left. So if you look at the cytokine release syndrome, it's a webinar that happens every yearly. So I think about 2 years back, this was a person who was speaking from US. He's an intensivist, and he gave that of the 5 million ICU admissions per year, 4 million experience a cytokine storm. So it is not uncommon. So the infection and hypercytokinemia, we know about it from the late 70s when there was a paper by Dr. Nesbitt, viral associated hemophagocytic syndrome. This was followed by the FHL, the familial histiocytosis study group, Professor Hunter and his colleagues who published extensively on familial HLH. Professor Grita Janka, who published on infection and malignancy associated hemophagocytic syndromes. So this is going on since the late 70s. And you have the HLH 2004 criteria, which actually was basically dealing with more of a primary hemophagocytic lymphohistiocytosis. But over here, we are interested more in the secondary one. And this was one of our old publications, I think 2011, when we published a series of 23 cases of infection-associated HLH, which we treated only with steroids. So you can see there was hepatitis A, chikungunya, tuberculosis, CMV, dengue, EBV, so a whole gamut. We did not follow the entire protocol, we just treated with steroids. I think the timer is not moving. Can you have a look at the timer? And it was around 10 years back when this name came up, the cytokine release syndrome, which came up in association with CAR T cell therapies, and the hyperinflammation followed that, and there was a cytokine storm syndrome. There's a beautiful book by Professor Randy Cron. You can go through this book if you're interested. So cytokine storm refers to a diverse set of conditions with the shared clinical phenotype of hyperinflammation, the hallmark hyperferritinemia, and a multi-organ dysfunction. which results from excessive cytokine production through unchecked and amplified immune activation. And there's a huge host of conditions which can actually trigger this. You can have a genetic basis, which is a primary HLH, a lot of infections, oncologic, leukemia, rheumatic, MAS in associated with SGIA, medication, and iatrogenic. So the list is exhaustive. So let us look at the changing times of 2020-21, when actually the world became a little more aware of the cytokine storm syndromes. So this is a very interesting thing, that the multifaceted immunology of cytokine storm. So they have reflected there's nothing quite as powerful as a worldwide fatal pandemic to bring increased attention to cytokine storm syndrome. And from a lumpus perspective, CSSs have garnered attention from a vast variety of biomedical disciplines. So people were talking about cytokine storms in general. So I'll start off with the infectious disease specialist. So Jogiraj was actually deeply involved in COVID during the COVID years. So what was your perspective of a cytokine storm syndrome in the COVID-associated cytokine storm?
When I started seeing COVID patients, the first COVID patient of Bengal was my patient. So from that, at that time, the notion internationally was not to give steroid because it is a viral infection, as we have a vast experience of influenza where we don't give steroid in ARDS also. So in that perspective, we avoided steroid in initial few patients, but with 1 or 2 months, when real COVID patients that with hypoxia started coming, we quote unquote we started giving steroid with hypotensive patients with hydrocortisone, as we give in hypotension in shock, and these patients was favored better than others. So that in that 2 to 3 months interval of first patient to our faith on steroid started with giving hydrocortisone. Then there was evidence that steroid actually saving lives. So that there was paradigm shift of giving steroids from anti-steroid to pro-steroid. Then again, what started? Giving long steroid. That even was very risky, and lot of patients actually developed sepsis after that. So there was a requirement of judgment over there. But with time, there are a lot of biologics also came into play. People was running after biologics. And at that time, I got an opportunity to work with one immunologist, and we published a lot of paper with him. He's my senior, Dr. Dipoman Ganguly, you may know him. Later, he got the Bhatnagar Award for his work in COVID. So we started seeing with a trial, we went for 80 patients with severe COVID and 80 patients with without severe COVID. So we followed them up for 10 to 15 days of their hospital stay and like that. So what we found that there are vast difference in different patients. So there are different subsets, and all subsets are not same. Some of them have expression of high amount of soluble urokinase, and these patients are actually having pulmonary hemorrhage. So in that patients, we pulmonary thrombosis. So in that patients, we have given say anticoagulant, and but majority of the patient had high CRP, high inflammatory markers, so and hypoxia simultaneously. So steroid was better for them, but some patients, only a few, had interleukin 6 level high. So there are subsets, and there must be some host pathogen interaction as plural as HLH spectrum. So we have to actually identify different pathway, which pathway is activated in whom, and actually what should be the immune suppression in all them, not steroid for long duration. So that was our experience.
So if I sum up what Jogiraj said, that here was an infection, a viral infection, a global pandemic, where immunotherapy was making a difference. But the timing of the immunotherapy was important. I think it was working best in patients who were developing a hypoxia. So not too early, not too late. And again, the duration of the immunotherapy, not too long. So that was basically the game which was being going on. And if you look at the recovery protocol, you can see what made a difference: steroids and subsequently baricitinib. And this was the landmark paper that was published in NEGM, dexamethasone in hospitalized patients, tocilizumab was tried. So yes, for the first time, possibly everyone was talking of immunotherapy in the background of an infection. Now, let us look at the pediatric subset during that time. So, July 2020, lockdown is going on, and we have this 6-year-old girl with fever, loose stool, red eyes, rashes. You can look at the rashes involving the palms and the palms. And day 5 of illness, she has a sudden onset hypotension. So, I would request Dr. Madhumita Nondi, the pediatrician, how would you have investigated and what can be the possible diagnosis?
Possible diagnosis, obviously, we are sitting in a panel discussing cytokine storm. It has to be something related to that. But on a serious note, if you think of the etiological possibilities broadly, I'll put etiology into 3 broad headings. Like, is it directly something infectious etiology, or it's not a result of some post-infective related to immunological phenomena related to some infections. And third possibility is non-infective, just inflammatory etiologies. No infections identified. So infection is dengue and all things. Yeah, we have
so
rash,
you are passing
fever.
through lockdown. Everyone is at home.
Yes, that's what I'm coming to. So infectious etiology, dengue-related virus, complicated by dengue complications, that is a possibility. Non-infectious Kawasaki is a possibility, but in view of 2 or 3 things, as you said, the timeline, the temporal relation with lockdown and COVID and pandemic
It's July
and other
2020.
things. So is it related to COVID? Number 2 is for Kawasaki may very closely mimic post-COVID that MISC, but age is 6 years. So Kawasaki mostly, it's not that it will not occur in a 6-year-old child, but it's more common in
so what do
age
you
group
think
of
has happened to this child? So this child has come under day 5 of illness with a sudden onset hypotension.
Yes. So it's some complication of some infectious pathology, what I feel.
So what was happening on those years?
And looking at the temporal relation, I will think of MISC as my first
Yes.
possibility.
So that was something that was going on. I think it was first reported in Europe, and then because of the webinars of that time that was going on.
At that time, July, 1 or 2 cases were coming up, some descriptions, some case reports were coming up. But,
so how would you have investigated this child?
I would have, if the child has come to me for the first time without any previous.
This child has come in shock, hypotension.
Yes. So I will first obviously give symptomatic management of shock with fluids and other things. And then I will try to make an etiological diagnosis. Etiology related to infections, so all possible
So I think it's the intensivist domain now. So this child has landed in the intensive care. Kaushik, tell us something.
So when we encountered these patients, what we used to find is that they are sometimes acutely crashing and presenting. And when we put the echo probe, which we often do in our ICUs right now, because ultrasound machine is readily available, we find severe myocardial dysfunction. So per se, it's a cardiogenic shock that we get. And another typical feature we find in this patient is that when we put the arterial line, and obviously to monitor the continuous blood pressure, there is this wide pulse pressure. So typically in cardiogenic shock, we should be getting a narrow pulse pressure. But in these patients, so there used to be a significant component of vasoplegia also. So they used to have diastolics even which has gone down to 30. And systolic also was low, but it was not that low. So we used to get a wide pulse pressure. So for these patients, we used to do the echocardiography, send the inflammatory markers like we used to send ferritin, D-dimer, fibrinogen. Anti-COVID antibodies used to be sent at that time because at that time COVID vaccination had not
What was the CRP like in these
and
patients?
CRP used to be sky high.
Sky high, almost
very,
150,
very high
200,
CRP.
250, something
Yes,
like that.
so it used to be 50, 60 times, sometimes 100 times elevated. And then we used to obviously give the symptomatic management and immunotherapy. And immunotherapy used to work like wonders in these patients. And a time had come when, as Madam mentioned clearly, that infection-related complications, when the wave of MISC came, with a single glance at the patient, we could tell, yes, this is MISC. So we almost had no other differentials at that point of time for quite a significant period of time. So many patients. And they also used to have that conjunctivitis, typical, that bulbar
We showed the red eyes,
conjunctivitis.
the red
Yes,
eyes, yeah.
eyes it used to have.
Non-purulent bulbar conjunctivitis,
Yes,
like
yes.
KD.
Yes,
So, Vijay, would you summarize your experience with MISC?
So I thought if I sit here, I'll get the first chance. But even in life, the rheumatologist is often blessed or cursed to be called.
No, intensivist has called you now.
At
Just
the very end, yeah. But jokes apart, this used to be a very straightforward thing once we started following the trend. And I always believe in the A, B, C, D, E, F approach for MISC. So most of these kids would come with A for abdominal pain, B for blood-tinged eyes, C for cold, clammy extremities, D for diarrhea, abdominal pain. Typically, the adolescents who have abdominal pain would not be rushed to the pediatrician also. E for extreme fatigability, and F of persistent fever. And day 4, day 5, day 6, they used to just come crashing with hypotension. And that always used to give a clues. Again, what are the blood tests that the pediatrician should think? A for albumin antibodies, maybe a PCR or an antibodies. B for BNP, so N-terminal pro-BNP used to come to our rescue, at least being a sensitive but not specific marker. We have seen BNPs really high, 70, 80 thousands. C for CRP, coagulation disturbances, cultures, and creatinine. I always used to send D-dimers because it kind of pointed to a coagulopathy. E for enzymes, and then because you know that the kidneys also were affected, I always used to send a urine PC ratio. The bottom line is, the term that I found very useful to explain it to myself and the pediatrician was inflammatory coagulopathy, resulting in multi-organ dysfunction. So when you have features suggestive of Kawasaki disease with any organ involvement in the form of liver, kidney, GIT, and the CNS, with coagulopathy, which is inflammatory. So high CRPs, high ferritin. Many of them would actually have slightly deranged ferritins, not really very high, but overtones of HLH, as we would call it. So end of the day, when people said, "Kya ho raha hai?" I used to say, don't forget everything, it's Kawasaki. It may not be Kawasaki, but what follows a COVID infection looks like a Kawasaki disease shock syndrome. It's the easiest way to understand. Think of, nobody will diagnose MISC, I think, right now in July 2025, but this was the way I used to dissect it out.
And what about the procals in those patients, if you remember? The procalcitonins?
So, in fact, the lesson that all of us should learn is high CRP doesn't mean infection, because like Priyanka and our intensivist friend said, we used to see a lot of CRPs in MISC, and what would you do? Not step up the meropenem and vancomycin. You used to pulse them with steroid, immunosuppress them. So I am almost convinced that the higher the procalcitonin, higher the CRP, you may be looking at a hyperinflammation story. And it's always a story of, like we will discuss hopefully, that think of a infection, rule out a malignancy, and start addressing the cytokine storm. High procal doesn't mean infection alone. High CRP doesn't mean infection alone. it has to be taken in the context of the clinical scenario.
There's one point I'd like to mention in this context, like from intensive care point of view. This is the subset of cardiogenic shock patients whom we treated with milrinone plus norepinephrine. Why? Because this is a subset of patients with cardiogenic shock who had very prominent vasoplasia, as I mentioned. So they required a lot of norepinephrine and even vasopressin, which is quite uncommon. When we were managing them, we had found at that point of time.
So have a look at this umbrella by Dr. Scott Kana. So this is the umbrella of the cytokine storm. So we have a lot of terminologies, the HLH, the MAS, the CRS. So it is a unifying umbrella. If you look at the umbrella, so there's infection which comes in, there's viral associated CSS which comes in. So you have flu, COVID, MIC, KD, you have malignancy associated CSS, and you have the SGIMS. So everything, you have a unified sort of umbrella approach if you look at if you call it a cytokine storm syndrome. Let us go over to another case. So this is a 9-year-old fever. So this is just a new, very latest patient, last month on 16th on oral antibiotics. So 8th day of fever, the child is drowsy, Vidal is strongly positive, the blood culture gives salmonella, and if you look at the reports, so look at the reports on 24th and 22nd. Jogiraj, how would you like to interpret these reports? So you can see that the platelet has coming down, your CRP is very high, albumin is low, and OTPT is deranged.
So this is a involvement of multi-system due to inflammatory response to typhoid. I will like to see like that. And one point in CRP, we don't give much importance in CRP, in all ID. We don't give much importance in CRP. We just see the patient clinically. That is the most important CRP for us.
Okay.
Yeah, I will give more importance to this trend of counts. Known typhoid is already diagnosed as typhoid, salmonella typhi, you were saying it's diagnosed, but the child is not becoming better. Child getting sick and the counts, this is very important, and the counts decreasing. So
would you like to have a look at the HLH parameters, the ferritin?
Yes, of course I'll like to
would you like to
look.
have that? And would you start immunotherapy or would you like to wait?
I'll of course do investigations for HLH, I mean your mass or HLH.
So if your ferritin is 12,000.
Yes, if ferritin is 12,000, if triglycerides are more, if fibrinogen is less, and here a differentiating point is ESR. We give, because as I work in a government hospital in a so-called periphery in North Bengal, where all these detailed investigation facilities are not always available, but ESR, a child getting sick, decreasing count, ESR not that raised. Suppose have you shown ESR? Actually, if in this child, if ESR is still 10 or 12, I will think of, because we don't always get facilities for ferritin. आज है तो कल नहीं हो सकता है. So to save, actually picking up these patients in time is important.
So my question would be to Kaushik. So would you like to start immunotherapy or would you give antibiotics or observe the patient, knowing that there may be an underlying cytokine storm?
Yes, sir. So
short answer.
In this situation, I would have to like to have some basic investigation. So what is available to me that I would like to know?
Your ferritin is raised. So the HLH parameters are raised. Yes. You have started antibiotics. The patient is drowsy. Would you start steroids? Or would you like to observe the patient?
At this point of time, with only a raised ferritin is there, along with that my counts and platelets both are dropping. So I think that giving 1 or 2 doses of steroids may not cause harm, and just seeing what is my response with that.
I would want you to tell me that the ferritin is 1200 and not 12,000. 12,000 is a no-brainer. This is frank HLH. You would want to pulse this child as hard as possible, but 1200 is with a backdrop of a known etiology. You may serially monitor, watch for, treat the infection. Maybe the HLH will get better like nephrotic. And then
so you have a bacterial infection, the HLH may improve on treatment, If the patient is worsening, you start immunotherapy.
Sir, for just one more thing in this aspect, like in these situations when we have a borderline ferritin, like we do not take the 500 cutoff obviously. Like for example, if we have a 7,000, 8,000 ferritin, we usually in the clinical context also give importance to fibrinogen. Like if we find that my fibrinogen is low, especially around 100 or even below that, then we are quite sure this is probably HLH that is going on.
Definitely.
So then our
And a
decision
ferritin
becomes
above
easier.
10,000 is almost HLH.
Yes, yes.
It has a 96% specificity for HLH. I think I have a slide
So
of that.
one last thing is always do an ESR when you do a CRP. ESR is the poor man's fibrinogen like we know. And that discrepant ESR and CRP, you can't compare yesterday's ESR with today's CRP with tomorrow's ferritin. Either you do all of them at the same time, but ESR is like kadi patta. You know, how many of you know how much 100 grams of curry leaves costs? Even the pathologist is not interested in doing ESRs these days. I'm talking of Mumbai. So it's not non-specific, but please do it in these situations.
Okay. So moving on to the adenovirus. So we know, I think everyone experienced over the last couple of years a lot of cytokine storms associated with adenovirus. Even if I do not say cytokine storms, bad adenoviral pneumonias. So let us look at this baby. I think this is the same baby Maria presented. So this is an 11-month-old baby, fever, cough for 5 days. And these were the initial investigations. And this is the X-ray you can see, some patchy opacities, interstitial. Day 3 of admission, so this is day 8 of illness. The child is still febrile, looks a bit lethargic, and respiratory PCR shows adenovirus. Day 5 of admission, so that is day 10 of illness, the spiking high temperature, 105 degrees. Now the baby is not only lethargic, the baby is drowsy, there's desaturation, the baby is transferred to the PICU, and you have the reports, you can see that counts are coming down. There's a serial fall in counts, the platelets are coming down, the CRP is normal, but albumin has come down, there is transaminitis, significant transaminitis, the SGOT is more than 10,000. So would you like to do some more tests? Anyone?
Yeah, again, it's a similar situation. That was on post-typhoid, and this is post-adenovirus. So child not improving, rather getting more sick with declining counts, with transaminitis, with albumin low. Definitely investigations
So
for
this is
HLH
almost
or
like an
MAS
algorithm.
are required.
So a child who is not improving, maybe the fever pattern has changed, there's development of multi-system involvement, this child has become encephalopathic drowsy, there's hepatopathy, the transaminitis have gone up, the platelets are coming down, the counts are coming down, the neutrophil lymphocyte ratios are getting altered, the CRP may not be elevated.
Yes,
So
but
a lot-
here also I would like to know about ESR. As Dr. Vijay said, ESR nobody talks about nowadays, but ESR still has
Vijay, would you like to say why the CRP is not elevated in a lot of viral infections?
Because it's never done. So in isolation, the ESR and CRP doesn't help probably, but the minute you start combining the two, again in this situation, this child has almost, he needs a liver transplant sooner than later. 11,000 SGOT PT, you know that you are entering the HLH MAS territory. I would like to call it Hamas, you know, forget HLH or MAS, it is Hamas, it is angry inflammation. You will do what needs to be done. And again, one of the situation, don't go on CRP alone. I have read enough about dengue and CRP.
We'll come to that.
Yeah, means why the CRP doesn't go up. Don't say CRP is not very high, so it's not HLH. There are probable mechanisms which maybe the interferons which are released in fighting the infection doesn't allow the CRP to mount, possibly, but it's always taken to be together.
So basically what was he was saying that the CRP is IL-6 driven, but it may not be IL-6 driven, the inflammation may be IL-1, IL-18 driven. So that time the ferritin goes up, but the CRP doesn't go up. So over here, you have a significantly high ferritin, 15,000. So Kaushik, I think you are involved in this patient. How did you intervene?
So yes, I was involved, and as we saw that the counts were dropping, the platelets were dropping, hepatopathy was there, ferritin was above 10,000 and sky high. So we naturally knew that this patient is going into HLH along with the clinical presentation. So we started the child on immunotherapy. We started initially on steroids. And
Dose of steroids?
10 mg per meter square per day of dexamethasone. That's what was started.
So the next day morning, the baby is afebrile, on nasal cannula oxygen, no further deterioration. Kaushik goes for evening rounds and he gives me a ring. So this is the evening round, sudden increase in the respiratory efforts, and the X-ray has been done. You can see there's worsening. Your thoughts?
Yes, so by this time the kid had already received immunosuppression for some time, and as we can see from the serial trends of the investigations, the inflammatory markers had started coming down. Ferritin had come down from 16,000 to around 8,000. The encephalopathy had also improved. The counts had started improving. Platelets had started improving, and liver enzymes had started falling. So overall, the inflammation seemed to be improving. And by this point of time, I think the child had received 10 mg per meter square per day dexamethasone for quite a few days, and also probably anakinra, right,
No,
sir?
anakinra.
Or
Just
only dexamethasone, right? And then we found that the child was having respiratory distress, and on auscultation there was crepitations, and chest X-ray revealed this picture. So naturally, I felt at that point of time that probably now the child has developed a secondary infection, probably a pneumonia. So that's why I called sir, and I felt that we should.
Or there's an adenovirus is flaring only.
And also it is possible that the adenovirus might be flaring, because the primary thing might be flaring now and the HLH might be settling. Also it could be a secondary bacterial infection, any other thing. So we again sent the cultures, markers, and we started on appropriate antibiotics, and also we felt that probably adenovirus might be worsening, so this child might require cidofovir injection to control the worsening pneumonia, and we came down on the steroid dose significantly. I think we had stopped at that point of time or lowered the dose.
So that is the thing, that these are all dynamic patients. So every day you have to take a decision regarding the patients. And again, the dose of steroids may not be uniform for all patients. And what we usually do, we give a very short course of steroids, 5 to 7 days. Maybe after 48 hours, if the child is improving, we start coming down of the dose, maybe within 48 or 72 hours. So what we said, ferritin levels about 10,000, almost 96% specific for HLH. I think I will just, because of lack of time, I thought I will ask Jogiraj. So this was our experience for adenovirus CSS. I will again just skip. So what we came across, that it was not at the initiation, it was almost around 7 to 10 days of the infection that the patient developed a cytokine storm syndrome. And this was our Shuparna's paper from her institute. And this was another patient who had severe adenovirus pneumonia with aneurysms in the coronary artery and ultimately received anakinra. This was also published. So the final thing, does viral hemorrhagic fever represent a reactive hemophagocytic syndrome? Because that is one thing which is a nightmare. Dengue remains a nightmare. So this was a very old case series that we published, the dengue associated classical. This was HLH. So we were not aware about CSS at that time. Let us look at this patient. This is a 14-year-old girl, diagnosed dengue, admitted. We'll have a very short sort of rapid-fire round of questions because we don't have much time. Admitted on day 7, hypovolemic shock. So initial management we all know. So we have given crystalloids, we have given colloids. So I will just skip over that. So the patient is in the ICU, and these are the investigations now. So you have a platelet count, which is of course 15,000 dengue. The creat is 0.9. The OTPTs are again very high, and the ferritin is 1 lakh. The fibrinogen is low. Vijay, would you like to modify your management? Would you like to think of something else?
So this is, again, no-brainer. This is call it macrophage activation syndrome, call it HLH, call it HLH-MAS, or call it Hamas. You will need to be very, very proactive. And I think as rheumatologists, we are fond of methylprednisolone more than a dexamethasone. I think I'll cover a part of it in my next lecture on steroids, but this is tailor-made for while I start pulsing 30 milligram per kg solumedrol for this kid. I am skeptical about what I'm seeing right now because
that was what we did. That was what we did. Opinions vary.
I actually used Dr. Priyankar's paper to sell methylprednisolone in dengue HLH because they seem to believe him more than the rheumatologist in Mumbai. I showed him that IIP ka paper, see, rheumatologists treat HLH and dengue differently. So like he said, Dexa versus Solumedrol, I think that methylpred works faster, gets out faster. So Dexa is a long-acting drug, longer half-life. In an emergency, give methylpred, 10 mg should be okay, if not 30. And then
we increase the dose the next day. We caught up with you. So post-IVG steroids, you can still see the day 2, the ferritin is still hovering in 1 lakh. The OTPs are still very high, and now you have worsening renal parameters. Kaushik, how will you manage this patient? And you have ARDS now. So this is, the child has gone into ARDS and AKI.
So intense and appropriate supportive care, that's very important. So mechanical ventilation obviously for this kind of ARDS, and obviously these patients will tend to get progressively fluid overloaded with acute kidney injury, so would require renal support therapy in the form of continuous renal replacement therapy, and also obviously immunomodulation, which needs to be escalated. And also we have extracorporeal cytokine removal facilities now in the form of cytosorb or oxyris.
Just 1 or 2 words about cytosorb. Because a lot of people will not be knowing about it.
Cytosorb is an extracorporeal cytokine removal filter which can be attached in series with a CRRT circuit. The CRRT machine is there, with the circuit in series we can attach cytosorb. And one filter will last for around 12 to 18 hours. So it will help to remove the cytokines by the mechanism of adsorption. And there is another filter called oxyris, which comes integrated with the CRRT circuit. And the advantage is that if you use oxyris, the whole filter along with the circuit with an appropriate anticoagulation can last for 72 to 96 hours. So effectively, oxyris becomes more cost effective. And cytosorb, every 12 to 18 hours, we have to change. That is
so your patient is still not improving. Vijay, would you like to do something?
Right. So
you have given methylpred, you have started cytosorb.
So I'll ask them if they have 2 lakh rupees. I believe one filter costs 1 lakh of rupees. The cytosorb filter costs about
75,000 here.
So that becomes 1 lakh in Mumbai. And in 1 lakh rupees, I can arrange for 10 injections of anakinra. So this is the perfect situation where cost cutting may not be that clever because the only chance of survival, and we know that anakinra definitely has a short half-life, better safety margins, and I would strongly consider anakinra at this point while continuing what he's doing. The most important thing is to balance out. You don't want to be giving anakinra and removing it from the exchange or the CRRT, etc. So time it in such a way, and depending on the weight and the pocket, think of anakinra straight away.
So anakinra is what we give. Anakinra has to be remembered. It has a very short half-life. So you can give subcut anakinra. A lot of people will recommend. In fact, Professor Cron himself recommended subcut 6-hourly anakinra just in a recent conference. So, but in the background of a coagulopathy, 15,000 platelets, we would give IV anakinra. We give twice daily IV anakinra, and this is what happened. You can see that actually, I don't know what really made a difference, but a difference was made. So anakinra, methylprednisolone, cytosorb, CRRT, so everything was done, and the child improved. So that is the bottom line. I will again skip this because we have just, I think, 1 minute. Yes. So anakinra is coming up in a big way. In fact, so is severe dengue a cytokine storm syndrome? I think after this session, everyone will agree from this, yes, severe dengue is a cytokine storm syndrome. So there are a lot of papers now, and I will just skip this. So I will come just to the 2022 EULAR ACR points, HLH mass, the initial, what do you think? So systemic hyperinflammation is an immunological continuum. The characteristic clinical and laboratory findings are individually non-specific, but when viewed collectively, it forms sort of an algorithm that we were talking about. And severe inflammation can be associated with hyperferritinemia. So I will again skip this. And treatment, what they have said, steroids, IVIG, or anakinra. So whatever you have. But anakinra again is coming up in a big way. So the final thoughts, CRS or CSS is present almost in all infections. But the manifestations may vary. The trick possibly is to think of CRS or CSS, identify that something is not actually going on, something normally is actually not going on, and intervene. So I think that is the most important thing, that timing. So the timely intervention, I think that is the most crucial. So think, diagnose, individualized, treat. And sometimes you need to hit hard, not only hit hard, hit fast, definitely, and hit often, as we did in the dengue patient, steroids, anakinra, CRRT, filter, so hit often. Thank you.
Thank you. Thank you for such a nice discussion. Now this panel is open for question from the house.
Can I ask a very simple question from a lab? Have you asked your lab, do they do ESR? And what is the method? The conventional Western or the automatic method?
Well, you said they have stopped doing. No, that was a joke. I said the pediatricians have stopped doing ESRs. Vestagrin.
That is what the problem is. All the present cell counters having automated ESR in 20 seconds. So this ESR is not a sedimentation rate. It is an erythrocyte agglutination rate. It's the information for all my clinical colleagues. Scenario of ESR is changing. It is no more a erythrocyte sedimentation rate, erythrocyte agglutination rate. That is what the automated machine gives because your report is in 20 seconds. So I need to calibrate the ESR with this. And I have done a good number of 1,000 cases. High ESRs are fine, but the low ESR in this automated system, it's not there. And usually the European community is all automated ESR. They don't do a manual, wait for an hour, go for a second hour. So they don't give you a report of millimeter per hour. They give only millimeters. Please check on your reports.
Okay. Thank you, sir.
So I have a question. As a intensivist, I am working in pediatric intensive care. I would like to ask you that if a child is admitted in our setup who has fulfilled the criteria of HLH, before starting secondary HLH, before starting treatment, which one will be important, the clinical condition or the inflammatory markers? So in which one will you treat?
I think
with
both.
immunomonitor?
Both. So basically you're treating a patient ultimately. So the clinics as well as the marker should go hand in hand. I think Rajiv is dying, and this is the last question because we're running late.
But investigations are important for monitoring, constant monitoring and follow-up, the trend of counts, the trend of your albumin and ferritin. So in other words, ferritin in more, I don't think just one ferritin, more ferritin means more serious patient. It does not. It may not always correlate with the clinical
everything
condition.
should be
the
taken
clinical
into
condition
account.
is important,
So
but
everything.
investigations for monitoring will.
So last question, Rajiv. Yes.
Not a question, just a comment that this is a very common scenario that we get. And like if you're involved with a PICU and if you unfortunately have a nephrology and a rheumatology, all working together, and anakinra is removed by CRRT. And this sort of a patient, we cannot do normal dialysis. So like future studies should be focusing on like whether we have to increase the dose of anakinra or something like that.
So if you remember what we did in this patient, so before the CRRT we were giving the anakinra. So anakinra itself has a very short half-life. So
yeah, but often like these children are so sick that you cannot even
understand.
postpone the CRRT. So whether that dose can be...
Anakinra would be removed by CRRT or CRRT plus cytosol?
No, no, CRRT
Only
also.
CRRT also.
CRRT can remove anakinra.
So actually, the anakinra in sepsis related HLH is 30% mortality benefit. Last 1 year back, one multicentric study has found in adult 30% mortality benefit, but in others not. But actually, these are plural things: polygenic disease, different infection, different comorbidity, and different outcome. We need to have some sort of say by say not consensus. We have to club these patients in different domain and find out what are the patients, which are the response. So this is a more statistical things we need to work on, like a Monte Carlo simulation related things. So thereafter we can find these subsets. So this is a very complex thing.
Definitely.
And
definitely.
more to evolve.
Definitely. So during COVID, possibly because of the global emergency, people were together working. They came up with a lot of things, Arki. Thank you.
Okay, so we have come to the end of this session. Thank you, Dr. Priyankar Pal, moderator, and all the panelists for the wonderful discussion. Thank you.
Up next, we have a segment on osteomyelitis is not always bacterial. I would like to call on stage our chairpersons, Dr. Abhishek N.K. Shaha, Consultant Pediatric Orthopedics at ICH and Amri Hospital, and Dr. Nepal Chandra Mahapatra, HOD Pediatrics, Calcutta National Medical College.
Thanks to the organizing committee for giving the scope for the relearning for the session. To chair a particular session, I invite Dr. Sanjeev Mondal, Assistant Professor of the KPC, to present the case and some inputs to our existing knowledge.
Welcome to the stage, Dr. Mondal.
Good morning, all. So, first of all, I would like to thank the organizing committee for giving me such a wonderful opportunity. So, today I'll be talking on an interesting topic of osteomyelitis is not always bacterial. So, let's start. Here is my disclosure. So, in my talk, I will cover the routine practice on osteomyelitis. Then, is that true that osteomyelitis is not always bacterial? Then, if it is true, then what are beyond bacteria? So what we see in routine practice that once a child is coming to your clinics with fever, bone pain, some erythema and swelling over the painful side, we order some blood investigations, order some imaging, we diagnose the child as bacterial osteomyelitis, start some IV antibiotics. If there is a response, it's okay. If there is a no response, we start another course of antibiotics and sometimes start empirical anti-tubercular therapy. Here you can see two clinicians. Right one is very confident. With this presentation, he is very confident it is nothing other than bacterial osteomyelitis. But on the left side, you can see the guy is very confused. Is there any valid reason for his confusion? So the fact is that what we see from the outside is not the real story from inside. If you look from different angle, it will look different. So for this better understanding, I have put here 6 cases side by side. So all are boy, all are male child, 4 years of age. They presented with similar clinical manifestation of fever and bone pain. Out of the 6 children, 3 had similar site involvement of the tibia, 1 had mandibular involvement, 1 had clavicular involvement, and another had vertebral involvement. So the confident clinician diagnosed them as having bacterial osteomyelitis, started on IV antibiotics. Many of them required multiple courses of antibiotics and ATT. But unfortunately, he failed 5 times. Only 1 child responded. That means definitely something is there beyond bacteria. So before managing and diagnosing this patient of osteomyelitis, our etiology should be clear in mind. So among the etiology, infection is very known to all. Among infection, bacteria is familiar to all. Tuberculosis is always on the back of the mind. What we miss in daily practice is the unusual organism and fungus. So once you are getting any unusual organism or fungus, it is nothing other than any inborn error of immunity like MSMD, CGD, or secondary immune deficiency. Some tumor like osteoma can present with this kind of manifestation of bone pain and fever, but tissue biopsy and typical imaging features can differentiate it from bacterial osteomyelitis. What we miss, that is inflammatory bone diseases like CRMO, DIRA, and Majeed syndrome. So today in my talk, I will cover these mainly inflammatory diseases. So once a child is coming with fever and bone pain, we should not be stuck with preoccupied diagnosis with bacterial osteomyelitis or tubercular osteomyelitis, because children can present with this similar manifestation having diagnosis of leukemia, histiocytosis, metastatic deposit, primary immune deficiency, metabolic bone disease, and some inflammatory bone disorder. So from different angle, now we can see, once we took the history properly and examined the children, 6 patients had different past history, 6 patients had different clinical findings. So today, I will not touch the bacterial osteomyelitis because I know this is very known to all, and this is not the ideal forum for discussion the malignancy-related inflammation in the bone. So I will discuss only the inflammatory bone diseases. So among these, first I am going through CRMO. So chronic recurrent multifocal osteomyelitis occurring primarily among the children and adolescent. Most of the time, it is misdiagnosed as bacterial osteomyelitis, and there is a gross diagnostic delay. So basically, this is a diagnosis of exclusion. Though it is named as chronic recurrent multifocal osteomyelitis, neither it is always multifocal nor recurrent. So basically, this is under the umbrella term of chronic non-bacterial osteitis or chronic non-bacterial osteomyelitis. It may be recurrent multifocal or unifocal, it may be persistent multifocal or unifocal. So what is leading to this CRMO? So initially from the first description in 1972, it was thought that some infection is playing role behind CRMO, as in first few cases, Staphylococcus aureus and Propionibacterium acne have been isolated from this patient, especially from the pustules and acne. However, in the last 50 years, we have noted there is no relation with the infection. Until now, no antibodies have been isolated from this patient, so it's unlikely to be an autoimmune disease. So basically, this is a disease of innate immune system. There is a gross imbalance between the anti-inflammatory and pro-inflammatory cytokines, leading to accelerated osteoblast differentiation and activation, and finally, osteolysis and bone remodeling. Here you can see in the left side, in bacterial osteomyelitis, there is an infiltration of neutrophils throughout the course. These are red. But in inflammatory osteomyelitis, initially there is some neutrophil, but over the time, there is a change, like some lymphocyte and macrophage, and over the time, they become histiocytes and some fibrotic tissue. So how will diagnose a child with CRNO? So there is some criteria, including some major criteria and minor criteria. In major criteria, there are some typical imaging features, typical histological features, and clinical features. In minor criteria, consisting of the duration of the disease, the family history, the associated clinical condition, and blood parameter. So if your child having any 2 major criteria or any one along with 3 minor criteria, you can diagnose your child as CNO. Other than this, there is another criteria, that is Bristol criteria. If your child is presenting with typical low-grade fever and bone pain, and you are getting typical imaging features on bone marrow edema on MRI, you can diagnose a child with CNO. And also, if there is a multifocal lesion and the inflammatory markers are very low, this is a probable case of CNO. So these are common among the girls in comparison to the boys, commonly seen in between 7 to 12 years of age. Once you are getting or suspecting any child of CRMO below 2 years of age, always you should exclude the monogenic form of other autoinflammatory bone disease like DIRA and Majeed syndrome. So how will they present? They will present just like bacterial osteomyelitis, like they will have fever, malaise, weight loss, multiple site bone pain, tenderness, erythema over the painful site. The difference from the bacterial osteomyelitis is that the fever spike is not that higher like bacterial osteomyelitis, and the patient are not sick like bacterial osteomyelitis. They will present with indolent and unpredictable course of remission and exacerbation. 1/4 of the patient will have ankylosing spondylitis. And a subset of the patient with CRMO may present with inflammatory bowel disease, psoriasis, and severe acne. So as it is multifocal, which bones are commonly involved? So from this picture, we can see any bone in the body can be involved, from mandible to clavicle, spinal bones, pelvis, and long bones. However, the most commonly bone involved are long bones. Though it is multifocal, 1/5 of the patient may have unifocal lesion. Now the question is that which part of the bone is involved? Here you can see that typical lesion in CRMO is metaphyseal lesion. It may be sometimes metaphysio-epiphyseal or metaphysio-diaphyseal. Is there any typical pattern to involve the different bone? So the most common pattern is tibio-appendicular. The long bones are involved. Sometimes there is involvement of clavicle and vertebrae, and the rare variety is both flat bone and long bone involved at a time. So how will diagnose? So you have a child with recurrent painful sites with low-grade fever. You are getting normal inflammatory parameters. You are suspecting CRMO. You do MRI. You are getting some edema. To identify the subclinical lesion, the whole body MRI or whole body imaging is required. I will discuss later. The important thing, when to do biopsy, because it is very difficult to convince the parent to do bone biopsy in our setup. So once you are getting solitary lesion, the lesion over the unusual site, the lesions are atypical, you must go for tissue biopsy to exclude malignancy, unusual organism, and inflammatory bone disease. If you are getting multifocal lesion and this on the typical sites, you can start the therapy and do follow up the child. In the histology, you can see here, in bacterial osteomyelitis, there is neutrophilic predominance, and in inflammatory osteomyelitis, there are few neutrophils with background of sclerotic and fibrotic tissue. Now, regarding the imaging modality, all kind of imaging modality is helpful to pick up this bone lesion. With simple X-ray, you can pick the sclerotic, lytic, and hyperostotic lesion. However, in the earlier stage of the disease, the X-ray can miss this lesion. It is better to avoid CT scan due to the high radiation exposure. Bone scan is good for picking the spinal lesion. However, they are unable to pick the small bone lesion. MRI is actually good. It picks 100% bone marrow edema, and it is much better than bone scan in picking the small bone lesion and spine, and it can also detect the soft tissue involvement. So here you can see on MRI of a child. In this picture, you can see one child presented with left knee pain. In MRI, detected edema over the upper end of left tibia. He also had edema in the lower end of the right femur, left sacroiliac joint. Middle one is the diffusion-weighted imaging, diagnosed some subclinical lesion over the spine, and the extreme one is the STEER MRI, who detected the soft tissue involvement along with the spinal lesion. So how will we manage? As it is an inflammatory disorder, naturally the child needs some anti-inflammatory or immunomodulator. So what we do, we start the child with NSAIDs and corticosteroid. If there is a response, it's fine. If there is no response and this is refractory, you can go with the DMARDs like methotrexate and sulfasalazine. In cases of severe disease and multifocal lesion, you can start with the TNF inhibitor. But in cases of spinal involvement, it is better to start with bisphosphonate to prevent the compressive spinal fracture. So there is a time constant, so I will not touch much on this disease. So other than CRMO, there are few diseases like autoinflammatory syndrome. So these are all monogenic disease. So I am telling because they present with some prototype features. So if I tell, you can pick much patient with this, but this needs lot of literature search and exclusion of other common diseases. So DIRA present from the neonatal period with typical clavicular osteomyelitis. They will have pustules and ichthyosis. Mojs syndrome present within the first 2 years of life with any bone involvement. They may have splenomegaly, history of blood transfusion. Papa can present in the late childhood with any bone involvement. They have pyoderma gangrenosum and acne. Cherubism is very rare but interesting disease with mandibular involvement. So here you can see one picture of patient of DIRA, typical involvement of the medial end of left clavicle. He had also pustule and ichthyosis. And another picture is the bilateral mandibular osteomyelitis, that is patient of cherubism. So as these patients are diagnosed late, naturally they will have some complication. Now who are prone to this complication? So more the recurrence, more the chances of complication like limb length discrepancy, thoracic outlet syndrome, spinal cord compression, kyphosis and scoliosis. Now who are prone to develop recurrence? So those are boys had increased ESR at presentation, vertebral and jaw involvement, and more chances for recurrence and complication. Now finally I am coming back to these 6 cases for diagnosis. The case 1 had no past history and no other findings other than tibial involvement and responded to antibiotics. So naturally, it is typical case of bacterial osteomyelitis. Second case has mandibular involvement, had history of PRBC transfusion, associated finding of splenomegaly. So probably we are dealing with Majeed syndrome. Third case is upper end of tibial involvement with previous history of recurrent infection and scar mark on neck indicative of some incision and drainage for abscess. So possibly we are dealing with some PID. But the child didn't respond to antitubercular therapy and antibiotics, so probably etiology is different like fungal infection in PID. Fourth case, involvement of clavicle along with typical presence of acne and skin pustules, so probably it was a case of DIRA. Fifth one, history of tibial osteomyelitis, similar femur osteomyelitis 1 year back, so probably it is a case of CRMO. And the last case has vertebral involvement with the previous history of pulmonary tuberculosis. And there is an ugly BCG scar that is suggestive of some combined immunodeficiency like CGD, MSMD, or some combined immunodeficiency CGD and MSMD. As the child didn't respond to antitubercular therapy and antibiotic, again we are dealing with something unusual organism. So it may be NTM in non-tubercular mycobacterium in MSMD. To conclude my session, all osteomyelitis are not bacterial, autoinflammatory bone diseases and CRMO remain under-recognized. Children not responding to antimicrobials or with any atypical presentation needs evaluation. Tissue biopsy and radiological imaging is crucial for the diagnosis. So thank you.
Any questions from audience?
But from the pathologist's point of view, monostotic or polyostotic, when we are called in, the commonest diagnosis is Langerhans cell histiocytosis.
Yes, sir.
In a pediatric population.
We should not miss it. Yes.
So that is what, with or without eosinophils, that is the commonest that we see in our daily practice.
Yes, sir.
Thank you, sir. Any questions?
Any more questions from the audience? Yeah.
Okay. Thank you, Dr.
Thank you,
Dr. Mondal.
Thank you,
Sanjeev Mondal, for adding the existing knowledge, few things. I have experience in by call from the orthopedics department. The surgeon was ready for the second time operation for osteomyelitis as a different site. It is a good message to them, but to us also, when we call for that, to the consider and to the exclude the autoinflammatory and the autoimmune disease also. Specifically, if there is a history, family history in such as cases, and if it is associated at the abnormal site. Sir, please.
One more thing I would like to stress over here is technically the need for an whole body MRI.
Yes, sir.
That is what I think was mentioned over here. And once you do that, you can definitely have a look, and it helps us to cleanse the diagnosis of CRMO in one way. And one more thing, I think what you mentioned over here, bisphosphonates, they definitely have a technically have a role in vertebral presentation of CRMO, because if you had a vertebral some issues, collapse or something like that, then it will not recover. So in those cases, it is technically preferable to intervene as soon as possible and to prevent any vertebral collapse. So
yes,
that's the point. Thank you, Dr.
Thank you.
Thank you. Thank you all.
Up next, I would like to call upon stage our presenters. We have the paper presentation right now. We had 50 abstracts which we received, and they were blinded and sent to our 3 judges, Dr. Abhishek Sharma, Dr. Murangam Sudhakar, and Dr. Satish Langanathan. And I would like to go through the rules once again. 5 minutes would be for presentation. First bell would be at 4 minutes. The final bell would be at 5th minute, and 2 minutes for question and answer. Please maintain your time, or else it may carry a negative marking. I would like to call on stage our judges, Dr. Arup Kumar Kundu, ex-visiting faculty in internal medicine and consultant rheumatologist in Archikar Medical College. President of East Zone Rheumat Association 2024 to 2026, and Dr. Vijay Vishwanathan and Suma ma'am.
So if we can call the first presenter, Dr. Ria Kalai, who's going to talk about safety and efficacy of intravenous tocilizumab in pediatric rheumatological illness, an update from a tertiary center.
A very good afternoon to everyone present here. I'm Dr. Ria Kalai from IPGMR SSKM, and today my topic of discussion is safety and efficacy of intravenous tocilizumab in pediatric rheumatological illness. So as we all know, tocilizumab is a monoclonal antibody primarily used to treat inflammatory and autoimmune conditions. It targets the interleukin-6 receptor, blocking the activity of IL-6, which is a key cytokine involved in the inflammatory process. The recent guidelines recommend the upfront use of IL-6 blocker in systemic juvenile idiopathic arthritis. There has been no study regarding the safety and efficacy of tocilizumab in India yet. So the goal of the study is to provide an overview of the current evidence assessing the therapeutic benefits of tocilizumab while addressing the potential risks to inform clinical decision-making and optimize patient care. Coming to the methodology, it's a retrospective observational study conducted in the Department of Pediatric Medicine in IPGMR SSKM Hospital within a time period of 32 months, that is from July 2022 to March 2025, with the inclusion criteria being patients receiving intravenous tocilizumab. As we all know, SGIA is a diagnosis of exclusion. So it was diagnosed as per the ILR criteria. And the dosing of tocilizumab in SGIA, like pediatric patients, pediatric SGIA, with a body weight more than or equal to 30 kg, they get 8 milligram per kg IV tocili, and a body weight of less than 30 kg, they get 12 milligram per kg IV tocili. Provided that, first of all, we rule out TB in these patients before administering tocilizumab. Previously, tocilizumab was administered as IV 2 weekly for 10 doses, followed by 3 weekly for 10 doses, followed by 4 weekly for 10 doses. However, after November 2024, as per the new guidelines, tocilizumab was given IV every 2 weeks for 6 months, followed by every 3 weeks for 3 months, and then 4 weeks for 3 months, gradually tapering or withdrawal of tocili, provided patient maintains clinically inactive disease. In parallel to tocilizumab, all patients were continued on methotrexate and steroids were gradually tapered on OPD basis. Coming to the results, we have studied the profile of 17 patients, out of which 9 were female and 8 were male children. The median age of diagnosis being 4 years, and the median interval between the onset of symptoms and diagnosis were 5 months. Indications of tocilizumab in my 17 patient profile included SJIA and autoinflammatory diseases. 15 patients were a diagnosed case of SJIA, out of which 1 patient received tocilizumab as a first-line therapy, 13 patients received tocili as a second-line therapy, and 1 patient was a refractory SJIA case. 2 patients were diagnosed with NLRP12 and NLRP1 mutations, which fall into the autoinflammatory disease category. This table outlines the drug efficacy outcomes of my 17 patients. So the efficacy determinants here are the remission, relapse, and failure. 8 of the patients maintained remission. The remission was determined by the JADA-10 scoring. And the 7 patients had relapse, which were either systemic or arthritic or both. And 2 patients had failure to treatment, and they succumbed to death due to complication of MAS. The safety of drug was assessed by documenting the side effects like drug reaction, infections, neutropenia, increased liver transaminases. And from my study, 2 patients had infections, 2 patients had transaminitis, and 2 patients had torticollis, and none of them had neutropenia and transfusion reactions as such. So there are 2 limitations of my study. First of all, it's a small-sized single-center study. Second, it's a retrospective cohort. To conclude, tocilizumab demonstrates safe and efficacious in children with SGIA, as it reduces the disease activity and improves patient outcomes. That's all. Thank you.
Very interesting study and timely. What were the problems that you saw?
Ma'am, the problems we saw were, first of all, can you just give the slide? Ma'am, first of all, when the patients arrived to us, were like in a delayed stage, like when the first symptoms appeared and the time they arrived in our OPD or emergency were almost like 4 or 5 months gap, and some even like were in already mass. So then 2 patients of them, they went to mass. So like people, like the children, they were already in the complicated state. So like there's a delay in diagnosis, like higher centers, like people, these children were first, they first visit the primary centers. So there's a gap in the...
I meant problems with tocilizumab that you saw in the study.
Problems with tocilizumab, in our patients, we saw infections, like 2 children, they had infections like cellulitis and viral hepatitis, and one of the patient also had varicella. And 2 patients also had transaminitis during the treatment of tocilizumab. And then torticollis was the like next very common complaint the mothers were saying, like in children. So like these are the side effects that I have found in my like 17 patient profile.
No transfusion reactions, you're lucky. Vijay?
It's a nice study. Any particular reason you chose only IV tocilizumab, or you just collected the IVs that you have given? And in the current situation, would you be giving more preference to a subcutaneous tocilizumab, which is less logistic issues?
So I would prefer IV tocilizumab only, and the patient I have collected were only based on IV tocilizumab administrations.
Okay. Thank you.
Thank you.
If we can call the next person, Dr. Rifa Khan, who's talking about the clinico-pathological profile of renal involvement in IgA vasculitis in the pediatric population, a prospective study from tertiary care in Eastern India.
Ma'am, I would like to make an announcement right now. After our paper presentation, we will start with our e-poster presentation. So all those delegates who have a e-poster presentation can gradually proceed to the poster hall for presentation.
Good morning to all my respected seniors and fellow doctors. Myself Rifa Khan from Institute of Child Health. Today I am presenting a study on clinico-pathological profile of renal involvement in IgA vasculitis in pediatric population, a prospective study from tertiary care center in Eastern India. Henoch-Schönlein purpura or IgA vasculitis is the most common systemic vasculitis in childhood, with kidney involvement ranging from 20 to 54%. Currently, there is lack of long-term prospective data about HSP nephritis in pediatric population, especially in the developing countries. So the primary and objective of our study was to describe the clinical feature, histopathological findings, treatment details, and long-term prognosis of the disease. We also wanted to evaluate the prognostic factors of the disease. It is a prospective observational study with study population of children with biopsy-confirmed HSP nephritis visiting OPD and IPD of Institute of Child Health. Inclusion criteria included all children below 18 years who had biopsy-proven HSP nephritis, while children with all other vasculitis-associated nephritis, while suspected case of HSP who did not agree for biopsy were excluded. The study took place in Institute of Child Health. So if we see for the results, we started the enrollment of our study since August 2022, and since then 62 cases of HSP have been encountered. 35 cases screened positive for HSP nephritis, out of which when biopsy was done, biopsy confirmation of IJ vasculitis nephritis was seen in 26 patients. The median age of the patient was around 10 years, while there was slight male preponderance of about 57% males. So if we see the clinical features, all of our patients see the clinical features. Among the extrarenal manifestation, all our patients showed skin manifestation in the form of skin rash. Around 70% of the patient had abdominal complaints such as pain abdomen. Out of that 70%, 47% patient had GI bleeding, while 33% of the patient developed arthralgia, and only 23% patient had arthritis. One of our patient had epididymoarthritis. So this was the all extrarenal manifestation. If we see the renal manifestation, all of our patient, 100% of our patients showed proteinuria, but nephrotic range proteinuria was present only in 33% of the patient. So 1/3 was nephrotic range proteinuria, while 2/3 of the patient had subnephrotic range proteinuria. Microscopic hematuria was seen in 44%, and gross hematuria was in 33% patients. Hypertension was also present in about 1/3 of the patient, and 1/3 patients developed AKI on presentation. So at the onset of HSP, nephritis was present in 48% patients, while a median interval of 3 months, rest 52% patient developed nephritis. So if we see the ISKD classification, most of our patients lied in class 2 and class 3. So 52% of our patients were in class 2, 42% of the patients were in class 3, while 8 and 8% were in class 1 and 4 respectively. If we see the treatment modalities, ACE inhibitors received by all of our patients, steroid were given in 88% of the patient, methylpred was prescribed in 58% of the patient, and 42% patient received cyclophosphamide. We also gave MMF to about 23% of the patient. So on the follow-up, if we see ISKD classification 2, at the onset, only 1 patient had nephrotic range proteinuria, 3 patients had AKI, 6 patients received methylpred, cyclophosphamide was received by 3 and MMF by 2. In class 3, 6 patients had nephrotic range proteinuria, AKI was in 3 patients, and methylpred was given in 5 patients, and cyclophosphamide was given in 4 patients. At the end of the 6 months in class 2, none of our patients had significant proteinuria. EGFR reduced EGFR, and significant proteinuria was seen in 1 patient that came up as flare. While in class 3, 1 patient was lost to follow-up. He came only after 1 year with reduced EGFR and proteinuria. In follow-up, at 6 months follow-up, reduced EGFR was seen in 3 patients. Subnephrotic proteinuria was seen in 4 patients. Microscopic hematuria was seen in 2 patients. 3 patients, steroid was stopped, and recurrence of hematuria was seen with URI was seen in 3 patients. At 1 year, only 1 patient had reduced EGFR. Subnephrotic proteinuria was seen in 3 patients, and steroid was stopped in 11 patients, and recurrence with hematuria was seen in 3 patients. So we had, since it's a long study, and we are currently going on with long-term follow-up, we have not done any statistical analysis of the follow-up. So that's why this data is in numbers. So this is an ongoing prospective observational study. Currently, not much prospective data has been available in the term of long-term follow-up. A long-term follow-up will obviously help in understanding long-term outcome of the HSP nephritis. Thank you.
Just two questions. How did you define proteinuria in this kid, and when did you do a biopsy? What level of proteinuria? Was it just a PC ratio or a documented 24-hour protein? Question one. Question two is, you said many of these kids or a few kids developed proteinuria later. What's that later thing, and what was your time frame for the biopsy?
Sir, the proteinuria for biopsy that we take is nephrotic range proteinuria. If we have, we go for biopsy.
Which is?
Which is UPCR more than 2, because 24-hour urine collection is little bit difficult. Early morning UPCR we take. And if subnephrotic, that is from UPCR is 1 to 2. If it's more than 2 to 4 weeks, we'll go for biopsy. And if mild proteinuria is for more than 4 weeks, we'll go for biopsy. Or there is reduced GFR at any stage. That is less than 90 ml per 1.73 meter square, sir.
So you are telling me that all proteinuria more than 1?
If more than 1, if it's more than 2 to 4 weeks, not resolving, sir.
After this study, what is your message to your junior colleagues?
Okay. Sir, HSP nephritis, it's first of all the type of, we are a developing country, sir. So in peripheries, there's not much data is available for other people for the long-term follow-up, like how to follow these patients, what is the long-term outcome. So we wanted to do this study to see, like a patient is coming for HSP nephritis, we are giving the treatment, patient is in remission, but what after that? How is the patient going to do in 4 years, 5 years or 6 years? So if patient is landing in like CKD, if he's resolving with a good return of the kidney function, so we wanted to see that.
So it is an ongoing study?
Yes, sir.
Okay.
Yes, sir. Because it's a long-term study. It started in August 2022.
Sure.
We are still following up.
In some cases, immunological reaction to streptococcal infection. This penicillin prophylaxis is helpful in some cases, at least in those cases where ASO titer is raised. It was advised by one of my teacher, and there was no textbook recommendation. Can you highlight on this subject?
Would you like to take that comment?
Any comment?
So we haven't encountered with any such cases in my study. Although it is documented, what I have read about the studies, it is documented in parvovirus, streptococcal virus and other infection also. So basically it's an immunological disease. It can happen after any infection. The IgA vasculitis mainly happen because of the glycogen deficient, the IgA formation. So that for that autoantibodies IgA forms that attacks the immune complex, and then C3 activation and membrane attack complexes, all those forms. So it may happen with the streptococcal infection, but in my study what I did, I may not have encountered any such cases.
At least ASO titer may be checked. If it is raised, then it may be given penicillin prophylaxis.
I think 20 years back, there was a statistic that 35% of IgA vasculitis could be streptococcal triggered. Today, probably it's other bugs, but clearly we do see IgA vasculitis in crops. So there is an infection trigger that is triggering these patients, though addressing the infection may not be the way forward therapeutically. There's one question there.
No, not question. That is just a comment on the SIRS. So there is no such recommendation presently regarding giving benzathrin penicillin prophylaxis. If previously it was given in PSGN cases, but in HSP there is no such recommendation, sir.
That's right. Yeah. Okay, we'll end this session. We'll call the next person, Dr. Natasha Lalbiazuali. I hope I've got your name right. Doing an observational study of children with gastrointestinal manifestations in Hinox-Schönlein and purpura treated with single-dose cyclophosphamide. Can I just make a comment? I'm so glad to see all these studies coming out on HSP. Extremely common disease and so little objective work for us to see.
Good afternoon, everyone. Good afternoon, respected judges. Good afternoon, esteemed guests. So today, my topic is on observational study, cyclophosphamide for severe GI involvement in henoch-Schnoelen purpura. Hi, my name is Dr. Natasha Lalbiak-Zwali. I'm a second-year PGT, and the main hero, must mention Dr. Priyankar Par, Dr. Jiknadi, Dr. Ravali, Dr. Anandita, and Dr. Ria. Without them, it would have not been possible. Thank you. So coming to it, henoch-Schnoelen purpura. It was formerly known as HSP, and now IgA vasculitis. Why? In 2012, in International Chapel, they have mentioned that they have redefined, they have put in IgA vasculitis, mainly because it is the mainstay in the histopathology. Now, it mainly affects, as we all know, small cell vasculitis. The classic tetrad, we know, purpura, arthralgia, abdominal pain, and renal involvement. But what about the criteria? The criteria, if we know in European rheumatology and pediatric rheumatology, ULRI, which we know, and in Pediatric International Organization trial, in which they mention mandatory is purpura, and any one of the four, which can be histopathological leukocytic vasculitis, arthralgia, and along with abdominal pain and the renal involvement that include proteinuria and hematuria. Now, my main thing is GI involvement. So in here, what can we manifest? As quality pain, abdominal pain, interception, hemorrhage, and even leading to perforation. Now, we all know the first line of treatment in which we get, then we will start with IV steroid. First line in severe GI involvement. Now, yes. Now coming the rationale for study. Why are we doing this? As we know, they are already in severe form. So we can see the patient are already affected that lead to submucosal edema that affects the internal absorption and often impair the GIA. And along with now, cyclophosphamide. What is a cyclophosphamide? We all know it is an alkylating agent, cytotoxic immunosuppressant, and only used in severe vasculitis. Now, it is evidence limited for single dose. If we know, we have seen this in other papers also, in which we have seen 2013 in Turkey, 2015, and in 2018 in Italy, where they have done similar studies using cyclophosphamide, a single dose in GI HSP. Now, what is our main aim? Our main aim is to evaluate the effectiveness of single dose in IV cyclophosphamide, in which steroid-resistant GI bleeding. What is our method? Our method type is retrospective observational. Actually, why we went for the retrospective? First of all, we did not expect that we'll have these kind of studies. And second, within our limit time and limited numbers of patients. Now, the population which we had was around 8 children, and we intervened by single dose of cyclophosphamide. Now we see, we had 8 patients, which contains 6 boys and 2 girls. And the cyclophosphamide timing, median day 12. We'll be asking, why median day 12? Again, this was not pre-decided. We waited for the response of the oral steroid, and also we gave the time for the treatment to occur in giving IVs steroid in a high doses for at least 3 to 5 days. We gave the timing. Now result, the beautiful result. All 8 of our patients responded to the single dose of IV cyclophosphamide with no further GI bleeding and the pain abdomen within the 48 hours of administration. Now, side effect. It won't be, we must also see the side effect. What are the side effects that we saw in our, okay, so we gave cyclophosphamide. At the same time, we have to be cautious. So what did we do by caution? By giving a proper hydration along with mesna. So what this mesna do? It helps in binding the toxic metabolite of the acrolein and preventing the hemorrhagic cystitis. Yes, and gonal toxicity infertility. We must counsel all our patients. We counseled all our patients by the possibility, but we know it has very minimal risk. And in all our studies, we did not find where there was studies of the infertility. And yes, the best thing is about this is a single dose that contains very less. And in studies, so far it's 8 gram. And bone marrow suppression. So we took into very consideration if they had even one spike of fever, vitals monitoring with any blood count parameters were taken very seriously. And in the only thing we saw was alopecia, in which there was reassurance and hair growth.
Conclusion, single dose of IV cyclophosphamide effective in severe steroid refractory GI involvement, which was well tolerated with minimal adverse event, which avoided surgical intervention and it could be a potential alternative in severe refractory cases. As we know our limitations, sample size, retrospective design, and no control group. And it would be amazing if we have more of our studies in multi-center trials along with RCT that would have been the gold standard. Thank you.
That was very energetic presentation and a very, very valid topic. I have two questions for you.
Yes, ma'am.
The first question is, what were the ages roughly of the patients whom you gave cyclophosphamide to? The second question is, did you check factor 13 levels on these patients?
Did you check?
Factor 13 levels on these patients because we know that with IgA vasculitis, patients can have a factor 13 deficiency, which can exacerbate the duration of and the severity of gastrointestinal vasculitis.
Thank you for your question. Ma'am, first of all, the age that were for 6 to 12 years old. And 6 to 12 years, although we know that mean peak age is around 4 to 6 years. But in our cases that present with severe HSP that leading to GI manifestation, which we saw was 6 to 12 years, 6 to 12 years. And for your second question, ma'am, for factor 13, we checked 2 of our patients, 20%, but the rest of the other patients we did not check. And in 20%, only 1 of 10% showed the factor 13 deficiency.
Thank you. Great. Thus, one more thing. So all your patients are below 12?
Ma'am, 6 to 12.
Okay. So no adolescents per se in the
Yes,
who
ma'am.
receive cyclophosphamide?
Requiring cyclophosphamide.
Because I would like to take up that one thing you said about very low risk of gonadal toxicity.
Yes, ma'am.
If you had a 15-year-old patient, a boy, or a 15-year-old patient, a girl,
yes, ma'am.
With the same situation, which patient would you counsel the family about the potential of a gonadal toxicity with the single dose? I would not refuse the idea to give cyclophosphamide, but which patient would you counsel the parent about the potential?
The one with the higher age.
The 15-year-old boy and a 15-year-old girl.
Ma'am, I will counsel them both because gonadal toxicity is present, and in female, again, we can say the fertility is there.
Okay. It's a 15-year-old boy. For a 15-year-old girl, we have cumulative doses that are significant. In a
Yes,
15-year-old boy, even a single dose,
can be
an adolescent
significant.
boy who has already started spermatogenesis, a single dose also can cause damage.
Okay. Thank you, ma'am.
Thank you. Next patient, next person, Dr. Aninditya Nandi, with a presentation on chronic recurrent multifocal osteomyelitis.
What is the highest stage till when the henoxolone purpura may occur?
90% of HSP occurs below the age of 19 years.
Good afternoon all. Today I'm going to present a case series of chronic recurrent osteomyelitis, which is also known as chronic non-bacterial osteomyelitis, which is a rare autoinflammatory bone disease affecting children and adolescents, characterized by multifocal, often symmetric bone lesions with episodes of exacerbation and remission. Diagnosis is often delayed as there is no definite diagnostic criteria and it mimics infection and malignancies. And MRI is the gold standard. So in our retrospective analysis of 5 patients, we diagnosed them on the basis of mainly history supported by radiological evidence and blood reports. Remission was defined as resolution of the symptoms and normalization of the X-ray, sometimes supported by MRI whenever possible. Our aim was to understand the clinical course, treatment and outcome of the disease. So in our cohort, the median value of age at diagnosis was 11 years. Delay in diagnosis was 1 year with a range of 6 months to 2.5 years. Pain and swelling being the most prominent clinical features. None of the patient has any systemic features, and lower limb bones was the most commonly involved, with tibia fibula in 4 cases and femur in 2 cases. The clavicle and vertebral involvement, which is classic of this disease, was found in 1 patient. All the patients received multiple doses of antibiotics before diagnosis. 1 even had 18 months of anti-tubercular drugs. And diagnosis, previous diagnosis was infectious osteomyelitis in 3 cases, Ewing sarcoma is 1, and vertebral tuberculosis in 1 case. So this is some clinical features. This is showing the left leg swelling and the ankle arthritis. And one patient had swelling and tenderness on the left clavicle. Laboratory investigations, the median value of hemoglobin was 11.2, total count was almost normal. We had mildly raised DSR in 1 case with a median value of 29, and CRP was mildly elevated in 1 case with a median value of 3. So these are some X-ray of the affected parts, mainly showing sclerotic lesion with periosteal reaction, sometimes in the diaphysis of the tibia, metaphysis of the bone, and one patient also had a lytic lesion on the medial end of clavicle. Biopsy, bone biopsy was done in 2 patients to exclude malignancy and infection because these 2 had some local lesion at the diaphysis of bone, single bone, which showed inflammatory, chronic inflammation only, culture was negative. MRI was done in all, which is actually the confirmatory, showed marrow edema, soft tissue edema, etc. Whole body MRI was needed in 2 patients, which showed multifocal disease. So these are some MRI picture of the affected part. Predominant features was symmetrical marrow edema, sclerotic lesions involving diaphysis, metaphysis. One patient also had collapse of the 2 vertebral body, D5 and D12. Whole body MRI saw involvement of the multiple sites, and diffuse FDG uptake was seen in 1 patient in PET scan. So we gave NSAID in all our patients, and 3 patients in addition need bisphosphonate. Outcome was satisfactory with a median interval of clinical remission being 4 weeks after starting treatment, and radiological remission, that is X-ray remission, median time was 3 months after starting treatment. And our follow-up period was 18 months. 1 patient had relapse that was treated with NSAID successfully. So we compared the cohort with the other data. Our had a male preponderance, which is similar to another 2 Indian studies, whereas some Western literature show female preponderance as well. And our mean age at diagnosis was 10.8, which is almost similar to other studies. And our response was very good with the NSAID bisphosphonate. We did not require any other medications. So limitation, definitely it was a single center study with a small sample size. Whole body MRI could be done in 2 patients only. So in conclusion, I want to say the CRMO should be suspected in chronic osteomyelitis not responding to antibiotics. Absence of systemic features with near normal inflammatory markers should raise the suspicion. Raising the awareness is very important because early diagnosis and indicate better prognosis, and to avoid prolonged unnecessary antibiotic use, radiation exposure, invasive procedures. Response to NSAID and bisphosphonate is good, and CRMO can have recurrent course, so long-term follow-up is important. Thanks to my whole department, my patients for supporting, and definitely my mentor, Dr. Priyankar Pal sir, without whose support it was not possible.
What are the level of CRP in all of your cases?
Sir, this is the CRP level in my case. Yes. The normal value was less than 5, so one case has only one case, that is case 4 has 9.5, all has normal CRP. And ESR was also mildly raised in 1 cases with a 72 value, case number 5. So median value was, actually cases did not have any systemic features, they have bone pain, swelling, and with that almost normal inflammatory markers.
Normal.
Yes.
What are the indications of bone biopsy in your
Yes, sir. We did bone biopsy in 2 patients because they had focal disease. Multifocal involvement was not there. So to exclude malignancy and infection, we did bone biopsy in those 2 patients, which was suggestive of chronic inflammation only.
Was it the case 5 that relapsed?
Yes, sir. We have 1 relapse.
Because I thought...
Yes, 1 relapse which successfully treated with NSAID and responded with X-ray improvement within 4 months.
So the reason I ask you is that's the only kid with ESR of 72. So...
Yes, sir.
Are you...
High inflammatory markers, always there is a chance of relapse.
And was there a reason why you chose only an NSAID, or you just got lucky that NSAIDs worked this time around?
Sir,
when the same kid had received...
We cannot say because this patient responded to NSAID also. We did not add any other treatment. Thank you, sir.
What was the duration of NSAID treatment?
Pardon, ma'am?
The duration of NSAID treatment in your patients.
Okay. Medial duration in our study was response within 4 months with X-ray improvement, whoever responded. And who did not improvement clinically and radiologically, we went for an bisphosphonate. And all patients responded to that. Thank you, ma'am. Naproxen, sir. Only naproxen.
Okay, I think we will go to the next presentation. Thank you very much. Useful study. Now I welcome Dr. Shantanu Jana, who's doing a study on the usage of intra-articular triamcinolone hexacetonide in patients with JIA.
Good morning, everyone. I'm Dr. Shantanu Jana from Institute of Child Health, Kolkata. I'm going to present our study on response to intra-articular triamcinolone hexacetonide in JIA. Now, treatment strategies in juvenile idiopathic arthritis aims to control inflammation, relieve symptoms, and improve quality of life. To achieve this, one such treatment modality is intra-articular steroid injection. These formulations usually have lower solubility, thereby their joint residence is longer and they have longer duration of action, thus having better efficacy. One such formulation is triamcinolone hexacetonide. Although it was the preferred intra-articular steroid globally, it has only recently been marketed in India. Now, our objectives were to determine effectiveness of intra-articular triamcinolone hexacetonide in reducing the pain, swelling, and restriction of joint movements in juvenile idiopathic arthritis by assessing time for the inflamed joint to respond, duration of remission, and safety. Coming to methodology, our study was a prospective observational study happened in Institute of Child Health, Kolkata in between January 2023 and June 24. Our sample size was 30. We included the patients of GIA who received intra-articular triamcinolone hexacetonide, children with polyarticular GIA, SGIA with disease-modified anti-rheumatic drugs or biologics with few active joints were also included. We excluded the patients with coagulopathy, systemic symptoms, and more than 4 active joints. Now coming to results, mean age of the patients were 8.4 plus minus 4.5 years, out of which 70% patients was less than 10 years. 53.3% patients having oligoarticular GIA, 16.7% patients had polyarticular or SGIA. Enthesitis-related arthritis was found in 13.3% cases. We injected total 43 joints, out of which the most injected joint was knee joint, followed by which wrist joint, then ankle joint, elbows, and lastly metacarpophalangeal and metatarsophalangeal joint in 2.3% of cases. Coming to response to arthritis, overall 89.2% of patients at the end of 6 months and 88.8% of patients at the end of 12 months had complete response. Now this is an excellent response we achieved. 3.3% of patients had complete resolution of symptoms at the end of 1 week. At the end of 1 month, 86.2% of the patients had complete response. The average time for complete response was approximately 3 weeks or 0.9 months. Among 30 patients, 33.3% were on methotrexate, 23.3% were on methotrexate and leflunomide, 16.6% patients were methotrexate and tofacitinib. 26.6% patients were not on any regular medications. 43.7%, that is a significant number of oligoarticular GIA patients, didn't require any additional immunomodulation following intra-articular corticosteroid injection. Coming to adverse effects, out of 30 patients, only 3.3% had adverse effect in the form of skin hypopigmentation at the injection site. Now, in terms of relapse rate, out of 43 joints, only 3 joints, that is 7.3% of joints relapsed at 6 months, and 2 joints, that is 7.6% relapsed at 12 months follow-up. Overall relapse rate was 7.46%. Now, this is comparison of our study with other internationally published studies. A study by Rana et al. Showed the response at 6 months in around 73%. Though this is a retrospective study and our response at 6 months was better, that is 88.9%. A study by Sirin et al., a retrospective study showed the response at 6 months. They have also adverse effect at skin atrophy and hypopigmentation. Now coming to a study by Julian et al., the most cited study showed a comparable response at 6 to 12 months, that is percent of joint responded, a double-blind trial study showed the relapse rate more than us. A unique feature of our study is that we didn't administer intraarticular injection USG guided. We used landmark-based technique for intraarticular injection, yet we achieved excellent efficacy and safety results. To conclude, our study showed that triamcinolone hexacetonide maintained an excellent efficacy post-procedure with 87.8% joints responding and in remission at the end of study period. It is worth pointing out that in majority of the patients, no major side effects were observed. To date, there are no data on longer follow-up results in children. Limitations of our study was this is a single-center study. All the 30 patients didn't complete follow-up of 12 months after the initial therapy. It was a subjective analysis. Standardized scoring system like JADAS or CJADAS were lacking. Our study is composed of a heterogeneous group of patients, including patients treated with methotrexate or biological therapy during the study period. Now, these are the references I have cited, though due to lack of space, there are many more. Thank you.
Question one, what dose did you use for the big and small joints?
It depended on the joint volume and age of the patient. We usually administered at a dose of 1 mg per kg in case of large joint and 0.5 mg per kg in case of small joints.
And what anesthesia did you use, or you preferred local and vocal like many
We
of
used
us
local
do?
anesthesia, sir.
And you think that the side effects in your cohort is slightly less as compared to the other ones?
Yes, sir.
You think some technical issues would be responsible for more skin atrophy, hypopigmentation? What I'm trying to say is, under USG guided, you think the side effects would have been lesser, or?
This might be a factor, but other studies showed that our results in terms of the adverse effects were similar or comparable to other studies. But definitely USG guided administration is desirable in these cases.
You got good pair of hands.
Thank you.
So, did you find the relapse rate according to the kind of JIA subtype? Was there any correlation?
Sorry, ma'am?
The relapse rate you put 7% or something. So
relapse rate, okay.
Yeah. So was that correlated with the subtype of JIA?
We actually subtyped. We had multiple subtypes of the JIA patients, like poly JIA with less active joints involved.
Was there any particular subtype where the relapse rate was higher?
In case of persistent oligoarticular JIA, the relapse rate was higher.
And is that because those patients were not on DMARDs at that time? That could explain why, according to the course of disease, as the effect of the injection weaned off, they relapsed. Could be just
Probably
based
due
on
to
that?
there were not any regular DMARDs, or they are not taking proper follow-up. But a significant portion of the persistent oligoarticular JIA having intraarticular steroid injections showed a good outcome.
Okay, thank you.
Thank you.
Normally, systemic JIA patients are the least responsive to intraarticular steroids. It's a good study. Thank you.
Thank you, ma'am.
Yeah, so the session is closed and we'll move on to the next session. Thank you.
Up next, we have our segment on steroids. When, how much, how long to, I would like to call up on stage our chairpersons, Dr. Shamur Ranjan Pal, Senior Retired Consultant from RKM Rheumatology of Internal Medicine, and Dr. Taposh Kumar Shabui, Professor of Pediatrics, Shantiniketan Medical College. He is also the current President of Indian Society of Kawasaki Disease. I would like to request all our e-poster presenters to please proceed to poster hall for presentation.
I think there is no need to introduce further Dr. Vijay Vishwanathan. He is from Mumbai and is a consultant pediatric rheumatologist at Jupiter Hospital, Thane. And he was the past president of Indian Society of Rheumatology Society of India. So, Dr. Vijay, stage is yours, please.
Thank you very much, Dr. Tapas, for the kind introduction, and I thank Priyankar and team for the kind invitation. And I have been given this enviable job of talking on steroids. I think there's a lot of commotion happening behind.
Hey, those who are standing, please, Archon, অনেক জোরে জোরে কথা বলছো, শোনাই যাচ্ছে।
Archan, I can take the lecture outside also. Just go and check how many people are outside. So when Jigna gave me the topic of steroids, and I often used to remember in pharmacology, the saying was that do not enter a pharmac exam without knowing how to give iron as a pediatrician. So as pediatric rheumatologist, I've never given it a thought that it's such a common thing, and yet you keep on doing things. So is steroid in 15 minutes, what is to be? So I thought this is a good way of, steroids are friends or foes. I normally would like to start all my lectures with this slide, and I won't talk much about the first 6-7 points which has been covered enough. What I think is important is whenever I go on a vacation for a conference, I have to sign a leave form, and then who do I feel as locum, So my friends used to joke, tu aane tak steroids are your locum. We'll give some steroids and buy time till you come back. And which is probably true, and the only difference is that we probably use steroids, but after explaining and with a rationale. I might bore you with this kind of a presentation that, when was steroids first started? So 1935 was when it all started. But then 1950 was when Dr. Hench and Kendall et al. Received the Nobel Prize for discovering steroids. And it's been 75 years, and it's quite interesting coincidence that we are having 75 years of our independence. Yesterday was Dr. Satyajit Ray's 104th birthday, and today is World AS, our ankylosing spondylitis day. It seems to be a Shubha Muhurat for many things. I promise that was the only boring slide that I would have given, right? So to start thinking, what do I tell about steroids? And if I write an autobiography, most of us, the millennials, would have grown up seeing this movie, for your own eyes only. For the Gen Zs in the crowd, this was a James Bond movie. And if I ever write a book, it will be for my eyes only. How many medical students in the audience? None of them. How many pediatricians in the audience? Quite a few of them, right? So the first word that all of us encounter in the medical college is idiopathic, right? Doctors are idiots, patients are pathetic, or vice versa. And so most things in rheumatology were deemed idiopathic initially to begin with. The next word which we learned, and we will always practice in our life, is iatrogenic, because most of the life we will be giving steroids and give medicines and think something works. The third word is sometimes a few of these kids do behave idiosyncratically. And the whole idea of today's exercise is not to be an idiot in front of the patients anytime we start in the future. So I thought if I could use these 4 I's and try to see where steroids fit in, it might be an easier way than a very boring lecture, right? So, in a nutshell, most of the things in rheumatology textbook, whether it's lupus or dermatomyositis or vasculitis, juvenile idiopathic arthritis, of course, we talked enough about HLH, MAS, autoinflammatory syndromes, all of them need steroids. And if I have to sum up the steroids, we can use high doses of steroids for rheumatological emergencies like a macrophage activation syndrome, an HLH, lupus crisis like a neuropsychiatric kid or a bad nephritis, dermatomyositis child who comes with palatal weakness, primary vasculitis, whether it's polyarteritis nodosa or Kawasaki disease, etc. And this immediately ensures that the disease is under control and helps plan further treatment. Then there is a role of bridge therapy where you want to give some time to the DMARDs to start working, and you may start using, once you give the pulse, give a 1 to 2 mg per kg, slow tapering. And then you have the low maintenance dose, which quite a few kids might need till the disease modifying drugs take effect. And we've heard about intra-articular injections in oligo-articular presentations from time to time. So this is, So this is one child who, how many of the pediatricians think that this child is sick? I thought there were many hands. Quick, quick, quick. Dr. Suma has to give an oration very soon. Sick or not sick? This child was referred to me by an endocrinologist saying that was referred to the endocrinologist with some joint pains, etc. and some parathyroid issues were there. But he said, तुम्हारे type का कुछ तो है. So I said, तुम्हारे type का या तुम एक type के हो, right? And very interestingly, this boy actually walked in with a T-shirt which looked like this. Now I have not photomorphed this because you can't photomorph a T-shirt which has JRA written in it, right? So how many of you think this is JRA based on what I showed you in the picture? You need a history. The volume, please. Volume, please. What's the diagnosis? This child hardly has any swelling, but so much of pain and discomfort. Someone who was attending the morning lectures. This looks like an infiltrate. So this was a malignancy, right? It's turned out to be a leukemia, which shouldn't have been given steroids for a start. So don't go by the T-shirt. The T-shirts can be misleading. This was another kid who was a 7-year-old boy who has pain throughout the day. We've seen in the morning discussion about labs. And this child had did not have morning stiffness, but didn't have nocturnal pains too. But his counts were 20,000, platelets were 2.5, CRP was 40, and RF positive. So we discussed that a 7-8-year-old has all the reasons to have RF positive JIA. He was started on steroids because RF positive is extremely erosive and poor response to methotrexate, right? And look at the WBCs and counts. You think it's normal? You want to add something, subtract something. Who was listening to my lecture in my panel? Whoever said ESR comes with me to Bombay. Yeah, he's my best friend. Okay, so let's give you the ESR. So this child was counts 22,000, 15,000, and when they came to me, it was 68,000. So no prizes for guessing what the diagnosis is because 75% lymphocytes and a platelet which is dropping and an ESR of 100 is a big, big problem. So where do you think the adult rheumatologist went wrong? I would like to say seeing a child of 7 years, but I would not enter into that territory. But the classic example that this child, again, if I start, you hardly see a swelling. It's more of a diffusely swollen ankle than a single swollen joint. And a big boy who's just, this is a child who is extremely in pain and do not diagnose a JIA purely based on rheumatoid factor positivity. Like we discussed, you have to document 2 occasions of RF positivity. If in doubt, throw in an anti-CCP, but never do a steroid. And the simple bedside test that you may do is an X-ray, which will pick up this metaphyseal band if you're lucky, because these areas reflect the the proliferative blasts which cause this kind of a changes. So when you have more of pain, less of swelling, please refrain from using steroids, right? Next slide. This was again covered in the morning. 3-year-old female, fever for 3 months. This was during the post-COVID time, right? Fever for 3 months, thigh pain, viral myositis was the label given because this child had thigh pain for some reason. Fever kept on happening, and then she was labeled as MISC, given IVIG steroids purely on the basis of COVID IgG. And still the fever persisted. The diagnosis got revised to systemic GIA. This kid's t-shirt actually had... This wasn't for me, right? I hardly started. Quickly went to Kerala on phone and came to Bombay through Dr. Suma. And quick, what's wrong in this child? Can you see anything? On the forehead, sorry. This child actually had a swelling on the forehead, which should not have been missed. And the only complaint that the parents came was pain, 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 pain. And see the blood test, platelets. Remember, rheumatologists in children, we are like Bata slippers. We like platelets of more than 2 lakhs, but 199 is a problem for me. And a 3-digit ESR in this child was a potential problem. You can't have viral myositis, and you certainly don't have MISCs anymore. Systemic GIA doesn't look like this, right? So that's where the idiocy part of it comes from. You know, when you start seeing a lot of pain and a 3-digit ESR, please do not use steroids and use everything with caution and try and analyze. So a simple imaging revealed a lot of the infiltrations below the scalp. What's this? This turned out to be another malignancy. Turned out to be a neuroblastoma, but then again the message here is whenever there is a lot of pain and a 3-digit ESR, please be very careful about giving steroids. I'm going fast. So that alarm was before the delay, right? Quick, the last situation, this child was again referred with lots of pain, went to the orthopedician, gave steroids, and he was still having pain on steroids. Remember, RF positive, however bad they may be, they have a brilliant response to methotrexate and steroids. A bad response to a high dose of steroid tells you that there is something really bad and sinister happening. This child was an ESR of 120 with severe pain in the lower extremities. Again, no swelling at all, but a lot of pain. And like the age-old saying, no, when the problem is in Kerala, find the solution in Kashmir. Just open the mouth. As pediatrician, we are trained to look at the throat. Today onwards, you will look at the hard palate for ulcers. And this is very classical gingival hyperplasia. And the diagnosis turned out to be an AML, right? The biggest crime you will do is to miss an AML. And the worst crime will be to start giving steroids without a biopsy. So this is the most important slide. When you see a synovium or a joint like it's seen on the left side of the screen, you will think that it is more of an articular swelling, or this is pure inflammation, will respond to steroids. But if you see something like the kid on the right, periarticular, this is a full proper diffuse dorsal edema, it's a periarticular pain. So it could be a bone pain, osteomyelitis, leukemia has to be ruled out, right? Okay, the second last scenario is idiosyncrasy and iatrogeny, right? Sometimes you start wondering, most of them, they look, yeah, we are doctors, we give medicines and we get better. But sometimes these things can go wrong. So idiosyncrasy happens from time to time. So it's not just rheumatology where we use steroids. This was a kid who was referred as a suspect Kawasaki disease. Fever for 6 days, rash, mucositis, abdominal pain, excessive sleepiness. You almost think there is something inflammatory happening in this child. But then the counts do not look very suggestive. It's a 7-year-old. And this was the kid, you know, he was having these tremulous movements and he was quite sleepy. And then you dig deep into the history. There is a bit of inflammation, a bit of transaminitis, and you dig deep into the history. To the pediatrician, it looked like KD, but then just spend 5 minutes with the history. It turns out that this child had some seizures. He was started on lamotrigine, and typically the dose was doubled, and that's the time when this kid got into trouble. That's what I mean by iatrogenic. The doctor gave the lamotrigine, increased the dose like they would normally do, but then this child was idiosyncratic enough to throw an adverse reaction to lamotrigine. So you know that lamotrigine can cause Steven Johnson syndrome, DRESS, DILI, etc., etc. All you need is to give the steroids and stop the lamotrigine. So this sometimes you don't need actual rheumatology for using steroids. So take-home message is, do not be an idiot. I like this definition. You guys have to listen to this because, the one message that I want all of us to know is, at least in the pediatric rheumatologists, you should not be missing out leukemia and don't miss out tuberculosis. While we think a lot about it, we deal with steroids on a day-to-day basis, thinking that we are smarter than the pediatrician, but it is inevitable. Many of us will burn our hands, but it's just a matter of being a bit more cautious and careful when you use steroids. The last and the most important part of my presentation, we have all seen this. My problem doesn't end with locum being steroids. These days they are saying steroid de to dega, lekin kitna dene ka? 2 se ki, 10 se ke, 30 se. 2 mg per kg or 10 mg per kg or 30 mg per kg. That's been COVID's gift for us. So none of the pediatrician or whoever is motivated enough should leave for the clinic without learning this by heart, right? So remember, short acting, medium acting, long acting based on the half-lives. We'll leave the F-corlins and hydrocortisones to the intensivists, right? The decision is dexamethasone versus methylprednisolone becomes very crucial, and I said that we are fond of methylprednisolone only because of this relatively midway half-life where it works faster and gets out faster. And in the long-term use, like an HLH, you may get away with the dexamethasone because of the longer half-life and better CSF penetration, right? So how do I decide, or what decides? Let's go back to the physiology textbook. We know that there are genomic actions, which is the conventional. The steroid enters the cell, enters the nucleus, alters the transcription, translation, and works its magic. That can be used for the conventional settings, whereas when you have a crisis, you need a slightly faster mechanism of action, which is the non-genomic. So even as soon as the steroid enters the cell, even before entering the nucleus, it binds with a lot of membranous receptors and cytoplasmic receptors and starts working its magic. You cut the story short, the non-genomic is the pulse treatment. So a 2 mg per kg or 10 mg or 30 doesn't mean absolute numbers, because if I actually use this example, if you have a 30 kg kid, a 2 mg per kg prednisolone is 60 mg per day, which it's the nephrologist dose as I call it. The same amount if you use a methylpred, it's 75, which is more than 2 per kg. 10 mg is 375 and 30 is 1125. So by numbers, you think that you are overdoing the steroids, but it's not about numbers. When I want a rapid action, you pulse 2, I think is the lower, on the lower side. 10 and 30, I think would probably behave the same. So I wouldn't be fussy about 10 mg or 30 mg, depending on urgency or emergency of the situation. Simple rules of rheumatology is pulse therapy, 10 to 30 per kg, 3 to 5 pulses is what I normally do. And then by giving that pulse, you don't need to use 2 milligram per kg. You may get away with 1 mg per kg, achieve the remission and start tapering. The idea that most of us follow is 0.3 to 0.5 milligram per kg over 3 to 6 months tells you that your DMARDs are working. As pediatric rheumatologist, a TDS works better than an intermittent fasting. So nephrologist, 8 a.m., 40 mg steroids. Yeah, less chance of pituitary suppression, but then we deal with situations where you need more anti-inflammatory. So TDS works better than a single dose. And then once you come down to a reasonable 10 mg dose, you could probably give it orally. Adverse effects, most of us know. I'll probably just skip it. Some of the common adverse effects that the pediatrician is likely to encounter is appetite, mood fluctuations, acne, but at a routine OPD visits, the pediatrician probably be checking blood pressures, keep a watch on the sugars, eye check has to be important, bone health, and obviously vaccinations. I'll click. So to end it, friends of more than when to give steroids, I think I covered when not to give steroids a bit longer because Jigna had requested, please tell us when do you not give steroids. And all of us have burnt our fingers giving steroids to malignancies and TBs. Remember when to give, what's the indication, urgent or emergency decides 2 mg or 10 mg or 30 mg. How to taper, we all know that. And how and what to monitor, most of us know. The key is timely introduction, prudent taper, and promptly stop. So believe in idiopathic, be iatrogenic, always be aware of idiosyncrasies and avoid being an idiot. So is steroids a magic? Yes, it does work magic, but we think that there is more than rasgullas in Kolkata. They are not the only drugs, and I always feel that we should probably use steroids only, when we don't know, kuch samajh mein nahi aata hai, to steroids though is not the good way to do things. It's always used when you know what you don't know, or you rule out what you think you should be knowing. I hope you understood what I meant to say. Thank you very much.
So, good afternoon to everyone. So we have come to the most important part of our so-called this oration, and I'm proud to tell you that rheumatology, pediatric rheumatology in West Bengal is probably the only subspecialty in Bengal which is running its first. It was CME's, thanks to Dr. Priyankar, who first had booked 1st May as since I have joined in this teaching, I've been saying that this is being held every 1st May. And then pediatric rheumatology is the only chapter which is having its conferences. I mean, it's probably the 6th or 7th conference. So first it was CME, and then it was conference. And so, as it is a ritual in all conferences, we started an oration. So we are proud to say that we have many. I mean, for the last first in 2017, it was Professor Chuda from Japan who delivered the oration, and then it was followed by none other than our Professor Shukman Mukherjee in 2018. Then it was our very own sir, Professor Thakur Sabui. He is, you can say, Sabui sir is the father of pediatric rheumatology, if not in India, but at least in the eastern part of India. So he delivered the oration in 2019, then followed by, there was a virtual conference in 2021, 2020 we didn't have any conference, and then it was again our very dynamic in 2022, our Priyankar Pal, and then we had Professor Sujit Singh sir as the orator in 2023, and in 2024 we had none other than Professor Amita Agarwal. And so each and every one, we are proud that we had. So to continue that legacy, this year we have Professor Dr. Suma Balan, who is going to deliver our oration. And I request Dr. Archon to introduce, though she doesn't need any introduction, but as a formality, Dr. Archon will introduce Dr. Bhagat.
Good morning, one and all. And we are fortunate to have Professor Dr. Shuma Balan. And I am honored to introduce ma'am. She is presently working as professor and head of the department and pediatric rheumatologist at Department of Rheumatology and Clinical Immunology of AIMS Kochi, that is Amrita Institute of Health Sciences. And she did MBBS and MD in pediatrics, both from the prestigious JIPMER, Jawaharlal Nehru Institute of Postgraduate Medical Education and Research. And then she worked as senior resident from 1994 to 95. Then she completed MRCP UK in October 1998. Then she had CCT in pediatric rheumatology in the year 2009. And she has special interest in systemic GIA, PUO in children, autoinflammatory disorders. She has a big cohort of autoinflammatory disorders that we all know, and hereditary angioedema. She had conducted several national meetings like APLAR, Pediatric Rheumatology Resource Group in Colombo in the year 2024, then multiple rhythm workshops, then rheumatology for physicians, pediatric rheumatology, pre-conference CME, musculoskeletal workshop, National Conference of Pediatric Rheumatology, IRACON, and many more. And she has been invited as national faculty in many national and international conferences. She has portfolio of Vice President of Indian Kawasaki Disease Society. She has been President of Pediatric Rheumatology Society of India from January 2021 to January 2023. She was past Secretary of Pediatric Rheumatology Society of India from 2019 to 2021. And she was in the pediatric content creation team of Ministry of Health. And she was IAP National COVID-19 treatment in the treatment task force also. She has multiple publications, numerous publications in national and international journals. And her other interests are blogging, poetry, cooking, and bird watching. So welcome ma'am, welcome to the City of Joy, and stage is all yours.
It's a great honor, and I'm very touched by this invitation. Thank you to the West Bengal Pediatric Rheumatology Society. When Jigna first called me and asked me this, the first thing that struck me is, do people think I've become old? But anyway, so I called it the roller coaster ride of rheumatology because, I don't know, a lot of people think rheumatology is dull, but it's very exciting. And though a lot of the excitement happens in our head, it can cause many sleepless nights. So I decided to do it on a theme of certain patients who've had roller coaster rides who have actually been instrumental in changing my practice. And Maharishi Charaka was a bust at one of the crossroads of my alma mater and in JIPMER, and I passed by this every day during my MBBS and MD periods. So I started MBBS in 1985 in JIPMER, Pondicherry, gained many friends. Then I carried on to do MD in pediatrics in the same place under the tutelage of Dr. Srinivasan, who taught me how to love clinical pediatrics, and Dr. Nalini, who instilled in me my interest in chronic disease. She is now a Padma Shri for her work in hemophilia. Then I moved on to the UK, and after a long journey there, I ended up doing my CCT in the Children's Hospital in Nottingham. And my interest was always pediatric nephrology. And in fact, I started off in Nottingham with Professor Alan Watson, working in pediatric nephrology. But circumstances, I couldn't continue training in this field, and it was by sheer serendipity that I landed up in Nottingham Children's Hospital doing pediatric rheumatology under one of the first doyens of pediatric rheumatology, Dr. Helen Benning, who is as dynamic as the streaks of red in her hair. They're often blue, purple, and different colors at different times, but she taught me much more than rheumatology. She actually taught me how to deal with patients, and the art of medicine was one of the main things that Dr. Helen taught me. And Dr. Rangaraj was the other consultant in pediatric rheumatology with whom also I learned how to become a pediatric rheumatologist. And after this, my husband and I, we moved back to India with our 2 children to Amrita Institute of Medical Sciences, where I've been since the mid of 2009, building up a pediatric rheumatology practice. The first question asked to me in my interview was, will you have patients? The only reason they hired me was because they needed a joint replacement surgeon, and my husband was one. But they just humored me along. And it's been a long ride. The first 12 months, I saw a total of 185 patients. In the last 12 months, I have seen more than 4,500 patients. So it's been a long, fulfilling ride. And finally is my friend, philosopher, mentor, and guide for life, Mr. Pelham Grenville Wodehouse, PG Wodehouse, who's inspired me forever. We started a DM in rheumatology and clinical immunology since 2016, and I probably have the fortune of being the only pediatric rheumatologist in the country to head an adult DM program. We have 3 adult rheumatologists, and there's me, and we have a composite, what I like to think, a complete department. So I'm going to start with a number of cases who have influenced my practice. And this girl I met within 2 months of joining. And this is probably the first satellite patient who made the pediatricians sit up and recognize why pediatric rheumatologist was a good value addition to the team. And this was a 14-year-old girl who'd been diagnosed as lupus at the age of 10. She was under the pediatricians, and all she was getting was recurrent courses of steroids every time they thought she had a flare. She did not have any steroid-sparing medications. And this time she was admitted with fever, cough, oxygen requirement, and abdominal pain. She had multisystem lupus, pneumonitis, nephritis, pancreatitis, multiple cutaneous ulcers, and previously had sequelae of APS2. So as a rheumatologist, we attack aggressively. Vijay said, high dose methylprednisolone pulses and IV cyclophosphamide. But pancreatitis is a difficult bug. And what happened was, though it started responding, she started developing peripancreatic effusions and collections, massive collections, that started getting secondarily infected with rather horrible drugs. And then the pediatric surgeons and the interventional radiologists were putting in pigtail catheters. At one point, we had 5 pigtail catheters in her, draining large amounts of pus. And despite octreotide, finally we went for surgical way to address that pancreatic disease. And this is the kind of collections that she was developing. And what was interesting was the horrible presentation, but she survived all this. It was a 3-month admission. It showed how much, if you leave lupus untreated, the disease itself causes immunodeficiency. And then when we use our drugs on top of that, it can compound the problem. There's a lot of learning from this case. But we actually stabilized her. She got to go home. She got to go back to school. Everything looked good until 6 months later, she comes back with a community-acquired pneumonia. We admit her. It's unexpectedly goes into sepsis, literally in hours, and we've lost her. It's strange how we didn't lose her the previous time, but this time we lost her. My first patient as a consultant. And it was not an easy cross to bear. So man proposes, but God disposes. And that's why, to me, lupus is like the many hydra. This was a horrible sea creature in the island of Lerna to defeat the sailors that came around and prevent people from coming there. It was very poisonous. It had 9 heads. And every time you cut one head, 2 more would pop up. And Hercules, the second labor of Hercules was to kill the Hydra. And he brought his nephew along with him. He used a sickle to cut the head, and his nephew would brand it, cauterize that head with torches. And that's how, and the final immortal head, they buried it under a rock. And that's how they vanquished the many-headed Hydra. And many times, dealing with lupus is like trying to kill the many-headed Hydra. If lupus is a many-headed Hydra, even the new rheumatologist in a Hercules avatara can be challenged by the head immortalia. And that is the kind of journey we face with difficult lupus patients. This child came along almost immediately after that, a very poor child, a 9-month history of lupus in an Ayurvedic hospital, brought to the Government Medical College in Ernakulam, where they had no rheumatologist at all. And the pediatrician on duty happened to be a baby junior of mine in my MBBS days, whom I had taught when I was an MD student there. And she called up just out of that familiarity and said, I think I have a child with lupus who's extremely sick, severe cardiac failure, I don't know what to do. So I told her, pulse the child, her cardiac failure will improve, and then send her to us, we'll have a look, and we'll tell you what to do. They were very poor. I work in a private institution. And she had multi-system lupus, PEO, cardiac failure, severe LV dysfunction, rashes, cutaneous gangrene, and we found out that she had coronary vasculitis, massive coronaries actually, which is a small vessel vasculitis within the vasovasorum of the medial vessel of the coronaries. Since then, we've had another 3 patients with that. Then multiple organs were involved, and she has gangrene. It was quite a very, very sick child. And with, together we worked. This child would just come to us for opinions and for our cardiologist to do echoes. I would write the prescription for cyclophosphamide and send it back. They would give it there. And with that, we got her better. She lost a few fingers, but today she's a solicitor's assistant and doing extremely well. So it was indeed a journey of pain. Losses, yes, but much to gain. The disease was a devastating force, yet she managed to stay the course through a miracle of great liaison, through the marvel of modern medicine, through trust in her treating team, and that is fundamental. She remains in remission like a dream. And this, I just put up this, it was submitted for NCPR 6 years ago by one of my students, because contrary to what my discussions with my friends, especially in the eastern part of India, we get a lot of patients coming with lupus, severe disease actually, who don't have much of mucocutaneous findings. This is fairly, I think, typical to Kerala more than any other part of India. So we looked at, we had 111 patients that we looked at in 2019. Now the numbers are much more. And even then, about 20% of the patients had no mucocutaneous findings at all. 57% had oral ulcers outside of this 20%. And of these 20%, 1/3 of them had actually severe organ disease. So lupus can present without mucocutaneous lesions, and that is an important message that needs to go out, that you need to suspect lupus even if there are no mucocutaneous lesions. This is another patient, a 6-year-old girl. She flew in from Dubai, classic juvenile dermatomyositis. She had all the features, and she had peripheral edema. She was quite weak. She had high muscle enzymes. This is again going back to 2017, 2018, when myositis-specific antibodies were very expensive, and so we didn't do it at that time. Now we would do it for every patient. So we started her again on IV methylprednisolone, converted that to oral steroids and subcut methotrexate as a first line, but she wasn't really improving as we expected her to improve. She had mild dysphagia, static ulcers, and so we added an IVIG to the mix to help her and let methotrexate have some more time to kick in. 2 weeks later, she comes back, and this time it's a diffuse abdominal pain. I'm driving home. The patient is in casualty. My student calls me and says she has diffuse abdominal pain. Her abdomen is rigid. I said, do a chest X-ray with both dooms of the diaphragm, and bang on. What we found was gas into the diaphragm. We called the pediatric surgeon. She went to theatre, And as always, the dilemma for the pediatric rheumatologist, infection or inflammation. Is this GI vasculitis? With that setting, very highly possible GI vasculitis with perforation, which means she needs much more aggressive immunosuppression. Or is this an infection that's caused the problem, in which case giving her more immunosuppression would not be the answer. The biopsy held the key. She had a single site of perforation. There was no vasculitis on that biopsy, and she had CMV inclusion bodies. And CMV PCR corroborated the same thing. So this was CMV colitis in a child with JDM, probably reactivated secondary to the immunosuppression, who developed a perforation. So the treatment was now supporting the CMV infection, supporting her disease while we treated the CMV with IVIG, and she's done very well. And luckily, she's a monocyclic JDM. Now it's a few years since all treatment is stopped. She remains in remission, doing extremely well. And my student got a first author publication in an international journal. So all's well that ends well. Not always. This is a 2-year-old boy with systemic JIA, fairly classic fever, evanescent rash, arthritis. You can't get more classic than that. And he'd been on here homeopathy when he came to us. We tried naproxen, it failed. I always tried for some time if the patient is reasonably stable, so I get an idea of what's going on in this patient, being a diagnosis of exclusion. Then we had to give him steroids. There was some improvement, but he had to be readmitted in 10 days. He had a viral infection, and his disease became active, and he went into MAS, quite a nasty MAS. And methylprednisolone, cyclosporin weren't enough. He developed hypertension. We couldn't give him more cyclosporin. And so the only thing we had to us, this was again 2018, the only thing we had with us at that point was tocilizumab that we could use. So we tried it. We tried it along with antibiotics for an infection. And slowly we got him a little better. There was still smoldering MAS, so we decided to give a second dose of tocilizumab after 2 weeks and then discharge him after a month-long admission. He comes back 4 days later with an ulcer in the lower lip, which is growing MRSA, again sensitive to vancomycin. We gave him vancomycin this time. He was still in mass. He developed a red man syndrome, went into a cytokine storm, and we could not save him. It was very, very, very tragic situation actually. And if you look at his blood test, you can see how stormy the process was with the MAS. We had some improvement with the tocilizumab, but we really couldn't contain the situation. And he had a procal of more than 100, which I will come to in a minute, when the final thing. So MAS is something that has been part of my work since I came back in 2009. So in 2012, I presented a little modification we had done, because at that time, what did we have? We had very, very few drugs. Tocilizumab was very expensive. It was there, but very expensive. So there were a couple of patients with systemic JIA presenting with MAS who were not responding to steroids. We could not give cyclosporin because of associated hypertension, renal failure, etc. So we gave them etoposide, but I decided to give them limited doses of etoposide, where we gave 2 doses to this patient. Actually, the second patient got 3. It says 2 there, but got 3. And then the mass turned, so I stopped the etoposide and carried on with the steroids, and the renal failure also improved once the mass improved. And we were able to actually get these patients into remission, into treatment, very, very good long-term prognosis with both of them, with a limited dose of etoposide, which is something that we pediatric rheumatologists can think about as a potential option. I don't like etoposide, let me say, but when it's necessary, you have to use it. So then subsequently, by 2018, we got the courage. You know, the main 2 studies done about tocilizumab in SJIA, the TENDER and the CHERISH, both of them brought out caveats. Be very careful if your patient has MAS, because the patients who died in both those studies were patients who had active MAS. So it was always like, can you use it, can't you use it? But this was a time when we had no other option. So the 4 patients whom we gave tocilizumab to, we decided to share our experience. 2 of them did very well. One of them had anaphylaxis, so we couldn't continue. And the last one was a patient who died. And I think Priyanka was discussing in his panel discussion earlier on about how it's not always IL-6, it's often IL-18 and IL-1 that is driving the process. And that also dictates what is going to work and what is going to help. So another study that we did, one of my students published, was we looked at procalcitonin as could we use this test to differentiate between a patient with systemic JIA who comes back with fever to see whether the fever is due to bacterial infection versus the fever being due to active disease. What we found, it was a negative result. There was no difference whether, whatever reason the systemic JIA fever was triggered, didn't matter as far as the procalcitonin was concerned, but there was one outstanding finding. That is, the patients with MAS had huge, very, very high results of procalcitonin. So all the over 75, over 100 numbers we saw were actually when they were in a macrophage activation or a cytokine storm. So this gave me an insight that when you see such high procal numbers, you should be thinking about immunomodulating these patients and not just thinking sepsis and infection alone. Then my insight with the boy who died was we didn't have anakinra, and I wanted to catch the tiger by its tail. So after he died, I got my hospital to get anakinra and stock it. So if in future I needed anakinra, I would have it for immediate use. And this was 2018, 2019, we managed to get it. And since then, this was presented in 2022, and we had about 10 patients who were given anakinra for secondary HLH. And what you can see is the infection-induced and the systemic JIA-induced did extremely well. The patients we had a couple of patients who were referred as systemic JIA, but it turned out to be malignancy-induced HLH. It did not work in those patients. And one child with a PID and secondary HLH due to that died of the PID and not of the HLH part of it, but again, it did not work to the extent we wanted. And another student of mine also wanted to work, because we saw a spate of 3 patients who had lymphoma-induced HLH, mistaken as systemic JIA, and treated with lots and lots of steroids, came to us, and we lost all these patients while we made the diagnosis because it received too much steroids. They're just not able, and the disease took over, and it was very difficult to treat them. It was also very difficult to make a diagnosis. And he came up with the concept himself of looking at a serum interleukin-2 receptor to ferritin ratio in MAS. And what we found was that actively looking for a lymphoma-associated HLH, when the platelet count is less than 38,500, LDH more than 617, and an SIL2R to ferritin ratio of less than 0.196. And this was something that, again, is awaiting publication. So we'll go on to some other diseases. Again, a 2-year-old boy with a VSD, recurrent respiratory tract infections, not surprising because he has a restrictive VSD, dental caries, being beautifully monitored by a pediatric cardiologist in his local area. Now he develops a quotidian fever going on for 2 months with the polyarthritis. There is no rash, very high inflammatory markers. The local pediatricians did a great job. They've looked at cultures, bone marrow. The echo is showing a stable VSD and no response to antibiotics. Is the systemic JIA. They started steroids. To a fault, the only thing you can say is they weaned it very fast, so he became febrile again. At that point, he was referred to us. And we saw he has daily fever, the quotidian pattern, with arthritis of 2 major joints and a VSD, murmur, but stable VSD. He has significant inflammation with a ferritin that's beginning to trend upwards. So once again, we also thought systemic JIA, gave him steroids and methotrexate, he improved, we discharged him. He came back a few weeks later with high-grade fever, cough, chills, rigors, Krebs. We thought respiratory tract triggered, but he had a new murmur. And he had bilateral knee joint arthritis. So again, the infection versus inflammation seesaw, that now we are dealing with infection for sure, more than inflammation. And the blood culture brought out a very strange organism. I heard it for the first time, Apitrophia defectiva. And now the echo shows a vegetation. Okay? So we had to treat him as infective endocarditis at this time, and I really questioned, was this all along? Did he have two diagnoses or one? And the thing is, you can actually make a case for this endocarditis, a restrictive VSD, the jet stream landing exactly at this point, bad dental caries, and so an oral commensal coming out into the heart, and an immunosuppressed state. So perfect setting for infective endocarditis. But then after we treated him for the infective endocarditis, he comes back with a high-grade fever, quotidian, high CRP, high ferritin, and systemic GIA. So the proof of the pudding is now coming out again. So he did have two pathologies. And patients teach you every day, every time. So along with treating him for a systemic GIA, the cardiologist wanted a good dental treatment to clear up his mouth and reduce the infection risk from there, and then a surgical VSD closure. He remains in remission today, just on methotrexate. And I hope this, yeah, you can see the vegetation popping in. It's quite impressive actually. And this is the evanescent rash that he developed after the treatment of the endocarditis. So really, two diseases, a two-in-one scenario, one explained by the other. And that's the roller coaster that some patients ride. So VSD, systemic GIA, infective endocarditis, back to systemic GIA. It's quite a rocky ride for patients. This is a 9-year-old girl who came to me about 2 years back. And, you know, this is a story of why you shouldn't be complacent. Okay? IgA vasculitis with GI vasculitis. Which pediatric rheumatologist hasn't seen this? This is like bread and butter for us, right? So this child was treated in a local hospital. As an adult rheumatologist was treating her, she got lowish doses of steroids. She wasn't responding adequately, so she was referred to us. And clearly she was significant GI vasculitis. The hemoglobin was on the lower side. And we looked at that CT. It showed quite a diffuse jejunal involvement. So as we do, we gave her IV methylprednisolone. She didn't improve with 10 milligram per kilo, and she showed worsening, so we actually had to give her a higher dose. And she was almost teetering that balance towards getting a dose of IV cyclophosphamide. But she seemed to improve, and that's the time we had South Zone Iracon in the Leela, Trivandrum, and I was sitting there and gazing, and various verses were coming to my mind when my PG calls me up in the night and tells me she had a seizure. She has, due to shock, she's now in the ICU, intubated and ventilated. Oh my God. And I said, no, this has to be a perforation. The pediatric intensivist said, no, her stomach is very soft. The pediatric surgeon said, no, her stomach is very soft. I said, no way. She's had so much of steroids, you will not get the physical signs of perforation. Do a CT, the X-ray was negative. Do a CT, and lo and behold, edematous bowel loops, pneumatosis, portal venous gas. You can't get a more stark story for a perforation. She underwent a small bowel resection of 20 centimeters, obviously peritonitis and sepsis, gram-negative sepsis. And again, she improved over time with all our tender loving care. She made an improvement, but it took a very long time before we could establish feeds on this girl. And I would say nutrition was one of our biggest challenges in getting her better. Then, the same month, I went to press in Rotterdam, where I met the beautiful Jigna. And while I was enjoying myself there, I get this video from my postgraduate again. And now she's developed, video is not playing, I think. She's developed a vertical nystagmus with visual blurring. MRI is normal. There is some evidence of vasculitis in the eye, with some mild prolonged latencies on the BEP. So what now? CNS vasculitis. My kind adult rheumatology colleague, Dr. Mithun, who's a great clinician, saw her on my behalf and told me, why don't you think of wernicke's encephalopathy? Because she's not been fed for adequately, nutritionally depleted for a while now. So it could be that, could be a thiamine deficiency. So we decided to treat for both. We increased her steroids. Someone who's just come out of a bad sepsis story, we increased her steroids and gave her IV thiamine, which worked. I don't know, but she improved. And I could spend the rest of my holiday peacefully. And so this was another roller coaster ride. And the answer for me is don't be complacent. I thought this ride would be as smooth as butter, but was it? No way. And Ronan Keating has sung beautifully, life is a roller coaster, you just got to ride it. And that sums up the life of a pediatric rheumatologist. The next year, she cut her birthday cake in my OPD, doing very, very well on Nothing Now. Then we had this boy. Sometimes we need to be patient. A disease will reveal itself to us with time. So this boy, at the age of 4, when I was not in Kerala, when I didn't know him at all, he developed recurrent painful arthritis. He was found to have a splenomegaly and neutropenia, which there was no clear answer why it was happening shortly after that. And what was strange was every time he has an infection, his neutrophil counts improve, contrary to our usual concern. I met him in 2010, soon after I joined Amrita, and he actually fitted the classification criteria for lupus, though I found it very difficult to call him lupus with the features he had. And then there's the persistent neutropenia dogs you. You tried, thought treat as lupus, maybe that'll get better. It didn't get better. Whatever you did, it didn't get better. The hematologist said, why not ALPS? We looked, he did have high numbers, double negative T cells, but that's not enough to make a diagnosis of ALPS. He really didn't fit otherwise. And the neutropenia continues to dog us. He has the odd once in a while infections when his neutrophil counts actually improve. So we don't really know what is going on here. Is he autoimmune? Is he a PID? What is actually going on here? And he gets lost for follow-up also. We've tried various things. We've tried treating him like ALPS, sirolimus, etc. No use. Then he becomes an adolescent and he starts developing this horrible cystic acne. And that is what is worrying him more than his neutropenia and anything else at that point. We had a few years when we never saw him. He went to Ayurveda. That didn't get him better. So he came back to us at the age of 18 with knee arthritis, acne. Then at that point, the hematologist did a West looking for various causes of neutropenia and found nothing. And but I was still thinking, this jigsaw is not fitted. And there he was, arthritis, recurrent severe acne, hepatosplenomegaly, pancytopenia with resistant neutropenia. His spleen is increasing in size over all these years. That's two things. So the hypersplenism was a significant entity that became obvious as he started growing up. And then I rang my friend Dhanya Lakshmi, who had this Wellcome Trust grant to look for autoinflammatory mutations. And I said, Dhanya, this boy has something. You have to find out what it is for me. Many calls to and fro later, and she told me, PST-PIP1, that is not Papa syndrome in this case, it is PAMI, which is a very severe variant of Papa. And then we spoke to NIH. They said, try JAK inhibition. It didn't work. They said, HSCT is the only thing that helps these patients, but with such a huge spleen, that's a very bad prognostic marker for doing a HSCT. And the spleen started having its consequences. He developed extrahepatic portal hypertension, started getting procedures for that. So it became a very messy affair. And every time now that he got infections, he tolerated it less better than he did before. And there we are now, with the spleen being the biggest problem, the hypersplenism being the biggest issue. And how do we get to a HSCT in him? How do we control that spleen before we can get him to that? And he has done a degree in visual media and animation, and he's so talented, like you can see in the pictures there. Then, what happened? There was this boy, whom again I didn't meet for a long time. From the age of 3 years, he has polyarthritis involving knee, ankle, elbow joint. He was treated as acute rheumatic fever at that time. Then he had a non-healing skin ulcer of his leg, age 4, for which he was on ATT. Then, at the age of 12 was when I saw him, that is 2011, I think, when he had, or 2012, and he had inflammatory polyarthritis, but I wouldn't call him JIA. He had biocytopenias, he had a splenomegaly, and no answers from the tests we did. But however, he did have some response to steroids and methotrexate, which he took for a few years and then defaulted to Ayurveda. And then I didn't hear of him for a very long time. This was how he presented to us. That little arrow there is showing the healed skin ulcer he had. We never saw the ulcer in the short period he was with us. And then he had a very horrible course. At the age of 19, he started developing horrible pyoderma gangrenosum. Sheets and sheets of pyoderma gangrenosum. He also had features of autoimmunity. He had hypersplenism, pyoderma gangrenosum, a requirement for frequent transfusions. Somebody said this could be Papa syndrome, put him on steroids and adalimumab. Absolutely no effect. The surgeons took over. He had an amputation done. Nothing could control, nothing was helping. And then there was a social media call for help. It came in our local rheumatology group. I saw that name, it was an unusual name. I recognized that name. I saw this process, and something went off in me. The pattern recognition hat of a pediatric rheumatologist. I rang them, I got them to come back to our hospital, to one of my adult colleagues. And this is what the story was: recurrent inflammatory arthritis involving lower limb and upper limb for going on for 20 years now. Extensive refractory ulcerative pyoderma gangrenosum, hepatosplenomegaly, persistent anemia needing transfusions, and a biocytopenia and some autoimmunity. The picture looks similar. I rang Dania and said, "You've got to do a West for me." And we got this exact same mutation. The same mutation with two faces to it. One patient suffers from the hypersplenism aspect and the myeloid insufficiency. The other patient suffers from the cutaneous inflammation aspect. We started anakinra, which is apparently helps, but I think we were too far gone with that kind of sepsis was our greatest enemy, and he succumbed to that. So, two PAMIs, very rare disease. There are just, very few patients in the world. But the reason I brought this out was that it can take a long time to make diagnosis. So keep mind open all the time. Look up the literature. However, this was an evolution from a time when we did not have molecular biology diagnostics accessible to us. Today, we live in an age where we have many more things accessible to us. So we should be putting one and one together to make two much more easily than we did before. But these were the stories that we've had to live on to come across these things. And I leave you with those words of Joseph Murray, who's the first renal transplant surgeon in the world, who said at that time, many decades ago, it's the best time ever to be a doctor because you can heal and treat conditions that were untreatable even a few years ago. So the next PAMI, hopefully, will pick it up when he can be treated. So, And the journey with autoinflammation continues. We have many diagnoses, we have series and series of patients, but a few notable ones. So Majid is probably my most unlucky series of patients apart from the PAMI, because we've made the diagnosis, picked up 4 patients. We've not been able to treat even a single one properly due to various constraints, and that is something that needs to be smoothened up with time. Then the PMVK was a boy who clearly had an autoinflammatory syndrome, came back with West negative, and then I called Dania and said, no, he has something. Clinically, he looks like a hyper-IgD. So she went and checked the hyper-IgD, all the various enzymes involved, and she said, he doesn't have an MVK mutation, but he has a PMVK mutation, and that was a novel one we were able to describe.
And now we have one more novel mutation on that same spectrum called the HMGCS. There are, I think, 2 patients reported worldwide. One is ours, one is from NIH, and Ivona is leading this publication that's coming up. I'm going to finish here. I have to say thanks to my department, my colleagues, my students, my mother, my family, and many of my pediatric colleagues. This little picture at the bottom is a boy with multisystem inflammatory syndrome following COVID, who we managed to work together, a very poor family, put him on ECMO and get him better. And I'm very happy, very proud to work in a system like that. And I would leave you with these words. I have had dreams and I've had nightmares, but I've conquered my nightmares because of my dreams. A Nobel Prize winner. So I stand on the shoulders of giants. To them I owe my little triumphs. If today my tales in you can inspire to find better answers, be your desire. I stop there. Thank you.
Daunting. It's daunting, but as you said, it's just a journey which we should all.
Thank you, ma'am. Truly a roller coaster, I would say. And journey of a pediatric rheumatologist, the pain, the satisfaction, and often we teach the PG students that diagnosis is often made in follow-up. So it keeps changing color. It keeps on changing color. So thank you. Thank you for teaching us with your experience, the experience of life. And we have learned a lot. Thank you. Thank you.
We disperse for lunch. So posters, I think we should give the judges 10 minutes to have their lunch. They are all hungry. So by the next 15 minutes we start the poster presentations, and we expect everyone in the auditorium by 2:45. So we start our next station 2:45.
And please, whoever has not uploaded the poster, please upload in your computer.
Now, our topic of discussion is when to suspect vasculitis. Our speaker is Dr. Archon Sil. He is Assistant Professor, Bardhaman Medical College, and young, energetic pediatric rheumatologist and immunologist. And he is also the in charge of pediatric immunology and rheumatology clinic, Bardhaman Medical College, Dishan Hospital, Ahad Multi-Speciality Hospital. And he is also acting as Secretary, West Bengal Pediatric Rheumatology Society. Please come on the dais and start your lecture.
Thank you, sir, for your kind introduction. So good afternoon all. One of the most challenging session is to engage the audience in post-lunch session and to combat this post-lunch drowsiness. So I will try my best, and today my topic is when to suspect vasculitis. So there is no conflict of interest to disclose. these are the points of my talk. So first, what is vasculitis? There are subtle differences between vasculitis and vasculopathy. Vasculitis is the inflammation of the wall of the blood vessels, and the causes may be various. The inflammatory exudate may vary in histopathology, like it may be mononuclear, it may be eosinophilic, it may be neutrophilic. And vasculopathy is actually abnormality of the blood vessels. The cause may be due to inflammation, maybe degeneration, and maybe intimal proliferation. So examples of some vasculopathy are Marfan syndrome, Ehlers-Danlos syndrome, fibromuscular dysplasia, and so on. So there is a basic difference that we'll have to understand between vasculitis and vasculopathy. So there are various risk factors. In this picture, you can easily understand that there are various risk factors of vasculitis. There can be ethnic difference, there can be geographical difference, there can be genetic component, there can be infection-induced, socioeconomic factors, immunization, seasonal variation, intestinal microbiome, and so on. So vasculitis can be infection triggered, rickettsial infections, syphilitic aortitis, tubercular aortitis, aspergillus arteritis. These are some of the examples of infection-induced vasculitis. It can be due to immunity triggered by infection. So not directly due to infection, but due to immunity triggered by infections like cryoglobulinemic vasculitis in cases of hepatitis C virus infection, and non-infectious causes. So as we all know that non-infectious causes of vasculitis are divided depending on the size of the vessels involved. So this is the Euler-Press classification of vasculitis depending on the size of vessel involved. So the large vessel vasculitis means vasculitis involving aorta and its major branches. So Takayasu arteritis is the only large vessel vasculitis that we see in pediatric age group. Giant cell arteritis is a disease of older age group. Medium vessel vasculitis are vasculitis involving the medium size arteries that are direct branches of the aorta, like renal arteries, mesenteric arteries, and coronary arteries. So PAN, polyarteritis nodosa, and Kawasaki disease, these are the two important medium vessel vasculitis. Now coming to small vessel vasculitis, they have divided based on this Euler-Press classification, they have divided based on the granulomatous inflammation or non-granulomatous inflammation. So small size vessels means arterioles, capillaries, and venules. And granulomatous, as we all know, GPA and Church-Strauss syndrome, which is now known as eosinophilic polyangiitis. Among non-granulomatous, there are microscopic polyangiitis, IgA vasculitis, isolated cutaneous leukocytoclastic vasculitis, and hypocomplementemic arterial vasculitis. Other vasculitis. So there are some types of vasculitis which do not belong to any of these categories. So mixed type of vessels may be involved. Behçet, mixed vasculitis, any kind of. So medium or small, both vessels can be involved. Vasculitis secondary to infection, as I have already mentioned. So hepatitis B, triggering immunity, and ultimately causing vasculitis. Vasculitis associated with connective tissue disease, lupus, often present with vasculitis. Cogan syndrome and some unclassified cause. So this is the Chapel-Hill classification of vasculitis, which have divided vasculitis in a slightly different way. So large vessel vasculitis and medium vessel vasculitis remaining the same, but small vessel vasculitis they have divided as ANCA-associated vasculitis and immune complex mediated vasculitis. So IgA vasculitis, cryoglobulinemic vasculitis, and hypocomplementemic arterial vasculitis, they belong to immune complex mediated, and ANCA-associated vasculitis GPA, EGPA, and microscopic polyangiitis. So when to suspect vasculitis, this is the biggest questions, and the presentation is non-specific. when there is multi-organ involvement, multiple systems are involved, there are constitutional features like fever, weight loss, appetite loss, fatigue, myalgia, and in baseline laboratory investigations, you will get a clue like anemia, neutrophilic leukocytosis, thrombocytosis, and raised inflammatory parameters like ESR and CRP. And typical skin manifestations like livedo reticularis, livedo ecchymosa, livedoid rash, subcutaneous nodules, these are all clues for vasculitis. So there is no specific clinical sign, there is no single diagnostic test. All this clinical profile in association with those laboratory findings, you should always suspect. So there are some features which are typical to large vessel vasculitis, like absent pulses, bruit over aorta and major vessels, hypertension, discrepancy of blood vessels, discrepancy of blood pressure between upper limb and lower limb, and congestive cardiac failure or cardiomyopathy, which is not explained by other causes. Medium vessel vasculitis, again hypertension, mainly due to renal involvement, deep skin changes like paniculitis, ulcer, livedo reticularis, microaneurysm, digital gangrene, focal neurodeficit, mainly due to mononeuritis multiplex or other neuropathy, orchitis. And small vessel vasculitis can present with purpura, superficial or mucosal ulcers, pulmonary renal syndrome, and some ENT features like chronic sinusitis, recurrent epistaxis, asthma, urticaria, uveitis, episcleritis, or scleritis. So now I will discuss 5 cases, and you should try to tell me the diagnosis, especially the PG students. So case 1, 7-year-old girl presenting with a history of intermittent fever for a long duration, 9 months. And there is generalized weakness and easy fatigability for 6 months. For last 1 month, this girl is having shortness of breath. Now, examination shows grossly reduced weight and BMI. Pallor was present, there was tachycardia, and while noting the blood pressure was elevated in all the, especially in upper limbs, and there was discrepancy in blood pressure between upper limb and lower limb. So lower limb blood pressure was low as compared to upper limb, and the difference was more than 10 to 15. And there were features of hyperdynamic circulation and congestive cardiac failure. Apex beat was down and out, there was right pasternal heave, high-pitched systolic murmur radiating to axilla and back, soft hepatomegaly, bruit present in periumbilical area and in left renal angle. So what is the diagnosis? Anyone? Yes. So this is large vessel vasculitis, and to be specific, the diagnosis is Takayasu arteritis. Coarctation is least likely because of the age of presentation, the preceding constitutional symptoms, the gender, and the other findings. So this was the case of Takayasu arteritis. As I have mentioned, in CBC you can see anemia, neutrophilic leukocytosis, and elevated inflammatory parameters, that is ESR and CRP. And echo showing severe left ventricular dysfunction with low ejection fraction as low as 20%, and there is distal descending thoracic and abdominal aorta narrowing on echocardiography. And on USG, Doppler, and KOB, there was monophasic waves in bilateral lower limb arteries. So the CT angio confirming the narrowing, CT angiography showing narrowing of distal descending thoracic aorta, the aorta, the renal arteries, and superior mesenteric arteries. So this was a case of Takayasu arteritis. So Dr. Mikito Takayasu, who was not a rheumatologist, unfortunately or fortunately, I don't know. So he was an ophthalmologist who described these typical changes in retina, these abnormal central retinal blood vessels. And he first detected this abnormality, and later on this disease was described. So clinical features we can divide into 2, and 1/5 of the cases are in pediatric age group. So female preponderance is there. Pre-pulseless phase, which present with non-specific constitutional symptoms. The key is to diagnose in pre-pulseless phase. We can do PET CT. And pulseless phase, there is diminished pulse, discrepancy in blood pressure, claudication, all these features will present. Classification, this is the Euler-Pinto-Press classification criteria. Mandatory criteria is angiographic abnormality, so you will have to detect the stenosis by angiography plus any one of the following, that is pulse deficit or claudication, discrepancy in fold-limb blood pressure, bruit, hypertension, and elevated inflammatory parameters. So any one of the following 5. And this is the angiographic classification. So our case belonged to class 3, where thoracic, descending, abdominal aorta, and renal arteries were involved. So in India, based on this publication by Dr. Devashish Danda, type 5 is the commonest type, whereas in Japan, type 2 is the commonest type. So coming to case 2, 12-year-old girl with non-specific fever, malaise, weight loss, myalgia, arthralgia, recurrent sinusitis, and epistaxis, so upper respiratory tract symptoms, and this girl had brown colored sputum with intermittent chest pain for last 1 month, and headache not resolved by analgesic for past 2 weeks. So what is your diagnosis? Yes, so this was saddle-shaped nose, typical, and lung nodule with bilateral lung involvement. This picture is showing subglottic stenosis, and this is in the morning session there was extensive discussion. So this was ANCA, anti-neutrophilic cytoplasmic antibodies, and to be specific, this was C-ANCA. So this is the Euler-Pinto-Press criteria for diagnosis of pediatric GPA. Any 3 of these 6 should be positive to classify it as ANCA, and our patient had these 3: recurrent ENT symptoms, the subglottic stenosis, and blood-tinged sputum. So there may be renal involvement as well. So this is mainly small vessel vasculitis. This is a rare vasculitis in pediatric age group. Mean age at diagnosis is 14 years. Again, there is female preponderance, and the vasculitis is necrotizing vasculitis. So GPA, MP, and EGPA, these are the 3 ANCA-associated vasculitis. GPA is little bit more commoner as compared to the other ANCA-associated vasculitis, and granulomatous inflammation is the key. Upper airway, upper respiratory and lower respiratory involvement along with glomerulonephritis. C-ANCA or anti-proteinase 3 antibodies are positive in most of the cases. So differential diagnosis, yes, good posture and other drug-induced ANCA vasculitis should come in differential diagnosis. So moving on to the next case, 7-year-old male with fever, weight loss, episodic severe abdominal pain for last 2 weeks, and abnormal gait. So there is foot drop with this kind of gangrenous lesion and ulcerative lesion. So diagnosis? So this is a medium vessel vasculitis, polyarteritis nodosa. This is the Euler-Pinto-Press classification criteria. Again, the major criteria is either you will have to demonstrate the vasculitis, the necrotizing vasculitis by histopathology, or you will have to demonstrate the microaneurysm by angiography, by imaging. And the other criteria are minor criteria, that is skin involvement. Typical skin lesions are livedoreticularis, livedoid racemosa, livedoracemosa, subcutaneous nodules, gangrene, myalgia may be present, hypertension due to renal involvement, peripheral neuropathy, and there is wide range of kidney involvement. So any one of these 5 should be positive. So constitutional symptoms will be present. Neurological symptoms like cerebrovascular accident, focal neurodeficit, skin lesion should be present, renal involvement, and pulmonary vasculature is one thing which is unlikely to be involved in polyarteritis nodosa. So this is the livedoracemosa, and this is the ulcerative lesions. So if these pan-like features are present on the, in the background of consanguinity, and there is history of recurrent TIA or strokes, and there is history of recurrent infections in the form of recurrent sinusitis or warts and mild splenomegaly, so then the diagnosis is a monogenic cause of vasculitis, which is anyone, which is known as, yes, deficiency of adenosine deaminase 2 or DADA2, where the gene, the culprit is CECR1. Nowadays it is known as ADA gene, and it is, you can say, the PAN in an infant or PAN in a child of lower age group, where hypogammaglobulinemia and lymphocytopenia are the clue, and recurrent strokes or recurrent neurological involvement will be present. So case 4, very easy, 5-year-old girl with purpura, ecchymosis, those who, the purpura ecchymosis symmetrically distributed in lower extremity and buttocks, bilateral wrist swelling. So I will not discuss in detail. So what is the diagnosis? Typical palpable purpuric rashes in lower limb, and so this is IgA vasculitis, but you will have to keep in mind all these things, meningococcemia and other causes of this. And now EVSG showed this target lesion. So this is intersusception. So this is the diagnostic criteria, you all know. And HSP nephritis will be dealt in detail in the next session. Risk factors I will tell: age of onset more than 7 years, persistent purpuric lesions, severe abdominal symptoms, and decreased factor 13 activity. So this is the differential diagnosis of leukocytoclastic vasculitis. So apart from IgA vasculitis, hypersensitive vasculitis, mixed cryoglobulinemia, hypocomplementemic arterial vasculitis, and even in lupus, leukocytoclastic vasculitis can be the histopathological feature. Last case, 4-year-old male, fever for 7 days with erythematous maculopapular rashes all over the body, excessive irritability, unilateral cervical lymphadenopathy, fissuring and redness of lips, and swelling of hands and legs, specifically dorsal edema. So what is the case? Kawasaki disease. So I will not speak in detail because tomorrow we have the entire day on Kawasaki disease. So if I speak, then the organizers, so KD to be continued tomorrow. So thank you. Take home message is vasculitis is multisystemic involvement. The specific age distribution like Kawasaki disease, under 5, IgA vasculitis, older children and adolescent, and GCA is a disease of older individuals. So there are various risk factors that you should take into consideration while taking the history. Thank you.
Thank you, Archan, for the beautiful talk, and the case reports at the end make it more easy for the trainees to understand, hopefully. We are running short of time, so we can have 1 or 2 questions at the maximum. I think they have all understood everything.
Yes. Yes. So we don't get often because those go to surgery department.
and it is
and older age, and so
it is more
pediatric
of
age group we hardly see. Yes, smoking is a risk factor. And
okay, so if no more question, I would again like to thank Archan for the fantastic talk and the organizers for inviting us. Thank you very much.
Thank you.
Next, we have our session on HSP, a gastrology perspective and nephrology perspective. I would like to call on stage our chairperson, Dr. Shumantro Raut, Associate Professor, Pediatric Nephrology, North Bengal Medical College, and Dr. Gautam Ray, Assistant Professor, Pediatric Gastroenterology, PGSSKM.
By chance, Gautam da ki acho? Probably taking lunch. So without wasting much time, we can proceed with the help. Okay, fine. So our next talk will be to continue on the same perspective of rheumatology sessions. At the outset, we'd like to thank the whole rheumatology team of Bengal for this one. So next topic will be on HSP, on amalgamation of 2 topics. Then again, one of the nephro-rheumatology amalgamation. And for that one, 2 hardest speaker, one from nephro team and one from rheumat team, probably will not fight here. So I will like to call upon first with the with the pet gastro team first from Dr. Sneha Dasgupta. She is the assistant professor at ICH and trained at the Elegant Institute of SGPGI. So ma'am, it's yours. We are still hopeful that Gautam will come. So as per ma'am's request, we can start nephro if you agree. So if our gastro speaker agrees, then we can call upon our nephro speaker first. Sanjita, you are ready for that? Okay, then fine. So our next speaker will be from the nephro team, Dr. Sanjita Poddar. She is from ICS, acting as assistant professor currently. And the whole stage is yours. She is one of the hard worker among our Bengal Society of Pediatric Nephrology team. So your stage. Please stick on to the time. Yeah. The topic is on HSP nephritis, the nephro perspective.
Good afternoon. I'm Dr. Songjukta Poddar. I'm a pediatric nephrologist presently working at Institute of Child Health, Kolkata. My work has been done much easier by Dr. Archon Silchar by giving his extensive talk on the vasculitis part. So I'm mainly talking about HSP nephritis. In Institute of Child Health, we have been encountering quite a number of HSP nephritis cases over the last few years during my starting from my fellowship tenure I'm seeing, and now I'm an assistant professor. So during these years, because of this, we have started a study also on HSP nephritis for the prospective, seeing the prospective observational study to see at the clinical features and the presentation treatment details. This was just presented in the last award paper session also. So I'm starting with a case scenario of a 4-year-old boy, a very typical scenario where the child presented with rash over both lower limbs along with abdominal pain for last 3 days, one episode of hematemesis, and pain of both ankle joints. All these followed an episode of viral prodrome. A very clear-cut diagnosis. With the Euler-Pinto-Press criteria, we can diagnose it as a case of HSP. When investigated and examined, the child was having pedal edema, and the investigations, they were more or less normal, but the skin biopsy was showing leukocytoclastic vasculitis with IgA deposit. So here, there is no component of nephritis present in this child. So now what to do? So this child, though the child is not having any nephro involvement at this point, but needs some monitoring for the next 6 months at least, because during the this is the high time that the child may develop some amount of nephro involvement. So at 3 months, there was no renal or external manifestation as such clinically, but when examined and investigated, the child was having hypertension with blood pressure lying around 95th centile. Urine dipstick was protein 2+ and also blood present. Creatinine was rising with a eGFR 63, which was quite low for him. Urine protein creatinine ratio was showing subnephrotic range proteinuria, and urine routine examination was showing microscopic hematuria. So obviously he was developing HSP nephritis, though apparently he looked completely normal. So HSP nephritis, it has been seen that from the onset of the disease, nephritis can develop within the next 2 months in 90% and next 6 months in 97% of the cases. So this is the commonest childhood systemic vasculitis with a preponderance of 3 to 26 per 1 lakh population, with a male preponderance much less in the adults. 1/3 of the HSP cases have developed some amount of nephritis by the next 6 months and affecting children mostly between 3 to 10 years of age. So they have the typical presentation of gross or microscopic hematuria with proteinuria. Sometimes they may present with nephrotic range proteinuria along with hematuria, which is suggestive of a significant histological lesion. So these children may present with as a case of classical nephrotic syndrome with edema, hypoalbuminemia, and nephrotic range proteinuria. Even hematuria may be absent in some cases. Hypertension is a very important factor, and reduced eGFR. A very dreaded presentation of these children is RPGN, rapidly progressive GN, where the eGFR will be going down very fast. Over days to weeks, the child may develop a condition where he may even require kidney replacement therapy, that is dialysis. The risk factors I'm not repeating, already mentioned by Dr. Archan. So diagnosis of HSP nephritis, clinical suspicion can be done depending on the clinical features, but biopsy confirmation is mandatory. There are 2 types of criteria. Presently, the world is following the KDIGO and the IPNA criteria. So IPNA criteria has come up with some updates. So we are presently following the IPNA criteria, which says if the child is having RPGN or nephrotic range proteinuria at presentation, then a biopsy is mandatory. Moderate proteinuria, that is UPCR lying between 1 to 2 for 2 to 4 weeks, then a biopsy. Mild proteinuria, UPCR of more than 0.5, even after RAS inhibitor therapy, that is the AC inhibitors or angiotensin receptor blockers, for 3 to 6 months. If still the proteinuria persists, in that case you have to do a biopsy. And if the proteinuria persists for more than 4 weeks in spite of treatment, then a repeat biopsy may be required. Regarding the histopathology, mesangial hyperproliferation, endothelial hypercellularity, and extensive crescent formation may be found in which is a very poor prognostic factor and may present with RPGN in case of extensive crescent. Immunofluorescence, I would like to mention that it shows predominantly IgA deposition, not exclusively. So there may be deposits of C3 and other immunological factors, but predominantly IgA. Differential diagnosis in case of IgA deposition, there are other conditions also like IgA nephropathy, chronic liver disease, psoriasis and so on. So these cases, they can also have IgA deposition predominantly in their biopsy, but the systemic manifestations, they differ it from other. Regarding the ISKD classification, that is the International Study for Kidney Disease in Children, they have, this classification is mandatory for any case of HSP nephritis undergoing biopsy, because this is very important for the prognostic purpose. As you can see, from class 1 to class 6, as the severity of histological lesions increase, the chances of renal failure increase hand in hand. So regarding the management, every guideline, they talk in same line that there is no role of any prophylactic steroid. So if it is a case of HSP nephritis, 3 factors are very important. One is lifestyle modification, low salt diet, exercise, avoid obesity, and if it is an adolescent age group, then ask for quit smoking. Maintain blood pressure, SBP, below 90th centile. Regarding the management of the proteinuria, the KDIGO guidelines say that UPCR more than 0.2 for more than 3 months, then start RAS inhibitors. RPG and nephrotic range proteinuria or ISKD classification more than equal to 2, then start glucocorticoids. And steroid failure or steroid toxicity, then think of starting other immunosuppressive drugs. IPNA guidelines, they differ a little regarding starting RAS inhibitors. They have asked, they are a little more proactive. So they start RAS inhibitors with if the UPCR is more than 0.2 even at the initiation of the disease. Indications of starting glucocorticoids are rapidly progressive GN. We have to start with IV methylprednisolone pulses, UPCR more than 0.2, or if there is histological risk of progression. They have defined complete remission at resolution of proteinuria, UPCR less than 0.2 in a 24 hours urine collection based on at least 2 urine samples collected 1 month apart with normal eGFR and resolution of hematuria. If the child is in complete remission for at least 1 month and then there is recurrence of hematuria, proteinuria or reduced eGFR or 25% reduction from the baseline of the creatinine, at least in 2 urine samples, then you can take it as a relapse. Follow-up, these children require blood pressure estimation, urine routine examination and eGFR estimation, urine protein quantification. These needs to be done at least 3 to 6 monthly to look for any recurrence. So all the guidelines, they tell us that to maintain this follow-up at least for 5 years. If there is significant component of nephritis, then you have to do it for lifelong. Regarding prognosis, these are mostly adult studies. So they tell us that uncontrolled hypertension and the amount of proteinuria at presentation and hypertension and mean proteinuria during follow-up are predictors of a very poor kidney outcome. Oxford Messi classification doesn't hold true for the prognostication purpose, but if there is E1 lesion, that is endothelial hypercellularity, in that case, the child may have a good response to the initial therapy, but there is a chance that he may progress to CKD in the later life. There is no role of IgA nephropathy prediction tool in predicting the long-term prognosis of the disease. So my take-home message will be, involve a pediatric nephrologist whenever there is a component of nephritis present. Diagnosis of IgA vasculitis nephritis always confirmed by biopsy. ISKD classification is mandatory. Lifestyle modification, blood pressure control and RAS inhibitors. These are the stepping stone for management. There is no role of tonsillectomy or omega-3 fatty acids as mentioned by many Chinese and Japanese protocols. Long-term prognosis of the disease depends on the hypertension and the amount of proteinuria. Thank you. That's my department. We were presently, they are the contributors also in this study. I'm indebted to them. Thank you.
Regarding lifestyle modification, is there any specific, particularly in diet?
Sir, they tell us that you have to maintain a low salt diet. Fat intake should be less than 10 to 15% of the total calorie intake. And other than that, nothing mentioned about protein. No protein restriction is required. This is what? Saturated fat. Yes, yes, sir. Saturated fat.
And any exercise
Yes, at least 30 minutes of moderate exercise that will increase your heart rate.
Nice one. Very nice presentation. And obviously within time, including the question answers, probably for the first time. So many thanks. So the bottom line is for HSP may not be nephritis at onset. So we need to keep our eye open that within next 6 months there can be nephritis which can be subclinical. So if there is slightest doubt, please go to biopsy. The threshold for biopsy is actually low for pediatrics. So now I request my co-chairperson Gautam sir for the, and thank you Sangeeta.
Thank you.
So it is my pleasure to invite Dr. Sneha Dasgupta on stage for delivering her lecture. Sneha is an assistant professor of pediatric gastroenterology at Institute of Child Health in Kolkata, and she's a rising star in Eastern India in pediatric gastroenterology.
As Neha prepares for her presentation, I shall take this opportunity to announce there is a BSPN Con, Bengal Society of Pediatric Nephrology Conference. We are holding it on 8th June here only. So kindly come forward and join hands to learn more about pediatric nephrology also. Thank you.
So just a minute, so on the same tune, on the same venue after just 1 month, we have enough in registration till now, but what we ask that the residents who have shown a very good zeal for presenting their papers here may also do the same thing in the nephro part, so that's why they also get some credits regarding their presentation. So please residents come forward because registration is quite enough for us for the practitioners, they are more keen. And we have quiz also for separately for residents and separately for practitioners. Thanks, over to Gastro team.
Thank you Gautam da for the very kind introduction and thank you to the organizers for giving me this stage. So we'll start off without much ado with the GI perspective of HSP. Very briefly, I'll just discuss the epidemiology. Already 90% of it was discussed by Sanjukta Di. It is the most common systemic vasculitis in children, and around 90% of the cases are reported in children less than 10 years of age. And nearly 40% of these children have GI involvement. Just one word I would like to mention about the pathophysiology. I will not go into these nitty-gritty details. It's just that it's mediated by certain mucosal antigens which inside the dendritic cells of the mucosa-associated lymphoid tissue. As a result, there is formation of the galactose deficient IgA1 antibodies which binds with the antibody complex, and these immune complexes get deposited in the small vasculature of the joint, skin, GI and the glomeruli. So the GI symptoms present as a triad of the symptoms of pain abdomen, GI bleed and the typical palpable purpura, especially of the dependent parts. So first we'll start off with a case scenario. A 7-year-old girl, she presented with severe epigastric pain with melena. So on first suspicion of ulcer bleed, a PPI infusion was started and an urgent upper GI endoscopy was considered. We found extensive erythema, I would say, of the antrum and the pyloric region, some erythema in the fundus, and here we can see a very small ulcer in the part of the D1 with overlying exudates. So initially the other ulcer in the D2, this was having some oozing and bleeding from the visible vessel, so argan plasma coagulation was done. After this procedure, the GI bleeding no doubt subsided, but the child had continued to have pain abdomen. So over the next 48 hours, this child developed a progressive decrease in the urine output, and after this the rash appeared. So all this while we were dealing with a case of IgA vasculitis. This child was started on pulse methylprednisolone, there was no response, and ultimately she responded to I think 2 doses of cyclophosphamide. So although the GI symptoms typically develop 8 to 10 days after the appearance of rash, in 10 to 15% of the cases, GI symptoms may precede the onset of rash and it may present as the initial symptoms, and very occasionally rashes may not be there altogether. And it is more commonly involved in the children as compared to adults. The most common presentation is a pain abdomen followed by nausea, vomiting and GI bleed. Commonly it complicates to develop intussusception, which in turn develops perforation very easily. I will come to that later on. And there are few uncommon GI presentations which we should not miss if we are getting. So that is esophagitis, pancreatitis, gallbladder involvement, and mesenteric ischemia. Due to prolonged ischemia, there may be sequelae of obstruction and stricture of the small bowel. The vasculitic ulcers may ooze, resulting in protein-losing enteropathy. There may be mesenteric vasculitis, which is associated with a high risk of bowel necrosis and massive GI hemorrhage. There may be appendicitis, enteroenteric fistulas, infarction of the bowel wall, intramural hemorrhage. And this low plasma level of factor 13, it is not an uncommon feature. I'm sorry I have mentioned it over here. It is pretty common, and it is like Sanjukta said, and like Dr. Orchon also mentioned in his presentation, it is also associated with very severe GI presentations. And probably the incriminating factors is a consumption consumption due to development of microthrombi, as well as formation of autoantibodies. So this is just a CT image showing double wall appearance of the bowel with extensive submucosal edema. And this is an fistula between the descending colon and the small bowel loops. So abdominal pain is typically colicky. Older children can localize it to the epigastric region, but mostly the younger children, they complain of a diffuse periumbilical pain. There is postprandial worsening of the pain in keeping with vasculitis, and abdomen may be tender and distended and often resembles an acute GI condition. Mostly there is an occult GI bleed. However, in up to 50% of the cases, the GI bleed may be overt. And the most common site of involvement is the duodenum, hence it presents as a melena and small bowel. There is also colonic involvement, which includes petechiae, hyperemia, and aphoid ulcers. So this is the image of the small terminal part of the ileum, which shows extensive erythema. And the next picture is a colonoscopic image, which shows multiple aphthous ulcers studded throughout the lumen mucosa. So intussusception is the most common surgical complication of HSP in childhood, and the most common site is ileo-ileal, with the pathological lead point being intramural hemorrhage and edema. This is in sharp contrast with the idiopathic intussusception of childhood, which presents in children less than 2 years of age, and the most common site is ileocolonic, with the pathological lead point being the hypertrophy of the Peyer's patches of the terminal ileum. So since the lead point is the intramural hemorrhage and edema, it tends to perforate very easily, and if the intussusception persists beyond 24 hours, urgent surgical intervention should be sought in these children before it perforates. There may be hepatobiliary involvement with acute acalculous cholecystitis, hydrops of the gallbladder wall. There may be hepatomegaly associated with elevation of the liver enzymes. But typically, the liver enzymes tend to normalize within 3 to 7 days of corticosteroid therapy. Rare manifestations may be hemorrhagic ascites with serositis and vasculitis of the peribiliary vessels, which ultimately leads to ischemic necrosis and obstructive biliary cirrhosis. So I will not go into the details of this slide. Just one point to note that up to, firstly, in literature, around 40% GI involvement has been reported, although it can go to as high as 70%. Even I think in the ICH data, they have noted a GI involvement up to 70%. And around 20% of these cases may have an occult GI bleed. So in this retrospective single center study of severe gastrointestinal involvement in pediatric IgA vasculitis, it was found there are certain clinical characteristics which correspond significantly to a severe GI involvement. And first of them is being extremes of age, less than 3 years or more than 12 years of age, with location of the skin lesions which proceed to above the waist, vomiting associated with pain abdomen, occult blood positivity, and renal involvement. So having learnt a lesson from the previous case, this was a 13-year-old boy who presented with severe epigastric pain with postprandial exacerbation. Although there was no history of overt GI bleed, this child looked pale. And since we already faced googly in the previous case, I feel, so on retrospect, we took a history of rash. So then the mother came up with a history of rash, but at presentation, this child was not having any. On examination, there was epigastric guarding and tenderness. Pancreatitis was ruled out and an upper GI endoscopy was done, which again revealed these typical erythematous rashes which we see in that antrum. And this was another ulcer in the D2 with some overlying exudates. So, since there was a history of rash, the child was started on pulse methylprednisolone and he was doing well after this. So, how to diagnose? The first modality should be an USG with a Doppler study, which just gives a basic idea of the mesenteric ischemia or status of the mesenteric blood vessels. If there is GI bleed, it is mandatory to go for an upper GI endoscopy and biopsy from the lesions can be taken. A small bowel enteroscopy can be done where there is obscure GI bleed and upper and lower GI examinations are normal. So this is a capsule enteroscopy image showing extensive erythema of the small bowel loops. So in GI involvement of HSP, there are no major studies or no RCTs which have been done to compare the findings and to quantify, or there are no major guidelines also. So this was a small retrospective study of 25 patients, with 6 patients being in the pediatric age group. The most common finding that they found was a erythema and petechiae of the mucosa, followed by erosions and ulceration. And the most common histopathological finding was the extravasation of RBCs. And leukocytoclastic, the typical finding of leukocytoclastic vasculitis, which was only present in 37% of the upper GI and 40% of the lower GI specimens. So, how to treat? NSAIDs are to be considered in children who have arthralgia or arthritis, but it's to be used with caution in children who have presented with GI bleed. Corticosteroids are the first line of treatment. It prevents complications and probably it induces remission earlier. However, its efficacy to prevent severe disease or relapse is very doubtful and controversial. Other agents have been used. Particularly, I would like to mention the use of cyclophosphamide, which we are also using in our institution. However, the clear-cut role has not been established, and azathioprine has no role in the management. Just one small case series of case report mainly of 3 pediatric patients who had factor 13 deficiency with severe GI involvement. These children were treated with cryoprecipitate transfusion and all 3 of them did well. So to summarize, GI symptoms are varied and often may not be associated with rash, and this makes the diagnosis more difficult. So a history, a very good history is to be taken in all these children. And although abdominal pain is the most common symptom, GI bleed can be life-threatening. And adequate immune response, immune suppression is a must. Thank you so much.
Any questions from the floor? Questions?
Sometimes during our practice we find that children taking mefenamic acid with paracetamol comes with some features of vasculitis and they develop like acute nephritis type of symptoms. So which class it is in? What is the classification of this drug-induced rheumatic vasculitis?
In GI involvement, the NSAIDs can develop rash, or ulcers may be present in anywhere all throughout the GI tree.
Sir, if it is usually if it is a drug-induced nephritis or drug-induced DLE even, so as per that common lupus or whatever may be the manifestation, we have to go accordingly. Do a biopsy, prove the lesion. If the lesion is extensive, start other immunosuppressants like steroids or whatever. But may not be true for HSP gastro symptoms what she is referring to. Beyond her extreme,
Pediatric,
right? 3
yes.
to 15, all are pediatrics. Extreme of pediatrics, that she is referring to.
Yes.
So thanks for the gastro option. One more thing, if you are giving steroid for the gastro part, better to give it at least for tapering dose at least for more than 1 month, because few studies have shown if the steroid is given for less than 4 weeks, in due course the nephritis part may exacerbate. So please keep in mind, if you are giving steroid at all for the gastro part, preferably try to give for more than 4 weeks. Thanks.
So one simple question, just a discussion for the students here. When we are considering HSP, the type of pain abdomen that it has, what are the other differentials that we should keep in mind? Just
So obviously when there's
the more common ones.
Yes, when there's an epigastric pain, first and foremost we need to rule out an acute pancreatitis, which may also present with a postprandial exacerbation of the pain. And other than that, there may be gastric ulcers, duodenal ulcers. These are the acute gastritis.
Pain abdomen is severe and it mimics like a peptic ulcer disease,
Yes,
or a
yes.
pancreatitis or a biliary
Yes,
pain.
yes.
And we also
And more commonly, vasculitis also presents with a severe postprandial exacerbation. So,
Thanks to the organizing team, Dr. Jigna and the whole rheumatic team. So session is closed. So next session, please.
Next, we have our session on vaccines in rheumatology. For this, I would like to call on stage our chairpersons, Dr. Joydeep Das, HOD Pediatrics, James Bojboj, and Dr. Mihish Shorkar, Professor of Pediatrics at Medical College, Kolkata.
So very good afternoon. So this is another post-lunch session. So next topic is the vaccines in the pediatric rheumatologic disorder. The speaker is Dr. Suprit Basu, who has done his DM pediatric rheumatology and the immunology from the PTI Chandigarh, and is presently working as the assistant professor in pediatrics in IPGMR Kolkata. Suprit was my student during the BC Roy days, and I'm proud of him. Okay, over to you, Suprit.
Thank you, sir, for the kind introduction. So, no conflicts of interest. In the next 10 minutes, what I will discuss is why this session has been given, the vaccine in rheumatic diseases, what are the barriers to vaccination in pediatric rheumatology, the recent guidelines, both in adult and pediatric rheumatic diseases, and the vaccine recommendations in patients on immunomodulator or immunosuppressive therapy. So, as we all know that all the rheumatic diseases, what we deal are either autoimmune or autoinflammatory in nature, and the treatment is immunosuppressants or the immunomodulators. So, both the disease and its treatment both increase the infection risk, and so to prevent this infection and prevent the mortality, vaccination have gained increasing importance in these patients. However, the immunogenicity and the safety of vaccines may differ compared to a healthy population, and which requires adjustment to vaccination or medication schedule. So first, what are the general principles of vaccination in this patient? So always we have to adhere to the national immunization schedule, and general rules of vaccination applies to this patient as well. The vaccination status, indications for vaccination should be assessed yearly, and preferably this vaccination should be done when the patients are in 100% disease remission or quiescent stage. Vaccination should be administered 2 to 4 weeks before the commencement of immunosuppression, but the main thing is we should not withhold medication or treatment for the vaccination. That is main. We should not withhold treatment, because treatment is essential. So what are the issues in the vaccination of patients with rheumatic diseases? So as I have already discussed that the patients, these rheumatic diseases patients, they are already having a background immunosuppressive status. The drugs are leading to immunosuppression. So there is always a chance of risks of reactivation in case of live vaccines, and there is a chance of vaccine interference with immunosuppressive drugs and vaccine interference with the primary disease. This is a recent study published in Frontiers in Pediatrics, where they have shown that in spite of definitive recommendation by the American Academy of Pediatrics, the EULA, the CDC, there is a strong evidence that these studies have said that inactivated vaccines are safe
and do not increase the risk of disease flare-up, but still there is the vaccination in this immunocompromised or this patients with immune primary these rheumatic diseases, the vaccination is less because there is a major almost 50% of patients or the caregivers, they feel that the vaccines may worsen the underlying illness. So the first and foremost step is to counsel these patients, to talk with the caregivers, and also to counsel, to educate the primary care physicians also, that in these patients what are the vaccines we can give, at what stage, at what dose of the immunosuppressant, and what are the major infections that can be prevented by giving vaccination in these patients, the pneumococcal disease, influenza vaccination, varicella, the reactivation of varicella zoster, and measles. So this is the latest pediatric based guidelines, the Euler Press recommendation for vaccination of pediatric patients with autoimmune inflammatory rheumatic disease, published in 2023. This is an update on 2021. So what are the general principles? As already described, we have to follow the national immunization program. Vaccination should be done in the quiescent phase of the disease. Vaccination should be administered 2 to 4 weeks prior to immunosuppression therapy. But it may not be possible every time because we have to treat the patient. And non-live vaccines, that is the killed vaccines, can be administered to pediatric autoimmune rheumatic diseases, the patients on glucocorticoids and DMARD therapy. And live attenuated vaccines should be avoided in immunosuppressed patients. So the next question comes, which are the immunosuppressed? So EULAR 2021 has given, so the definition of immunosuppressed as per the different drugs. For the prednisolone, cyclophosphamide, so you have to note this is the oral cyclophosphamide, and they have said intravenous monthly pulse dose of cyclophosphamide that is not associated with immunosuppression. This is the oral dose, and the rest of this is the oral one. This is methotrexate, it will be 15 milligram per meter square per week, not per day. And all patients were considered immunosuppressed when using biological DMARDs or targeted synthetic DMARDs. And also they said that patients were considered immunosuppressed.
These are not just primary immunodeficiency. Primary immunodeficiency means that some deficiency is there, and then only these disorders are there. So this disorder can be due to their immunodeficiency also, and because of immune dysregulation also. So there is a spectrum, and if there is a one arm is more strong, then like dysregulation will be more prominent, and if there is a this arm immunodeficiency is a more prominent, then you can have more of immunodeficiency feature. So these immunodeficiency will usually present with recurrent infections, and while immune dysregulations are, you can see that autoimmune cytopenias, lymphoproliferation, malignancy, atopy. So rightly the name is inborn error of immunity nowadays we call, because these are not just a primary immunodeficiency, but for the sake of, because we love this word primary immunodeficiency, and I will use more frequently that word only. So why we are talking about this today at this conference? Because the pediatricians are most likely the first medical professional encountering the patients with inborn immunity. It may be a little bit perhaps open unknowingly, because when we are dealing first time or when we are dealing as episode of these disorders, possibly we are, and so when should be a pediatrician suspect of IE in a child? So this will be a case-based, more of case-based, because the cases make a more difference. So you all aware about the 10 warning signs of primary immunodeficiency by the Jeffrey Model Foundation, and these are no need to mug up these things, because these are common sense. When you are saying that 8 or more than 8-year infection, you will not count that. If there is a 7-year infection, you will not think. But these are just a common sense that if there is a pneumonia, if there is a need of IV antibiotics, family history, and if there are several other things. So these are just a common sense warning sign. So inborn immunity is like, we have recently, almost 2-3 weeks back, this is an update of International Union IUS classification, and these disorders are now counting more than 500 and with 504 different genes. So you can see that how these disorders have evolved. So over the years, in 1980 to now,
the disorders, the number of disorders has increased, and this increment is exponential. If you can see in last 2 years, there are almost more than 60 new disorders have been identified. So this is the word of inborn immunity, and we are seeing many more significant males are affected with several infections, and he was presented with acute meningoencephalitis like presentation also, and had recurrent ear discharges. So at the time of examination, he had no significant lymph node enlargement, absent tonsil you can see, and when there was a recurrent infections, absent tonsil and absent lymph node tissue, and if there are infections which suggest that you will keep a possibility of X-linked agammaglobulinemia in a male child. So there was a pan-hypogammaglobulinemia, and if you can see a lymphocyte subset, almost CD19 is absent, so this is a XLA. So the treatment child was started on regular IVIG, TREF level was maintained more than 500, and you will do physiotherapy and rehabilitation for the bronchiectasis, and vaccination I have, it has been covered by Supreet in a rheumatological disorder, but you will not do the vaccination when child is on IVIG, and live vaccination is definitely contraindicated. So when to suspect IE is that infections with a common organism, if these are recurrent or persistent, if there are severe infection and not responding to usual medications, or if presented with some complications like HLS or occurring in unusual sites. So if there are, in this patient we were suspecting of antibody deficiencies, but the infections can have other manifestations like phagocytic disorder and hyper IgE syndromes. So as a group, you should suspect as IEA when there is unusual infections or infections with opportunistic organisms, infection due to the less virulent organism or vaccine strains like BCG, oral polio, or rotavirus, vaccines which we are giving, and that is causing infections, recurrent sinopulmonary infection or ear discharges, recurrent soft tissue infections, recurrent persistent oral thrush or recurrent diarrhea and dysentery or very early onset IBD. If there is a family history of similar illness, that is a very strong features, autoimmunity, especially polyautoimmunity, severe allergic manifestation like eczema and atopic. We see commonly atopic dermatitis when there is these are refractory to conventional treatment. You will think of feature of lymphoproliferation, if there is a failing to thrive, periodic fevers, dysmorphism with recurrent infection, and if there is a hyperinflammatory state in early stage. So the clues to picking IE is that if there is a clinical features which I have highlighted, if there are laboratory and immunological feature like lymphopenia, or if there is any other, genetics will also helpful at the confirmation of diagnosis. Family history is a very important thing, and while taking the history, we should think that this is one of the very important. If there is a type of organism, also will highlight you that whether you are dealing with primary immunodeficiency and age of presentation age. So broadly, we have a T cell defect, B cell defects, and complement defect and phagocytic defect. So T cell defects, they are the earliest to present. They can be almost all type of infection can be there. B cell defects are usually present beyond 6 months of life, or can be presenting in the child adulthood like a CVID. And they are typically presenting with sinopulmonary infections or predominantly bacterial infections, and complement defects can present with at any age, but they typically present with recurrent systemic infection due to the encapsulated organisms, or phagocytic defect again can present with any age, but early onset are typically seen, and they are having a suppurative skin and soft tissue infections, and bacterial and fungal infection are the predominantly. This is a 17-year-old boy who had symptomatic since 5 years, had recurrent UTI, recurrent episodes of loose stools requiring admission, and he was diagnosed with a celiac disease. But he developed an immune thrombocytopenia and also had a short stature, and there was no history of pneumonia and ear discharge. So you can see that typically this patient had only autoimmune manifestation, and there was a thrombocytopenia. But when we done the immunoglobulins, there was almost a pan-hypogammaglobulinemia. So these disorders are there. So and then low normal B cells and low switch memory B cells was there. So this is a common variable immunodeficiency. It's a common variable immunodeficiency. Name itself suggests that it's a common. The presentation is variable, and it usually presents in adulthood. So the antibody deficiencies are predominantly, you can see A gamma globulinemia, that is XLA or AR hypogamma, CVID phenotype, which is typically present beyond 4 years or in adults, and hyper IgM syndrome, and if there are specific class deficiency or subclass IgG subclass deficiency. Clues are they typically present after 6 months of life, cyanopulmonary infection, predominant bacterial infections, or they typically don't have viral infection, but enteroviral infection is a one infection which can create a problem in these patients, and they can have a significant component of autoimmunity also. So this is a neonate who presented at day 10 of life with thick recurrent oral thrush, had maculopapular rash also, and there was a fever which was ongoing. So then he had absent BCG scar, oral thrush was also present. There was a diaper rash, perianal erythema and peeling of skin, had bilateral crepitation. There was no hepatosplenomegaly. So this is a 3.5-month-old baby who had symptomatic since very early in their life, anemia, neutrophilic leukocytosis, but we carefully will see that there is absolute lymphopenia, which is very important. We should not disregard that if there is a neutrophilic leukocytosis, that is causing the lymphopenia. So this lymphopenia is a severe, and then when we perform the lymphocyte subset, there was a T minus B, B plus NK minus SCID. So this is a consistent with IL2RG mutation. So lymphopenia in infants are very significant because if there is absolute lymphocyte count is less than 3,000 for less than 12 months, it is a significant finding, and this can be because of several reasons. SCID and non-SCID causes of primary immunodeficiency is one of the cause. Severe sepsis can cause lymphopenia, but which is usually a transient, and it is usually improved, and then can be idiopathic T-cell lymphopenia. And in adults more than 1 year, the absolute lymphocyte count less than 1,000 is considered lymphopenia. So the clues for SCID in children are like usually it's present in less than 6 months, recurrent diarrhea. It can present with graft versus host disease or because of non-irradiated blood transfusion. It can have several complications because of vaccination like BCG or varicella. Autoimmunity can be seen in a SCID also, that some typically in a RAG defects, and these patients can be infected by anything. These are the culture media for any organisms. So laboratory features usually typically lymphopenia, reduced globulin. This is a case who had 2-year-old boy symptomatic since 3 months of life. You can see that gluteal abscess, suppurative lymphadenitis, and this infection staph aureus and aspergillus. So the infection profile is different. These are soft tissue and skin infection, suppurative infection, and lung abscess types. And if you can see, the counts are neutrophilic leukocytosis, and platelets are which is hovering around 6 lakhs, ESR CRPs, and rather than hypogamma, you are seeing hypergammaglobulinemia. So which is also very important, that you should not disregard that immunoglobulin higher side is a normal. So that is also an abnormal thing, and when we performed NBT and DHR, that was consistent with CGD. So CGD is if you are a defect in a phagocytic system, this is a machinery responsible for the phagocytic oxidative capacity, and if there is any defect in any of these component, there can be impairment in a phagocytic oxidative. So one more case to show that this was a 13-year-old boy who had doing well till 13 years of age, fever and pain abdomen. He had liver abscess, solitary liver abscess, and organism was isolated as Staphylococcus aureus, and he was treated with IV cloxacillin, and after 1 month he was discharged. After 4 years, he again presented with the same symptomatology and also diagnosed with a liver abscess. He had anemia, neutrophilic leukocytosis, platelets were more than 5 lakhs, and AST LT were also elevated. Again, Staphylococcus aureus was isolated in this patient. So if you can see, there is a recurrent liver abscess, Staphylococcus liver abscess, and other than this, he was doing well actually. So what are the causes of recurrent liver abscess? If we rule out the anatomical defects like recurrent cholangitis or biliary tract injury, diabetes can be the cause, but this is not the case in this patient. So then you have to rule out for the immunodeficiency. So when we performed the HIV ELISA, which is negative, CD4 count was also normal, and immunoglobulin profile again was suggestive of more of on higher side IgG AM. Again, NBT and DHR was suggestive of CGD. So liver abscess, whenever it is coming to you, when if it is not behaving like a normal typical pyogenic liver abscess, and if there is a recurrence of things, then you should rule out the primary immunodeficiency. The clinical presentation of CGD can have both infective and inflammatory manifestations. So infective, I have shown you recurrent lymphadenitis, BCG-itis, recurrent pneumonia, deep-seated abscesses. Inflammatory in form of obstructive or diffuse granuloma, because chronic granulomatous disease, the granuloma formation will be there, and these patients can have chronic inflammatory manifestation in form of colitis, fistula formation, and liver abscess can have both infective component and both inflammatory component in the CGD. So when to suspect phagocytic disorders, they typically present with early in their life with abscesses, suppurative adenitis, gingivitis, and classical organisms are staph, sericea, salmonella. They can have mycobacteria also in our setup. So typically phagocytic disorders are quantitative and qualitative. If there is a neutropenia, you see severe congenital neutropenia, cyclical neutropenia, functional defect in form of CGD, LAD, and other defects. So this is a 2.5-month-old boy, just a spotter that he had a palatal perforation and umbilical sepsis. But if you can see the counts, which is almost a leukemoid reaction, so that suggests the diagnosis which is staring on you as a leukocyte adhesion defect. So again, these patients present with recurrent bacterial infections, non-healing large ulcer, and typically these patients will have no pus formation because there is a defect in neutrophil migration, and history of delayed separation of umbilical cord and extreme neutrophilic leukocytosis, and these patients can have inflammatory complications also. Again, one more example of phagocytic defects is this is a 3-year-old girl who had recurrent episodes of pneumonia, air discharge, oral ulcer, these types of ulcers, and when we are seeing the DLC, there was a significant neutropenia which is less than 500 and which was almost persistent for some time, and when we have plotted for 6 weeks, we typically do whenever and there is a neutropenia, there was some cyclicity was there, and bone marrow was suggestive of maturational arrest, and it was identified as Elan defect in a. So again, to highlight that there is a neutropenia or functional defects. Neutropenias are like severe congenital neutropenia or cyclical neutropenia, functional defect in form of chronic granulomatous disease, leukocyte adhesion defects, and other defects are also in MPO deficiency and CHS. So I'm going to that the tuberculosis is a common infection in India, and when to suspect IEI in these contexts. So this is a case of child who was started at disease onset at around 4.5 months, had BCG adenitis, received ATT for 6 months, then again had pulmonary and abdominal TB, received antitubercular therapy. At 2.5 years had pneumonia, generalized lymphadenopathy. Again, there was a suspicion of TB, but gene experts was negative. So then he had a lytic lesions in left hand that was possibly related to the disseminated BCGosis, and at 6 years age, again pneumonia, sputum EFB was positive. So what we can see is that is a refractory and recurrent tubercular infection. So this was a BCG adenitis, disseminated BCG, and bone TB, and he has received more than 4 courses of ATT. And finally, the whole exome sequencing was identified as a defect in interferon gamma R1, which I will come to that, what are the type of defects. So tuberculosis is a common infection in India, but when to suspect IE in this? If there is a recurrent tuberculosis, even if it is a mycobacterial tuberculosis, but it is coming recurrent again and again, there's a known tubercular mycobacteria, even its first episode, disseminated TB, family history of TB, like now it's, although we take as a family history exposure, but that or TB as a family, if it is occurring like bone TB, and if there is a poor response to ATT, we should think as a underlying primary immunodeficiency. Gene expert is always give a mycobacterium tuberculosis complex. It is not always that it is MTB only. So when things are relevant and in context, we have to think whether we are just dealing with MTB or it is more than MTB. So just I will highlight that in pathophysiology of Mendelian susceptibility to mycobacterial disease, in response to intracellular organisms, the macrophage will. So in response to, I'll just skip this. Yeah. So in response to intracellular organisms, if there is a defect in a crosstalk between macrophage and T lymphocyte, if this pathway is affected, and if there is affection of intracellular killing. So if there is any defect in this pathway, there can be a defective killing of intracellular organism, and these types of disorder, Mendelian susceptibility to mycobacterial disease can occur. So MSMD is a misnomer. It is not just related to TB. It can have any intracellular organism which can have like NTM, non-typhoidal salmonella, or even typhoidal salmonella whenever occurring the more refractory or it is come as a relapse, chronic mucocutaneous candidiasis, and fungal infections and viral infections. So can we consider PID during the first infections? Yes, when we are having a very severe disease, unusual pathogen with unusual severity and unusual pathogen, and if there is a family history to suggest. So we have to pick these patients at first occasion only, and I'll just give a 2 example. This is a 18-month-old boy who previously healthy, presenting with acute febrile illness and right orbital swelling. So this was a first infection at 18 months, but the infection severity is a very significant, and when we took the history, in family history, there was history of death of one maternal uncle in early childhood. There was absent lymph node and tonsil in this child, and there was pan hypogammaglobulinemia. So you can diagnose these patients at first admission or first infection also, but the history is the clue and their severity of infection. This child we have seen recently, child with a severe streptococcal sepsis. So streptococcus pneumoniae we see in and out, but what was the odd is this was a 4-year-old female, had fever for 2 days, headache and vomiting, altered sensorium. So she had a bacterial meningitis, counts were like neutrophilic leukocytosis, Cramp stain was negative, culture in blood culture and CSF culture both grew the streptococcus pneumoniae. So what we were having is, we were having a streptococcus pneumoniae bacteremia, but again with this admission she developed severe cytokine syndrome, so which we have just heard a lecture that, so she had HLH requiring the methylprednisolone pulse and also developed pancytopenia, and when we performed the ANA that was 3+ speckled. So it was not behaving like a, I'll take a 2-3 minutes, sorry for that, because it's difficult to cover in a 20 minutes. So then, so what we were having is that it was not just a plain streptococcus pneumonia infections, it was having a significant HLH and also the autoimmunity, and there was child had developed the rash over the limb, and before that child was absolutely fine. So when we performed the genetics, there was a prolidase deficiency presenting as a severe streptococcus pneumonia infection. So these patients can have a primary immunodeficiency even at the first admission or even at the first infections. You should suspect whenever there is a background to suspect. So if this is a rheumatology conference, and I have to touch on that also, that IE can present to the rheumatologist in 2 ways: seemingly typical rheumatological disease with underlying IE that may be covert like SLE in early complement, or if there is a difficult to diagnose rheumatological manifestation with underlying covert IE. So something like that, we are dealing with some rheumatological disorders, we are unable to diagnose, unable to fit in one category, and that they are not behaving as a conventional rheumatological disorder we should think. So this is a 5-year-old boy who had early onset lupus. Whenever is a less than 5 years lupus, that is almost always we have to think for monogenic lupus, and this was a discoid lupus, had seizures and 2 episodes of pneumonia. Elder sister died of lupus at 7 years, and if you can see, typically they will have C3, C4 would be normal, ANA would be 4+ speckled, and in these patients dsDNA is typically negative, and this was a C1q deficiency lupus. So when to suspect early complement deficiency disorder: early onset, family history and associated infections, or if there is any positivity and anti-dsDNA negativity, that is a clue towards the C1q deficiency lupus. So IEs can be associated with lupus also, that there are several C1 complement deficiency which can be associated. So lupus is not a single disease, and there are several monogenic defects have been identified underlying the lupus, and there is a children with lupus are not behaving as a routine, then we should think of that they are dealing with something. This is a boy with HSP like rash. So we see commonly HSP, but what was the odd thing was that this child had thrombocytopenia, and we don't expect thrombocytopenia and HSP. So this is a presentation of Wiskott-Eldridge syndrome. So Wiskott-Eldridge syndrome can have significant autoimmunity also. This is a child with polyarteritis nodosa. This was a 13-year-old girl who was typically had all the textbook description of all the pan, like perforation beyond that. So but we have treated her as a polyarteritis nodosa, but after 5 years her sibling brother came with the acute painless loss of vision in left eye for 3 days. So this was just a presented central retinal venous occlusion. So when we thought that we are dealing with something which is occurring in family, so we have performed the plasma ID2 activity, and this was almost undetectable. So this is a disorder which is, we have deficiency of, in addition, adenosine deaminase type 2, so DADA2, which can present with fever, polyarteritis nodosa, livedoid racemosa, early onset typical lacunar strokes, and mild immunodeficiency. The spectrum of ADA2 is increasing, so it's not just a vasculopathy and inflammation. They can present with immunodeficiency, and they can present with a hematologist with a bone marrow failure syndrome also. So this is a possibly one of the most common autoinflammatory syndrome in coming years, because we are seeing many more cases in in India. So autoinflammatory syndromes, you have to suspect when they can present in early childhood. It can perinatal onset also, adult onset seen with somatic mutations. Fever is usually a dominant complaint, and there can be uncontrolled systemic or organ-specific inflammations. The skin, joints, serosal membrane, meninges, inner ear, anything can be affected. And this is usually a sterile inflammation, and the cellular infiltrates is predominantly a neutrophil. So these patients can present with fever, rash. There are several overlaps of symptoms. Auto-inflammatory, it's not autoimmunity, so we will not see several autoantibodies. We typically, this is innate immune defects. So this is a case of DIRA. You can see just these patients can just like present with the osteomyelitis like presentations. But this is not an infective osteomyelitis, and we have seen an elegant presentation by Sanjeev Mondal about this. So this is a 20-year-old female symptomatic from 3 years of age, initially diagnosed and treated as a fever and polyarthritis, had bilateral granulomatous uveitis, and in 20 years back we used to diagnose Ponset disease as a diagnosis, but what this child had, this was a bogey swelling and granulomatous uveitis, and nowadays we will be perfectly making the diagnosis of Blau syndrome. So these patients are there, we have to pick these patients. So common things are common, but I is not uncommon. That is the possibility, and always rule out secondary immunodeficiencies also. That should also be important, because secondary immunodeficiencies are much more common than primary immunodeficiencies, like drugs, HIV, nephrotic syndromes can also be. So suspect PID if there is infections are unusual, chronic and recurrent, which I have taken from just Nelson, that if one or more systemic bacterial infection, 2 or more serious respiratory or bacterial infections, serious infection at unusual sites, infection with unusual pathogens, and infection with usual pathogens but of unusual severity, all make sense actually. So when to suspect I, at almost last slide, recurrent, severe, unusual or opportunistic infections, multiple severe or early onset autoimmune disease, unexplained autoinflammatory symptoms, failure to thrive, persistent lymphoproliferation, unexplained cytopenias. So these patients are there in almost all specialty, pulmonologist, gastroenterologist, and so if we are just dealing with the episode, then possibly we will miss these disorders. So as a pediatrician, we need to think beyond infection, beyond sepsis. These disorders are staring you, and you have to diagnose these disorders more commonly. So immunodeficiency disorders, how can we diagnose these disorders? First and foremost is clinical suspicion, not uncommon in clinical practice, I can say you, and diagnosis is essentially clinical. The history is a paramount importance, and do not miss the forest for the trees. Thank you very much.
Thank you very much, sir. It was like a roller coaster ride, but I believe what we see is still the tip of the iceberg. The main inborn errors of immunity still remain to be explored. So, any questions from the audience? Yes.
Came across a case of 3 days old baby with libido racemosai. How should I progress?
3 days old?
3 days old.
So
Typically.
yes, thank you, sir, for the question. So basically, what you are saying, it is libido racemosai in a 3 days old. So that we have to see whether the rash is persistent or not.
No,
First of
it is persistent throughout the up to 1 year of age. That is persistent.
So like just for the libido racemosa, that is not the only presentation of DADA 2, but you have to see in other things also, like whether
nothing else.
So possibly we have to follow these patients and this patient for just see that what follow-up suggests, because that libido racemosa may not be clue for the any other thing.
Any other question? Otherwise, we are running short of time. And thank you, sir. It's excellent. Thank you.
Next, we have a segment on pyrexia of unknown origin, case presentation, followed by discussion by mentor, how to identify rheumatology and immunology in pyrexia of unknown origin to SJIA, SLE and PID. Now I would like to call on stage our chairperson, Dr. Alokendu Ghosh, professor, and one of the senior stalwarts of rheumatology in West Bengal.
Good afternoon. It's a very interesting session. Fever, very challenging for all clinicians, be it an adult practicing clinician, rheumatologist, pediatrician. And from that point, we need to review and we need to explore what is the primary causes. So we have three interesting cases. First is systemic GIA to be presented by Dr. Keka Das, resident from ICH, and mentor is Dr. Jigna Bhatia. So let us hear from Keka and then we'll hear from Jigna.
Good afternoon. I am Dr. Keka Das, postgraduate trainee from Institute of Child Health, Kolkata. I will present a case of pyrexia of unknown origin. 4 years old female presented with fever for 1 month. It was high grade intermittent fever, 2 to 3 spikes per day, but the interfebrile period was, child was active. There was no history of cough, cold, burning micturition, joint pain, rash. There was no history of significant weight loss, bone pain. There is no previous episodes of similar illness in the past. Initially, she had dull aching abdominal pain, received multiple antibiotics outside, but fever didn't subside. She received injection Dextrona for 2 days, followed by fever subsided for 1 day only and discharged. But at home, she continued to having fever spikes and hence admitted in our ICH. At arrival, she was looking pale, sick looking, encephalopathy was there and febrile. Per-abdomen wise, there is soft, liver was palpable 3 cm below the right costal margin and splenomegaly was grade 1 and severe encephalopathy was there. So empirically, injection ceftriaxone, doxycycline started and investigations sent. It shows there is hemoglobin is 9.1, platelet is 81,000 and there is slightly neutrophilic preponderance count. On day 2 of admission, fever spikes continued, antibiotics were upgraded, so too injection meropenem. And now on day 3 of admission, encephalopathy was increased, abdominal distension was also increased. Fever workup, other fever workup came in the meantime. Serology was negative, 3334 were normal, DCT was slightly high, 2 positive, peripheral smear was normal, chest X-ray MAN2 negative, urine culture negative, blood CS no growth. On echocardiography and CSF examination, it was normal. So till now, what are we dealing with? Persistent fever, encephalopathy, abdomen distension, relative pancytopenia, raised inflammatory markers like ESR, raised liver enzymes, raised LDH and ferritin. It is shown in the picture. So both pediatric hematology and rheumatology opinion was taken and on clinical basis it was diagnosed as HLH. In view of HLH, we have administered injection dexamethasone at the rate of 10 milligram per meter square and continued for 48 hours. As a workup for PUO, we have done bone marrow examination which shows hemophagocytes, but there was no blast cell and bone marrow culture also shows no growth. Now, what is the cause of the PUO? So the clinical history was reassessed and it was noted that fever was persisting for 1 month. There was organomegaly, neutrophilic leukocytosis, thrombocytosis, high CRP and ESR. So the final diagnosis is the systemic juvenile idiopathic arteritis presenting with macrophage activation syndrome. So we started methylprednisolone at the rate of 5 milligram per kg per day for 5 days. And now the repeat investigation shows all the leukocytes count came down, platelet count slightly increased, reduction in the CRP and serum ferritin reduced to 1000. So intravenous steroid shifted to oral steroid. On oral steroids, she was observed for 24 hours and she was stable. Platelet count improved slightly higher and to 1.5 lakhs. CRP improved, decreased, and she was planned for discharge on after 10 days. Now she was having again fever spikes. So as a part of systemic features of SGI like fevers with persisting, so we have added injection tocilizumab once fortnightly and first dose was given. But again after admission of the tocilizumab, fever was persisting. Facial puffiness was increased and which was gradually progressive. And we have decided to repeat all the counts and now it is shown again neutrophilic leukocytosis and platelet count is high and SGPT, SGOT was raised. So macrophage activation syndrome was diagnosed and now it is as the mass is persisting, injection soluble increased to 10 milligram per kg per day and oral steroid was advised and now patient is afebrile, observed for 5 days and now patient is afebrile and discharged with stable vitals. Thank you.
Now, Jigna will provide us the important inputs and challenges and from which point the clinician should start thinking that these are the things one should not forget. Yes. And the best part was the patient responded to the therapy and the components of fever, leukocytosis, no infection apparently, very raised ferritin and organomegaly with progressive thrombocytopenia with a macrophage activation syndrome HLH, and there was another surge and ultimately patient responded. That was really brilliant.
So actually it was not as simple as she showed it, and it was like a roller coaster, a 1 month admission. And this POO session was basically, I had thought of it because the POOs are the most difficult to diagnose, and it is very much important that we all know how to catch up these kind of patients so that we can start managing them early. And this particular case was actually a learning point for me also. It was a case which was referred to us when I was a fellow, and obviously even I diagnosed it as HLH because at that time the child was slightly encephalopathic. The child came with us with a history of fever for a long. I didn't realize it was 1 month, but it was like I knew that the fever was ongoing, the counts were falling, the ESR was slightly low, CRP was high, there was hepatopathy, encephalopathic, like subclinical mass we thought, and we like yes, we should go forward with dexamethasone. And then next day, obviously, sir came in and we relooked the entire history. So a fever of 1 month duration, thoroughly investigated even prior to coming to us. No infective focus, no cultures were all negative. Antibiotics were given very well in advance. Still the fever is persisting. We have to look beyond infection always. So what made us think about something beyond infection in this child? A prolonged fever, and if we see the very first investigation, which I have marked in red, there is raised TLC, there is raised neutrophils, the platelets are high, the hemoglobin is modestly low, and the child in the history, we saw that for such a high level of inflammatory markers, she remained relatively stable. And there was no infective focus, and obviously when she came to us, she had mass. So for us at that time, it is systemic GIA. So why are we calling it systemic GIA? Just on the basis of fever and blood investigations. But this was the old definition of SGIA as we know it. It was arthritis with fever of 2 weeks duration with evanescent rash, generalized lymphadenopathy, hepatosplenomegaly, or serositis. But what is the fallacy in this is that we miss a whole other spectrum of patients. And we have faced these patients. These are some cases that we have actually had a lot of time diagnosing because of the presence of those kind of criteria. patients who have only serositis as the initial manifestation. We have had a patient who had only fever and ascites and pleural effusion. For a month or two, was only getting antibiotics after antibiotics, and then the subtle lymphadenopathy. It was just then, it took a hard time convincing that we should have to hit with steroids and other immunomodulators. It was much after we started steroids that the arthritis came in. So another one is fever as the only manifestation. So this is a case which was discussed, I think ma'am is sitting here. She also has a similar case. Only fever and raised inflammatory markers. We have another case presently admitted, fever, raised inflammatory markers, but a very small child. But with that kind of inflammation, the child is pretty much active. And the child responds to antibiotics, goes back home, comes back again within a few days with similar findings. Fever with lymphadenopathy is the only manifestations. Again, so this can lead into a lot of rheumatological conditions, but the next one is also similar, but again, this can also be initial manifestation of SGIA, and we should look into the bloods very detailed. We should take into consideration the inflammatory markers. So this is the new criteria which has come up now, classification criteria as they say. Fever of unknown origin with major criteria, evanescent rash, arthritis, and the minor criteria, lymphadenopathy, hepatosplenomegaly, serositis, and now they have also included arthralgia. So, and there is leukocytosis with neutrophilia. Even though 2 major plus, if we see 2 major or 1 major plus 2 minor, we will still miss out a big spectrum of patients, but it is still a good guide. So, yet there are some red flag signs we should always look into in a case of PUO. A sick child. The SGI children will be relatively less sick. If it's a sick child, might be mass or just consider other infections or malignancies. Night pains. Night pains, be very cautious. Disproportionate anemia. In SGIA, the hemoglobin will not be as low. So if there's disproportionate anemia, we have to again take it with a pinch of salt. If there are matted lymph nodes, so again, you have to consider tuberculosis. Abnormal lymph nodes or retroperitoneal lymph nodes, hypertension, so that could go into neuroblastoma. This is actually again another recent case referred to us. There was fever, limb pain. We were referred to as, it was referred as joint pain, but we saw it as lymph pain, then night pains, and there were osteolytic lesions. So osteolytic lesions, again, and hypertension. Be very careful. And early onset diseases, another spectrum where we have to look into the autoinflammatory conditions, the genetic ones. So how to identify SGI and PUO? This is a very broad overlook to it. Fever of at least 15 days. They do not look that sick. Raised inflammatory markers and no infective focus identified. And please, we have to go into everything. We have to do the chest X-ray to see if there are any mediastinal enlargement. We also, another case I saw, fever not going down. They asked me to have a look. I said, I think USG is still left, give naproxen and let's have a look. And there you go, it was liver abscess. So ultrasound, blood pressure, eye examination, if in doubt, go all out. Do everything in hand, bone marrow, CT, PET CT, whatever you want to do. But then steroid should also be considered, but be very cautious before giving it. Do your bone marrow and then give, if at all, or timely referral, I would say. So be cautious, but do not put SGIA in oblivion.
Thank you, Jigna, for wonderful analysis. Certainly, lining point should be fever, arthritis, leukocytosis in absence of infection. For adult, one additional symptom we get sore throat in absence of any apparent pathology, with quote-unquote raised ASO, with a quote-unquote pentit being tried repeatedly, no response. So this is important, serositis. And as she was telling, the usage of steroids certainly is a both-way sword. When to start, and another in adult, how long to continue. We have burnt our finger with withdrawal of steroids after a couple of months, and there is relapse of fever. So this is really a very important clinical challenge in pediatric as well as in adult patient presenting with fever, arthritis with leukocytosis without any apparent cause at that point of time. Thank you. Thank you so very much. So let's move to the second case. Ria, Dr. Ria Singh, Fellow Pediatric Rheumatology. She will present SLE. Another very important challenge of fever in SLE. Fever for infection in a given SLE or fever for lupus flare. Steroid to hike or steroid to reduce. And that becomes really a challenge at that point of time. Yes, Ria.
Good afternoon, everyone. So we have 15-year female child who presented to us with complaints of swelling in both sides of neck for last 2 years, loss of weight for over last 2 years, headache and daily fever for past 4 months, decreased activity, apathy with tremors and arthralgia in multiple joints for last 1 month. So the course started in 2021 when the child had a complaint of bilateral neck swelling. On examination, there was generalized lymphadenopathy. Examination by other investigations, CRP was negative, CBNAT was negative, and to rule out tuberculosis. FNAC and excision biopsy was done, which was suggestive of reactive lymphadenopathy. The child was started on oral antibiotics and paracetamol. There was no improvement in child's condition. Over next 1 year, the child had persistent neck swelling. So the child was re-evaluated. Again, the CRP was negative. Blood hemoglobin was 12. Total counts were 7,000. ESR was around 16. Chest X-ray was normal. CBNAT was done twice, which was negative. FNAC done twice, suggestive of reactive lymphadenopathy. And excision biopsy was done again, which was again suggestive of reactive hyperplasia. The child was again treated with multiple oral antibiotics, but there was no improvement. Over next 1 year, the child started having complaints of fever with persistent lymphadenopathy, headache, altered sensorium, arthralgia, chest pain, and weight loss. On investigation, CECT neck was suggestive of enlarged cervical and bilateral axillary lymph nodes. PET-CT was done, suggestive of lymphoproliferative disorder. ESR was 22, serology was negative. But with a significant family history of 3 siblings having tuberculosis in past, the child was considered to have disseminated tuberculosis and started on anti-tubercular drugs. Over 1 month, the child did not improve. She had persistent fever, vomiting, abdominal pain, and altered sensorium with tremors. And this time, investigations showed anemia with WBC count 3,900, neutrophilic, and she was then with hypoalbuminemia, and she was admitted with us. So there was no history of any cough, rash, oral ulcers, and no history of any night pain or joint swelling. On examination, there was generalized lymphadenopathy. Child was thin-built cachexic with oral ulcers on examination. On systemic examination, the GCS was 10/15. Child was drowsy and lethargic, though vitals were stable. So the child was admitted with plan of repeat lymph node biopsy to rule out malignancy and was started on symptomatic management with continuation of anti-tubercular drugs. But due to continuous deterioration in sensorium, the child rheumatology opinion was taken, and on examination, non-painful oral ulcers were seen. Echo was done, which was suggestive of pericardial effusion. So she was diagnosed probably like SLE and started on methylprednisolone 5 mg per kg. In due course, other investigations were done, which was suggestive of low complements, DCT positive, ANA positive, dsDNA positive, APLA beta-2 GP IgM was positive. There was no renal involvement. CSF analysis was normal. Eye examination was normal. So with these investigations, and with the background of prolonged fever, lymphadenopathy, palatal ulcer, and mild pericardial effusion with low hemoglobin, low TLC count, normal CRP, and raised ESR in a 15-year-old girl, diagnosis of SLE was made. After methylprednisolone of 5 days, child was afebrile, but there was minimum improvement in sensorium, so injection cyclophosphamide was given. After a few days, there was minor improvement, but child had new onset seizures. So anti-epileptic was started and aspirin was started. MRI brain was done, which was suggestive of multiple small subcortical white matter signal abnormalities, query ischemic or demyelinating with diffuse brain shrinkage.
Rituximab, first dose was given, followed by second dose 15 days apart. Gradually, the GCS improved, but child had persistence of mild diffuse dull aching headache. MMF was started initially and the child was discharged. Investigation-wise, there was low hemoglobin, leukopenia, ESR was 90, albumin was 2.3, SGOT, SGPT was raised, LDH raised, and complements were low, and echo was suggestive of mild MRTR with mild pericardial effusion. So diagnosis of neuropsychiatric systemic lupus erythematosus was made. On OPD follow-up, the currently child is on full dose of MMF. She remained in remission and follow-up investigations were normal. Repeat APLA profile was negative, hence aspirin was stopped. She had persistence of headache for which flunarizine was added. And as of now in 2025, Levipil has been omitted, steroids tapered and omitted, and currently she is on MMF and HCQ. Thank you.
Thank you very much, Ria. 2/3 of the time, neurologic manifestations in lupus is not due to SLE. That's one learning point one should not forget. And neurologic manifestation in lupus needs to be, the other differential needs to be excluded. You have not mentioned, possibly you have done the CSF. So that is one important point where we need to rule out the infection. And a third important part is certainly after excluding the mimickers in neurologic manifestation in given patient. This was also another challenge in the sense the initial manifestation gradually did not point towards lupus, and ultimately when fever was not responding and progressive cytopenia, at that point started thinking for autoimmunity. And your laboratory investigation profile, complements were in the top. Complements certainly was done after ANA and DSDN, I think. Not at the top. We do not ask for complement first, then ANA, then DSDN like that. So that's an important point. This is really, again, a very important issues in the given patient of lupus who presents with these sorts of all overlapping manifestations, and to identify that one, because that point of time immunosuppression, corticosteroid plus cyclo or retax or MMF, whatever we plan. May I request Professor Suparna Goth to analyze and give us the insight.
So thank you, Ria. You've made the task easier. So just to recap, so this was a 15-year-old child who presented with generalized lymphadenopathy for over 1.5 years. She was having constitutional symptoms on and often. Labs were unremarkable. Serology done several times did not yield any evidence of infection. And this child also underwent, surprisingly, biopsy, excisional biopsy and FNAC several times, and just revealed reactive hyperplasia. She was just given symptomatic treatment with antibiotics, and the response was unremarkable. So what are the possibilities in this background of 15-year-old child who is coming with generalized lymphadenopathy plus minus constitutional symptoms? In a tropical country like ours, of course, we will first think of tuberculosis, but tuberculosis was extensively worked up. It was negative. There was no evidence of any granuloma in the lymph nodes, and all investigations did not yield any positive result. Another possibility was an EBV. That was also ruled out. CMV was another possibility that was also checked. Now we come to malignancy. A child having leukemia suffering for 1.5 years without getting any steroids is quite unlikely. So leukemia goes down the line. Then comes our lymphomas. The excision biopsy done several times did not reveal any evidence of lymphoma. PET-CT also was inconclusive. So by now we have reached a conclusion that the child is suffering from some non-infective inflammatory condition. It may be lupus, it may be sarcoid, it may be a Sjogren, or it may be an IgG4 related disease. So let's see what happens next. The child was carrying on this way for about 1.5 to 2 years, but something was not well with the child. She started developing fever, which was occurring almost daily. There was significant weight loss according to the parents, and there was a multi-system involvement in the form of aches and pains, arthralgia. She was having pain abdomen. So there was something more to infection. Then she started developing headache altered sensorium just prior to admission and developed abnormal movements. With a strong positive history of tuberculosis in the family, the treating team was tempted to start ATD, which I think was justified according to their scenario at that time. They started ATD. But let us recap the case from the very beginning. Did we miss something? This was an adolescent child, a female girl, having polyarthralgia, multi-system involvement, no evidence of infection, worked up extensively, no evidence of malignancy, underwent excision biopsy, FNAC several times. So that was the time when the bell should have rung that we should think beyond infections. Ultimately, the eye of the storm was identified. She was admitted, there were cytopenias, the DCT was positive, ESR was high with a low CRP, transaminitis and serositis. And then they went for the ANA, anti-dsDNA, which were positive, and complements turned out to be low. So lymphadenopathy in lupus, as we see, it is not mentioned in any of the criteria. Neither the ACR nor the EULAR criteria mentions lymphadenopathy as a clinical criteria, but it is not very uncommon. It may occur in about 20 to 30% of cases. Either it may occur at the onset or at the time of relapse. And usually when present only with generalized lymphadenopathy, we must, for long-standing duration, especially in this background, we must keep in mind the possibility of a connective tissue disorder, especially lupus. And these children usually have high disease activity, low complements, positive anti-dsDNA, and the lymphadenopathy which we were seeing in this child was basically inflammatory in nature. So just to say that this is another child of ours who is currently admitted. The picture above is when she was 4 years old, she was diagnosed with lupus, and the complaint was recurrent parotitis. Since it was a very early onset, we also went for a whole exome sequencing to rule out monogenic lupus, but did not yield any result. By 8 years of age, she had developed refractory thrombocytopenia, class 5 nephritis. She was put on MMF, rituximab. She was doing quite well for a pretty long time. In fact, we had stopped her steroids, and she was on Ritux prophylaxis. February 2025, she gets admitted with high fever for 10 days, and there is generalized lymphadenopathy. We ruled out all infections. We did an excision biopsy. All EBV, CMV, everything was ruled out, and the SLEDAI, which a couple of months back was almost 2 or 3, by this time had become 12. So basically it was SLE flare presenting with just lymphadenopathy. She did not have any other features, and she responded remarkably to steroids. So PUO, when do we think of SLE? When to suspect? Adolescent children, especially female, having a prolonged fever, multi-system involvement. It may either be a minor organ involvement in the form of skin or a musculoskeletal pain, or there may be major organ involvement in the form of CNS vasculitis, as Sir was saying. There may be expulsive hemoptysis presenting with DAH, or there may be also nephritis. Labs, you will usually get cytopenias, especially look for lymphopenia. ESR is high with a low CRP. CRP hovers around about 10, 12. Sometimes it is raised if there is serositis, infections, mass, or even arthritis. And in this type of scenario, always do a proper urine. We do not need fancy tests, as Suma had said, to diagnose rheumatological disease. A basic blood count, a basic urine. Look for the urine RE, look for the RBC, the protein, and the active sediments. Skin often is a window to lupus. See, these are the acute manifestations, the cutaneous manifestations which we see in lupus, the typical malar rash with the sparing of the nasolabial furrow, the palatal ulcers, but sometimes it may not be so benign like this child. She had presented with a fever of almost 3 weeks. And when she came to us, she had these ugly looking mucocutaneous involvement. And mother also complained that of recent she was losing her scalp hair, and you can appreciate the frontal baldness. It was acute lupus presenting with tense. This was a patient who presented about a couple of years back with this type of rash, and she was absolutely in severe psychosis. Just, I have purposefully highlighted the eyes. She had a vacant look, and she was so much psychotic, delirious, that the nursing staff were petrified, that they used to ask me, "Madam, when will she be discharged? She's just going around the ward at night and doing whatnot in the ward." So she had presented only with PO and psychosis in this rash. Ultimately, ANA positive, dsDNA positive, later also went on to develop nephritis. And this is a picture after treatment. She has quietened down, but her only complaint is that she has lost her hair, as DLE gives rise to a scarring alopecia, but we have promised her to buy a beautiful wig. This is another child, an 8-year-old female who presented with fever for almost 2 weeks, had severe pain abdomen. She was diagnosed as a case of acute pancreatitis going by the labs, treated conservatively, went home, but something was not well. She kept on coming back to several physicians with the complaint of fever and pain abdomen. And if you can just look at the serial counts, appreciate the low counts and the lymphopenia, the platelet count is on the lower side. Someone seeing the last report, the pancytopenia, ordered a ferritin, which came out to be 1800, and thought that is a case of mass, gave DEXA. The child responded temporarily, again to come back with the recurrent symptoms. Ultimately, ANA positive, anti-dsDNA positive, later on developed nephritis. This is another child, a 12-year-old female who had fever for about 1 month. She was having fever, and she actually came from a very poor socioeconomic condition, and the parents were not much worried about her, but the reason of coming to the ER was severe respiratory distress. She was in failure and was throwing fits. Initially, she was resuscitated, anti-epileptic givings, decongestant treatment started, and a bedside, nowadays we have POCUS. Everyone is doing bedside ultrasonography, bedside echo. So bedside echocardiography actually picked up vegetations in the posterior mitral leaflet. And then it was on the background of bicytopenia, high ESR, somewhat high CRP, active urinary sediments. The diagnosis of the treating team was infective endocarditis, possibly rheumatic in origin. Started broad spectrum antibiotics, but after 48 hours also, the child was not improved. Actually, she was sinking. The serositis worsened, the heart failure worsened, and the cultures were sterile. So it was now time to pull up our socks and revise our diagnosis. She was an adolescent female, a multi-system involvement, bicytopenia, active urinary sediments. ANA was ordered, which came out to be strongly positive, anti-dsDNA positive, and since she had these focal seizures, we also went and did APLA screening, which came to be positive, and actually the endocarditis, which was picked up in the echo, was a non-infective endocarditis. This occurs in lupus patients with a background positivity of APLA. So this is the Euler criteria for lupus, but we must remember that this is a classification criteria for research. We do not use this criteria to diagnose our patients. So lupus is a journey. There are constellations of signs and symptoms which may not occur simultaneously. They may actually evolve over a period of time. Our job as clinicians is to connect the dots, unmask the mask, and ultimately reach to a destination. Thank you.
Thank you. Thank you very much for presenting another very challenging and interesting case. So again, fever in lupus is always a difficult situation, and people have tried with many biomarkers, but everything failed. So only the clinician should give the insight to pick the primary cause. Thank you. May we go to the last case, Shukalpa, resident IPGMER, presentation of PID. We have heard a very beautiful presentation of PID just a couple of minutes back.
Good afternoon, faculties and delegates. Myself, Dr. Shukalpa Sarkar from IPJMR at SSKM Hospital. My case is PUO to PID. So here is the case. 3 years, 3 months old male child resident of Murshidabad, West Bengal, presented to our ER with history of recurrent fever and respiratory tract infection since 10 months of age. So at 10 months, child developed fever, which was high grade, 2 to 3 spikes per day, and relieved with medication. This time, child was managed conservatively. At 14 months, child developed acute gastroenteritis with sepsis, progressive pallor, hepatosplenomegaly. The child required hospital admission and received IV antimicrobials and 1 unit PRBC transfusion. So in the lab investigation, the retic count was high and direct Coombs test was 2+ and LDH was high, suggestive of autoimmune hemolytic anemia. At 22 months of age, child again developed fever with respiratory distress. This time again child required hospital admission and diagnosed with pneumonia with right-sided pneumothorax. So from 2 years to 3 years of age, child developed recurrent pneumonia for which he required multiple times of hospitalization and treated with IV antimicrobials and oxygen support. Sometimes he required NIV support. So child was immunized till 3 years of age as per national immunization schedule. In the family history, we can see that this child is a second born out of second degree consanguineous marriage. General examination. At 3 years, 3 months of age, child presented to our ER. Then that time the child had failure to thrive, severe respiratory distress and grade 2 clubbing, as we can see in this picture. In the systemic examination, child had bilateral wheeze, scrapes, severe suprasternal, intercostal and subcostal retraction. Other system investigation was within normal limit. So here is the case. 3 years, 3 month old, developmentally normal and immunized till 3 years of child. Symptomatic since 10 months of age. There was history of consanguinity, second degree consanguinity, history of recurrent pneumonia, child had failure to thrive, and on examination, child had clubbing. So what could be the differentials? Firstly, respiratory pathology in which cystic fibrosis, primary ciliary dyskinesia. Secondly, immunodeficiency diseases that can be primary or secondary. Third, congenital heart disease. Fourth, surgical cause like tracheoesophageal fistula. In the investigation revealed, there was absolute lymphocyte count low in the hemogram. Liver function test, kidney function test was within normal limit. There was high inflammatory markers. CFTR gene was done to rule out cystic fibrosis. 2D echocardiography was done to rule out heart diseases. HRCT thorax was done showing bilateral tubular bronchiectasis changes. Here is the HRCT showing the bronchiectasis changes. Immunological investigation was done. HIV was non-reactive. Immunoglobulin profile was within normal limit. Then lymphocyte subset was done, in which we can see there was reduced absolute B cell, T cell, but normal NK cell. In the T cell immunophenotyping, there was markedly reduced naive helper and cytotoxic T cells. In the B cell immunophenotyping, there is reduced switched memory B cell. So in the background of severe absolute lymphocyte count, naive, markedly reduced naive T cell, whole exome sequencing was done showing RAG1 mutation. So the child was diagnosed with severe combined immunodeficiency with RAG1 mutation. And child was started with monthly IVIG therapy, cotrimoxazole and itraconazole prophylaxis, isoniazid and rifampicin prophylaxis, and planned for hematopoietic stem cell transplantation. Further course, on IVIG therapy, child was doing well. There was no further recurrence. But after 12 months of therapy, child developed severe respiratory distress, progressive pallor, fatigue, and cola-colored urine. In the investigation, there was severe anemia, high retic, high LDH, and indirect bilirubin level. The DCT was 4+. So the child developed autoimmune hemolytic anemia, and this time child was treated with a PRBC transfusion, IVIG, and IV dexamethasone. The hemoglobin was stabilized and child was discharged. Current status, now child is doing well. on steroid tapering, azathioprine added, and we are planning for HLA typing and further hematopoietic stem cells transplantation, and child is on monthly IVIG therapy. So autoimmunity in RAG-SKID. So there can be two types of mutation, null mutation and hypomorphic RAG mutation. In the null mutation, there is no T cell and B cell, and this child is usually dies in the earlier infancy. In the hypomorphic RAG mutation, there is generation of autoreactive T cell and B cell due to abnormal central and peripheral tolerance. So, the clinical features of immunodysregulation are autoimmune cytopenias, granulomas of skin and internal organs, IBD, skin disease, vasculitis, and so on. Thank you.
Thank you, Shukalpa. It's really a brilliant one again. SCID followed by autoimmune hemolytic anemia in a given patient. Shuprit will now pick up the clinical pulse for all of us.
So this patient, basically what we know is SKID is a medical emergency. So once you diagnose SKID, we should go for the definitive therapy, that is the hematopoietic stem cell transplant, and everything rest is, that's only time buying. So in this patient, so in this patient, and this patient presented to us at 3 years, 3 months old. The child had 15 to 16 episodes of hospital admission due to pneumonia. And every time during the pneumonia, as already Rakesh has said in the previous presentation, that we are looking at only neutrophilic leukocytosis, but we are not looking at the lymphopenia part. So always whenever we are seeing any patient with recurrent infection, a suggestive family history, history of consanguinity, atypical infection, infection by pneumocystis, infection by cytomegalovirus, EBV infection. So atypical infection at atypical site, and which is not responding to our usual course of antimicrobials, which is taking a prolonged time. So always we have to think that this is not normal. A patient with liver abscess, recurrent liver abscess, patient with brain abscess, so unusual size, these are not normal, and so we should investigate for underlying inborn errors of immunity. So for this type of patient of severe combined immune deficiency or combined defect, what we can do, the best and the easiest investigation everybody has is the complete hemogram, and we should look for lymphopenia. Anything, any infant with an absolute lymphocyte count of less than 3000, and if it is persistent, yes, for sepsis, temporarily you can get a low lymphocyte count. But if it is persistent, when the child is not septic, then also if the lymphocyte count is low, so we should think that this is not normal, and we should make a habit of looking at the lymphocyte count, absolute lymphocyte count. And if we get a lymphopenia, the next best investigation is a lymphocyte subset. Yes, it is not available everywhere. It is a flow cytometry based test, but we should try, and hopefully in the next 1 or 2 months in our institute in IPJMER, we will be having the flow cytometry investigation free of cost under the National Policy for Rare Disease. So whenever we have a lymphocyte subset, so then we will see whether it is like T minus, B plus or NK minus, and then we will categorize, and whatever is the category of this lymphopenia and the lymphocyte subset, then we have to do a whole exome sequencing to find out the mutation. And what are the manifestations of typical SKID? So early infancy, age of onset is early infancy, failure to thrive, persistent diarrhea, severe pneumonia, oral thrush, persistent oral thrush. A newborn can have oral thrush, but persistent oral thrush in a 2-year-old child. So that is not normal. And what are the opportunistic infection? As already discussed, that pneumocystis infection, disseminated BCG infection, disseminated CMV, herpes, fungal infection. So these are the signature organisms. If we have a patient with pneumocystis, the etiology are very narrow. One is the secondary immunodeficiency, HIV, or this T cell defect and hyper IgM syndrome. So to conclude, always we have to look at the lymphocyte count. CBC can give an important clue to underlying immune deficiency. Persistent lymphopenia is a pointer towards SCID, and some form of SCID can have broad spectrum of presentation. Like in this patient, they do not present early within 6 months of age, and these are the patients who are really tough to diagnose. This is known as atypical SCID, and so we have to have a higher index of suspicion for diagnosis of these cases. Thank you.
Thank you, Shuprit. It's another very nice case. And sick child, lymphopenia with normal immunoglobulin. These are the components when one should start thinking, and one can pinpoint from clinical point of view and some primary investigation. Nothing more is required. Thank you so very much. Can you have one or two comments? Shuma? No. Yeah. Thank you. Anybody? Thank you so very much. We can conclude the session.
Next, we have a session on medical ethics. I would like to call upon stage our chairperson, Dr. Orchon Shil.
So nowadays there are a lot of litigations against the doctors, medical legal issues. So medical ethics is a very important topic. And I would like to invite Dr. Shomik Ghosh. He is a senior consultant pediatrician at Manipal Hospital, Salt Lake, Kolkata. He has special interest in medical legal and medical ethics and adolescent. And he is the Honorable Secretary of Adolescent Health Academy. Welcome, sir, Dr. Shomik Ghosh. And we are happy to have you in this forum and session on medical ethics. Over to you, sir. Thank you.
Thank you, Orchon, and thank you to the organizers for this wonderful opportunity. Probably a necessary respite from whatever has been going on, but it's really gratifying to see these subchapters really blossoming and with a dedicated audience. So while we pursue our professions in whatever way, we have to give ourselves a timely reminder as to whether we are practicing ethically and legally. So just to throw a little bit of light on this, next slide. Swipe. So just to give you an overview, so while we're talking about medical ethics, you probably have heard this before, but it's worth reiterating, it's worth re-emphasizing that it always depends upon the 4 pillars. Whatever we do should follow the pillars of beneficence, non-maleficence, justice, and autonomy. So what do we mean by all these pillars? Beneficence just means that whatever you're doing for your patient should be for the good of the patient. If you are stuck in a situation where you really cannot prolong the life of the patient, where there are questions on to whether carrying on the treatment will affect the quality of the life of the patient, you have to answer to yourself that I should be doing no further harm in the care of the patient. When we talk about justice, we have to be very, very clear. We are here irrespective of social status, irrespective of caste, creed, or even religion. And finally, every individual has to be respected for his or her views, her principles, and we must understand that whatever is my teaching, whatever is my knowledge, can only be executed on a patient if it has the concurrence of the patient. The autonomy of the patient's choice is paramount. While we talk about medical ethics, we have to be keeping in mind that we are dealing with someone who has come to us at his or her most vulnerable moment in life. we have to maintain the confidentiality of the patients, save aside the occasional situations where, in the larger interests, confidentiality may be sacrificed. But by and large, maintaining the confidentiality is of paramount importance. What do we mean by capacity? We should have the ability as a physician to judge as to whether the patient is in a position to understand what we are intending to offer as a treatment. Whether the patient is being able to process all the information that we are giving him, and whether after processing, the patient is giving us an informed consent. This consent can be in various forms. It could be verbal, it could be written, it could be implied. But what is important as a physician is, whatever we are doing, it has to have the consent of the recipient. How would you define a medico-legal case? In very, very simple terms, you've done a history, you've done a physical examination, and you feel that for the correct dispensation of treatment, the law of the land has to be invoked so that justice is done. That is where you talk about a medico-legal case. What are the duties of a registered medical practitioner? I'll be more than willing to share my slides with anyone who is interested, so I won't read through the slides. What is important is that the life has to be saved first. You can think about a lot of medico-legal implications, but when the patient is in front of you, please institute the ABC, and then you can think about the MLC, right? A registered medical practitioner is one who should be doing the initial assessment. There should be no compromise as to whether the case needs an MLC or not, but please remember, all of that is after the ABC of life, the airway, the breathing, and the circulation has been established. What you must remember is, as a doctor, if you ever decide that this case requires a medico-legal registration, you do not need the consent of the family members. You have your list. Like I said, I'm not going to be reading out everything, but this list of medico-legal cases, whether it's an accident, whether it's an assault, whether it's a burn, whether it's a poisoning, whether it's a sexual offense, whether it is a child abuse, whether it is a domestic violence, once you have put your finger that any one of these is a possibility, please invoke the law. So we can be talking theory for long periods of time. Let us see, whatever we have discussed till now, how it can be applied to a particular case. And this is something I had the misfortune of dealing with about 5 years back. So there was a 12-year-old girl who presented to the outpatient department of my hospital with incessant vomiting. The investigations revealed a gestational sac of 8 weeks of age with cardiac pulsation. So as you can realize, the entire gamut of medico-legal implications with all its challenges is there enshrined in this one single case. So again, first and foremost, much as we get shocked by what has happened, the first and foremost thought should be, I have to save this child from this unnatural event. Reporting, as we all know, under the POCSO Act, is absolutely compulsory. Please don't have any questions whether the parents are willing, not willing, anybody else is willing, not willing, whether the police is going to follow up the case or not. Your job is at stake, your registration is at stake if you do not report. How to break the news? we have all learned communication skills. Communication skills, not only for a completely morbid illness or a mortality, this is a very difficult situation. And we don't really manage to do it very well if we are completely honest with ourselves. So breaking of the news is an art which I will request all present over here to cultivate. There is not going to be a single uniform, one size fits all kind of a communication skill. It has to be tailored to the situation. It has to be tailored to the recipient. And obviously, this is an ultimate challenge where you are going to be challenged to navigate all the ethics amongst very, very choppy legal compulsions. So what are the challenges to applying ethics over here? So in this particular case, beneficence, you have to. This is a poor little girl of 12 years, deserves my best efforts so that the child is saved and is relieved of the problem. I am going to be doing no harm to the child, but in the execution of the law, if the offender has to be punished, I have to, as a doctor, report and help in the dispensation of justice. So justice, if it has to be distributed here or dispensed, one has to be firm with what one needs to do. If you get into the mindset, let me just refer this case away. Let me get it off my shoulders. Please remember that child is going to suffer. Here, it is a 12-year-old. So does the patient's choice matter? Any inputs very quickly? It's a 12-year-old who has been found to be pregnant, and we know what needs to be done. So does the patient's choice matter? Yes or no? Okay. So we'll come to assessing competency, and there has been a huge amount of debate. The UK talked about the Gillick's competencies, right? So the ultimate court rulings or whatever has come out is that every person has a certain amount of maturity. So we have to broach the topic. We cannot keep this person in the dark. This child is a minor, will have no say in the management. This is not going to work. You have to let the person know what has happened. When it comes to informed consent, the parents will be giving, but the child has to be given a complete understanding in the words that the child understands. And if the child doesn't understand at the end of your efforts, it doesn't matter, but your effort has to be there. So, the questions to be answered in this case: will the parents agree? Is the administration prepared? Most important, when you have a child abuse case like this, can I take this child away from the environment where the incident has occurred? And the final question is, as doctors, the body will be tended to. We will remove the products of conception. But what about the scar that this child's mind will have? Who is going to tend to that? So please remember, in medico-legal cases, there has to be a team effort. And do not hesitate to get in the mental health professionals at the earliest. They will help you in not only breaking the news, but at every step of the treatment. So the challenges of confidentiality, can we maintain them here? This is one place where the confidentiality will not be maintained in the interests of the child. Anyone aware about Gillick competencies? So Gillick competencies was a huge issue in the 1980s in the UK, wherein a lady by the name of Victoria Gillick, she went to court because the health visitors were going and distributing material in the adolescent age group about comprehensive sexuality education. They were telling teenagers how to be safe and how to be avoiding accidents in that particular age group. So this lady went and filed a case wherein she said that this literature cannot be distributed without parental consent. So the question she raised was, are these children competent enough to understand what is being told to them? So here again, most of the court rulings that have come in is, it has to be individualized. As a doctor, you need to make an attempt to explain, however young the person is. Whether he or she understands or not is a question to be answered later. And the parents are always there to be apprised of the situation. But you cannot abrogate the responsibility that whatever be the age of the victim, if that person is in any position to understand what has happened to him or her, or what we plan to do, it has to be conveyed. What is the difference between an assent and a consent? So we have this gray area. We have the transition of life called adolescence, where you are formulating your independent thoughts, you are formulating your opinions, but you are not in a position to take a decision. So that is where assent is important, wherein you speak to the adolescent. They may or may not, whether you're doing a procedure, whether you're doing a physical examination, you tell the person what you're going to do. And if you once have the assent of that individual, it's easier to get a consent. Ultimately, legally, consent will be provided by the parents. But as part of your practice, you may say, this is more of ethics than law, but please spend some time trying to get the assent of the youngster. Information to the police in this case has to be there within 24 hours. And if you are the doctor who has received something, you have to know that if you do not report, it is a punishable offense under the POCSO Act. So what are the difficulties faced by doctors? I'm sure many of you have faced this. Parents will say, na Dr. Babu, please, eta char kan korben na, amra family moddhe mitiye nebo. Whom to report? Lots of times, as a doctor, I will be hesitant to pick up the phone and speak to the police officer, not really knowing whether that person has been trained to handle this sensitive case. So it's very, very important that before you take this action, you spend some time in counseling the relatives, that this is not a vindictive ploy to harass them. It is a ploy in which we want to arrest a social evil, and we want to make sure that the person is healthy for the rest of their lives, both physically and mentally. So nationally, we have a helpline number, 1098. Doesn't really work, to be very honest, at many times, but it is there. As far as West Bengal is concerned, and forced by this particular experience, the West Bengal Council for Protection of Child Rights, who have their head office in Ultadanga, they have a number, and they have some very dedicated personnel who really offload this responsibility. They'll probably keep your name, that yes, Dr. Shomik Ghosh has reported, but they will be the one who would contact the relevant police station, put in the report, and set the process in motion. So you are saved from calling up the police station directly, and you have some place where you're more comfortable, and you have a place where you can convey whether the parents are willing, unwilling, and whatever other challenges that you're facing. And at the same time, you have also ensured that because this is a government agency, the reporting has been done promptly. Duties of the police, Well, once they get this report, they have to compulsorily register the case. Whether they follow it up or not, it's a sad story, but they have to register the case. They have to appoint an IO. They have to obtain clearance from the Child Welfare Committee, because in this case, a medical termination of pregnancy had to be done. And the police is also responsible for handing over the products of conception for DNA analysis with the CFSL. So the police cannot abrogate its responsibilities. And if you realize in this particular case, as a doctor, I cannot be detached. My multidisciplinary team, including the pediatrician, the mental health professional, the obstetrician, everybody is involved. Until the products of conceptus are handed over, our responsibility doesn't end. You may be facing easier situations, but this is one situation which I illustrated so that you know that if there is a situation, you must discharge your responsibilities. There will always be deterrents, like unwillingness of the parents to pursue. Child may not be of an age to understand what's going on. Doctors almost often face a dilemma about disclosing the incident, and let's not underestimate this. Given our social fabric, this is a real threat. There are social, there are political compulsions, there are legal compulsions, and what we have all faced is, while I might be empathetic and I might be having very good intentions, an overworked police force, an unsensitized police force may treat it just like any other crime, and they may do more harm than good to the particular family. The fate of the real case, finally, after going through quite a few barriers, the MTP was done. The products of conception, supposed to be handed over immediately, needed me to store them for 3 full days because there were procedural delays. What was very disturbing, and for which I had to really take the help of the West Bengal Commission, was because the CWC very intriguingly handed the child back to the family. As you all might be aware, most cases of sexual abuse, the perpetrator is within the family. So we probably need a more rigorous understanding of where this child will be safe. Thanks to the WBCPCR, and because I was the initial treating physician for this child, investigations ultimately culminated in the culprit being identified, and as per POCSO, he was an adult, and he was given a life imprisonment initially by the lower court. It's pending in the higher courts, because according to POCSO and this particular act, he is supposed to get a death sentence, right? He somehow managed to get it commuted to a life imprisonment, but he was identified and he was given a sentence. So the realization is there are enough laws to act. There is a lack of will, like many laws in our country. There is a parliamentary debate on sexual acts which are being committed by mutual consent, and social evils persist precisely for this reason, because there is a lack of will and the implementation is very poor. I had promised Priyankar and Jigna something, hopefully I'll do it. Key takeaways: acting within the rules. We have to act within the rules. Whenever there's a conflict between ethics and law, please plumb for the law. Otherwise, you will be in trouble. Be human. And the most important ethical takeaway which we give is, please work on your communication skills. You learn every day. audit yourself and make sure that you are being the best person who is talking to the patient in front. Thank you. That much is my submission for now. Questions, if the organizers permit, because I've kept 6 minutes and 55 seconds.
Thank you, Dr. Ghosh, for nicely elaborating with a practical case scenario. So any question? We can take 1 or 2 questions. I think we have enough time. Any question?
Yes. Yes. Extremely real, what you say, fear, and I think so, Priyanka, you also had called up in between. So that is why I think so the government will need to appoint a lot more of these bridging agencies, right? Jake Ami information ta dilam, like the WBCPCR, they have their own appointed officers. They come, meet the family, do the reporting on behalf of the doctor, as well as take some responsibility of counseling and preparing the legal formalities.
We informed the Child Welfare Committee
Yes.
through our MSVP,
Yes.
through our superintendent. So we are not directly involved. MSVP takes the responsibility to inform the
Absolutely.
CWC.
So if
and
you have
they
an
come, their
administrative
teams
arm
come.
who can help you in reporting within the 24 hours,
My name may be there. As
your
of
name
today,
will be there,
yeah,
right?
But,
Okay.
we're not disturbed much.
Yeah.
We just, it's our
Absolutely.
job
I
just
mean,
to inform.
the thing is, when you have an administrative arm or a machinery which can work, it's just like you have someone coming in a life and death situation. The emergency department with anesthetists, emergency medical officers, everyone is doing a particular role. Here also, we need different arms of the administration.
Just write to the MSVP officially and call
Yeah.
him and document in the BHT that such and such persons
Has
have
been
been
informed. So even for the private practitioners, please be well informed that there are arms of the government who are willing to help you, and you need not take the whole responsibility on your shoulders, because like Didi mentioned, that it's difficult in your day-to-day work to be pursuing something which is out of your domain. But yes, if you are a doctor, save the life of the child and make sure you make available all the treatment options and modalities for the child.
Like mosquito repellent or all out, something like that. So in that case, we should report all cases to police or just...
So that's
or
what
in case
we
did
said.
not report
I mean,
in good
if it is
faith.
an accidental ingestion of a mosquito repellent, why do you think the law needs to be involved? Is it crossing your head that somebody may have forcibly put it down the child?
No, not such history, no surgery. In case, suppose the child collapses in the night.
So
or
if you can defend yourself, should a question arise later, আপনি এটাকে রিসিভ করেছেন and you didn't report because you felt it was accidental, and if you can defend yourself with reasons, nobody is going to be taking any action against you. But yes, if there is a case of poisoning, poisoning cases would be long drawn out. There won't be a single case. So if you have a reason to suspect, please suspect. But if you don't have a reason to suspect, don't be afraid to stand your own ground. Thank you so much for your patient listening, and we'll get back to rheumatology, right?
Thank you.
Our next segment would be on bone health in rheumatology by our very own Dr. Priyankar Pal sir. Sir.
So, after a long day, we come to the last session of the day. The quiz we will have tomorrow. So, it's actually pretty long today. So, we have postponed the quiz I think Jigna is also agreeable with that. We'll have the quiz tomorrow because hardly anyone to interact in the quiz. So, and the quiz master is also willing to do that. So, I invite Dr. Hridoy De. Hridoy, please come to the stage. So, he will be speaking on bone health in rheumatology. So, we know that, yes, this is a very important thing that should be actually discussed because these are the patients, chronically ill children who get a lot of steroids. So Hridoy is the pediatric endocrinologist of the Institute of Child Health. And over to Hridoy for speaking on bone health.
Thank you, sir. Good evening, everyone. So actually, this topic is a little bit less commonly discussed in different rheumatology CME and also a bit neglected, at least at our part of our country. So let us start from the basics. So what are the bone components? So in a bone, there are two types of bone. One is compact bone or cortical bone and spongy or trabecular bone. That is compact is 80% and 20% is spongy bone. In a compact bone composition, the most of the part is the minerals, calcium hydroxyapatite, and 20% is protein like collagen, hyaluronic acid, and cells. There are three types of cell in a bone: osteoclast, osteoblast, and osteocytes, and water. So what is bone strength and what are the factors which determines bone strength? So it is not only the bone mineral density which determine the bone strength, also the size. The longer the bone, it is more strong. The cortical thickness, the quality of the matrix and collagen, its thickness and microarchitecture. So what are the measures to determine the bone strength? Number one, X-ray, but it can detect low bone mass only when it is already 30% bone loss is there, but it can detect vertebral compression fracture in case of glucocorticoid treatment. And quantitative ultrasound, it is not commonly used. Bone biopsy, it is the gold standard to measure the bone strength, but it is definitely not a common practice. DXA, it is the investigation of choice for determining bone mineral density. And peripheral quantitative CT, it is better than DXA because it is a three-dimensional and volumetric assessment of bone mineral density is there, but it is used for research purpose. So, little bit about DXA. Now the DEXA term is not there. They are naming it as DXA only. And it is the technique of choice to measure bone mass in children. And lumbar spine and total body less head are the preferred site. And it is expressed as Z score, age and sex specific. And also children with short stature BMD requires adjustment for height because it is two-dimensional and aerial BMD, and it will give falsely very low BMD in case of shorter bones. So these are the sites for the DXA scan for different age groups, and also they have recommended different types of ambulatory restriction or decreased weight bearing capacity or cerebral palsy like non-ambulatory children also. So what are the limitations? As I already discussed, the size of the bone, if it is shorter, then it will falsely give you very low BMD. Puberty has some effect, obesity has some effect. You have to adjust for all these things, and you have to have a proper software, proper reference range, and artifacts can give false region. So what is the definition of osteoporosis? There is specific definition. Number one, presence of one or more vertebral compression fracture in the absence of any local disease or high energy trauma, or Z score or bone mineral density less than -2, and a history of clinically significant low trauma fracture. And what is clinically significant fractures? So 2 or more long bone fractures occurring by age of 10 years, or 3 or more long bone fractures at age up to 19 years. Now coming to our main topic, effects of bone health in rheumatic diseases and its pathophysiology. So the skeletal system and the immune system share many regulatory molecules, cytokines, signaling protein receptors and transcription factors, and it is now termed as osteoimmunology. So the cytokines and pro-inflammatory molecules, it increase osteoclastic activity, so it causes increased bone resorption, and it decreases osteoblast maturation, so there is decreased bone formation also. So this is the complex pathway where you can see TNF-alpha, interleukin 6, interleukin 17, they actually stimulate osteoclastic activity by rank ligand, and also they inhibit osteoblast formation, so the bone becomes weak. So what are the roles of glucocorticoid in bone? So if there is a glucocorticoid excess, it will increase rank ligand, so there is increased osteoclastic bone resorptions. They also increases apoptosis of osteoblast and chondrocyte growth plates, and they have negative impact on growth factors, sex steroids, and so osteoblast will be less in amount. And also glucocorticoid decrease renal and abdominal, intestinal absorption of calcium. So many a time in chronic rheumatological diseases, the growth is delayed and puberty is also delayed. So if the pro-inflammatory cytokines has negative impact on growth hormone and IGF-1 X6, and as we know that growth hormone has a positive effect on bone, so that will go, and glucocorticoid use decrease pulsatile growth hormone secretions, and pubertal delay, if it is there, many a time there is delayed puberty in rheumatological diseases, and there will be less sex steroids, and there will be low bone mineral density. So what are the role of physical inactivity in rheumatic diseases? So physical activity influences up to 17% of the variability of the bone. And mechanical loading induces bone tissue strain, and it is sensed by the osteocyte system, and the osteoblast and osteoclast activity is stimulated. So any low muscle mass disease like rheumatoid cachexia, or low muscle power like in JDM, or immobility in JIA, there will be low bone mineral density. My next part of my talk will be based on this excellent journal published in Pediatric Rheumatology. This is consensus recommendations for diagnosis and treatment of secondary osteoporosis in children. So how to monitor a bone health in patients with rheumatological diseases. So there is a need to monitor BMD in patients with chronic disease like rheumatological disorders. There is no universal consensus regarding when and how to carry out this monitoring, and they said you have to follow existing guidelines on each pathology. And they had given they had also said that also special attention must be paid to patients with chronic disease who are receiving some treatment which can contribute to osteoporosis like glucocorticoid. They had given guidelines for GIA and SLE. They said that for GIA for less than 6 years, DXA in presence of any low trauma fracture, or for more than 6 years, DXA, if not GIA is not rapid remission is there, or there is a need of high dose glucocorticoid. For SLE, DXA evaluation in patients with prolonged systemic glucocorticoid exposure exceeding 0.15 mg per kg per day for more than equals to 3 months, and then repeat on annual basis if Z score is less than -2. Regarding all children and adolescents who are suspected of suffering secondary osteoporosis, they advise to do some lab tests like calcium, phosphate, vitamin D3, and PTH. So what are the imaging they had advised? So definitely DXA of the lumbar spine and total body less head is the chosen method of to measure BMD. And also for children with suspected secondary osteoporosis, it is recommended to extend the study with a plain lateral thoracic and lumbar X-ray to assess vertebral compression fracture, particularly if they are receiving glucocorticoids. And minimal interval to, again, repeating the test is actually 6 months to 1 year. Even if the initial normal BMD is normal, but if the risk factor is persisting, then you have to check BMD 1 or 2 yearly. So how to prevent low BMD in rheumatological diseases? So first, the most important step is to adequate treatment of the disease, because the treatment, if it is delayed, the disease, chronic disease itself is affecting your bone. Then oral calcium supplementation can improve BMD in healthy children with a low calcium diet, but they are saying that increase calcium in your diet by means of calcium-rich food rather than giving supplementation. Now coming to the treatment part, Now, vitamin D and calcium. Vitamin D supplementation must be prescribed for all those patients with chronic pathologies and chronic rheumatoid disease where vitamin D3 is less than 20, and if it is between 20 to 30 ng per ml, but Z-score BMD is -2 or any data showing bone fragility, you have to also give vitamin D. Along with that, give calcium supplementation. So what are the other pharmacological agents used? Number one, bisphosphonate, most important. Then rank ligand inhibitor denosumab, selective estrogen receptor modulator, and sex steroids for hypogonadism, and teriparatide PTH. So what are the indications of bisphosphonate in secondary osteoporosis due to rheumatological diseases? So treatment with bisphosphonate should be administered to patients with osteoporosis if it is established, and also without osteoporosis if the bone mineral density is low, like if there is a risk factor present and Z-score is -2.5 standard deviation with a declining trajectory confirmed at least on 2 occasions 1 year apart. And also, even if there is a no persisting risk factor, if patient Z-score is -3 standard deviation with a declining trajectory over at least 2 separate occasions with 1 year apart. So what is the role of administration, IV or oral? IV bisphosphonate should be used in children. Oral is not much effective. So there is two different bisphosphonate commonly used. One is pamidronate. It is second generation, long duration absent, and it is the protocol of pamidronate. Only to mention that it is used for consecutive 3 days and 3 to 4 monthly frequency, and infusion in 100 to 250 ml of normal saline over 4 hours. Zoledronate, it is third generation, highly potent. It has direct effect on osteoblast, including the anti-osteoclastic activity. It has longer duration of action. This is the protocol, and it is used as a single dose, and it is the frequency is 6 monthly, and so it is better to give. Generally, we prefer to give zoledronate, and also the duration of injection is very low, only half an hour to 1 hour duration, and it is also available as premix solution as well. So only daycare can be well enough. So these are the few side effects. Most important is acute fat response, and you have to keep in mind about hypocalcemia, osteonecrosis of jaw, and etc. Now, my last few slides, especially to concentrate on glucocorticoid-induced osteoporosis. So, when you should initiate bone health monitoring in children treated with glucocorticoid? So, if more than equals to 3 months of daily oral or intravenous glucocorticoid at supraphysiological dose. So, what is physiological dose of prednisolone? That is 5 mg per day. Or irrespective of glucocorticoid dose, if there is back pain, if the underlying disease is poorly controlled, or if there is a chronic subnormal mobility. So they said that lateral spine X-ray you should do at the beginning of the treatment with glucocorticoid and after 1 year. And it is recommended to carry out lumbar spine or total body less head DXA within the first 6 months after beginning of treatment with glucocorticoid, and then every 9 to 12 months if treatment continues. And also they say definitely you have to give vitamin D and calcium, and it should be maintained even after 3 months after discontinuation of glucocorticoid. And for inhaled corticosteroid at dose under 800 microgram per day, the DXA or X-ray is not required. And for management purpose, so you have to categorize who have to give treatment, because there are some potential to recovery from osteoporosis even without bisphosphonate therapy. So if the disease is aggressive but the risk factor is permanent, like Duchenne muscular dystrophy, there is high chance you have to give bisphosphonate. If the inflammatory disorder is variable risk factor, like any rheumatological disease, then there is variable chance for recovery without treatment. And if the disease is aggressive but the risk factors are transient, like leukemia, there is significant chance of recovering from osteoporosis without bisphosphonate treatment. So take home messages. So the negative impact on bone health in patients with rheumatological diseases is well established. Proper treatment of the disease is the most important step. Timely monitoring on bone health is needed. Special attention needed to patients treated with glucocorticoid, and don't hesitate to start intervention with bisphosphonate whenever it is needed. Thank you.
Any comments?
Yeah. Yeah.
I've tried to do it many times. When I was in SSKM, they do in the rheumatology department DXA. But when I tried to contact them for child patients, they said, no, you cannot do that because we don't have any data.
No.
Our equipment is
There are
not
few labs
calibrated to do children's
There are only
BMD.
few labs like
So
one
I
is
just wish to have information from you that...
So there are few labs only like Quadra 1, Ecote Kore, Elote Pediatric DXA hoy. So whenever you are seeing report of DXA, if there is mental Z score, then it is standardized and there is reference data. But if you are seeing T score, that means they are using the adult data only. Because in children, T score is not used, only Z score is used.
Z scores, age-specific Z scores.
Shupana, would you like to comment? Shupana did an extensive work on DXA.
Especially for children only.
RKM
Also done, also in children we do it. So I wanted to ask you that what is the risk of radiation exposure?
DXA. DXA radiation exposure is like not that much of a CT scan.
Okay.
Though even it is a dual energy beam,
Yeah.
so you can take it as 2 X-ray on a single DEXA scan report.
So,
because from X-ray and DXA there is only two difference. There is two beam of this thing, so that you can take two-dimensional picture of a thing.
So we had done an
But definitely it is exposing whole body. So if you are taking a whole body X-ray,
no, we only actually in our
so
practice.
whole body means total body,
TPM,
less
yes.
head and lumbar spine. So if you are taking a single X-ray of the whole body, then if it multiply into 2, then that will be the radiation exposure of.
And actually we had done a study at our institute, and then we had picked up many children who were asymptomatic actually, with a Z score of -4, -5, especially the SJIA children, who actually go and have over-the-counter steroids. So I think we as rheumatologists, we should be very much apprehensive and try to pick this up early. Suma, what is your practice? Do you recommend DEXA? What are you people doing?
I think we don't do DEXA routinely unless you're suspecting your patient has a fracture, etc. I mean, I'm talking about the rheumatology patients, not in general. However, there is actually an elegant study. It's a multi-center, very important study, which I think Michelle Petrie's team from Ireland have done. And they have actually shown that with all these patients whom we're going to give long-term pretty high-dose steroids like lupus, JDM, systemic GIA, etc., they have actually given a recommendation for prophylactic bisphosphonates along with the high-dose steroids. I don't think I've used it for every patient, but any patient who's had a fracture, anything after starting treatment, definitely we give them bisphosphonates. The other thing I've found is, the other area where we use bisphosphonates I've found is in AVN. The patients who develop AVN, we have, part of the pathology for evolving AVN could be the steroids, part could be the inflammatory part of the disease itself. And especially hip AVN, we find that giving them bisphosphonates is helping to relieve the pain and put off the corrective surgical procedures for some time, buy time for them. So those are two situations. And that is one area where oral alendronate seems to help. I wouldn't use oral bisphosphonates at all otherwise, but that is one area where it seems to help.
Yeah, so when you are getting a fracture, already BMD is already more than 3 SD or 4 SD below the cutoff.
We need to be careful with our steroid usage. We need to make sure that we get patients to move, because half of the problem is if they are non-mobile, that is going to exacerbate the problem
Yeah, and
considerably.
also always we tend to have in our mind that just steroid চলছে বলেই হয়তো আমাকে বোন এটা করতে হবে কিন্তু we have to keep in mind that disease itself is causing bone loss. Not only steroid is the only reason for decreasing bone mineral density.
I have an experience. We did bone mass density in a low-income group school, not at all affected by any disease. But just because it was a low-income group school, the bone density came very low. Then we took the history that how it is so low. They said that they work in pen factories throughout the day. Then they go to school. Then they come back and they watch TV having that cold drinks and chips, no activity at all. So that is the reason for low mass density. I just thought that it was relevant, that's why I just wanted to say.
Sir, any idea that nowadays we are getting a combination of calcium with calcitriol combinations?
I don't think there is a recommendation to use anything such combination
in pediatrics?
pediatric age group.
Yes, so
Many calcium syrup, you name it, it has some amount of vitamin D, 200, 100, but
no, vitamin D is separate, but nowadays calcitriol combinations are coming.
you are meaning rocatrol with calcium?
Yes.
No, there is no such role of combination therapy.
Yeah. Because I have encountered, because many patients they come with that, so that is the other thing.
So, and why should you use calcitriol in a vitamin D deficiency? You have to use 25 OH D3, right? So you don't have to calcitriol. You have to give only if there is vitamin D deficiency rickets
CKD.
or this thing or hyperphosphatemic ricket or these things.
In case of renal problems, calcitriol may be used.
Yes.
Otherwise,
My question to Suparna ma'am, are you doing the screening DEXA scan for all lupus, JDMS and systemic GIA patients?
What we are doing is that before we are starting steroids, major organ involvement, before we are starting steroids, we are doing a DEXA. Baseline. Yes. That is what the Spanish recommendation had said. So we are doing a baseline DEXA for the major organ involvement, yes. JDM patients, lupus patients, we are doing a baseline DEXA. Actually, initially you don't get, Arjun, what happens? Down the disease, you get it. And surprisingly, in our cohort, we saw that more of SGIA, we got a poor DEXA rather than the lupus. Lupus patients, sometime or the other, we usually stop. Within 6 months, we go to 0.15 and then usually stop. It is the SGIA patients, ektu batha holo, they go and have over-the-counter steroids. They are the ones who we have seen getting a very poor Z score. No, see, -4, -5, -5 of the pechi, we usually repeat it after 1 year. Yes, if they are improving, we don't do anything. But if they go, oneker hoyeche, we have given only one zolindonate.
So,
conditions are kidney patients, nephrotic syndrome, and get more steroids. So that is the issue of bone mineral
not
density.
necessarily a lot of these nephrotic syndrome patients, they are using MMF now. All these difficult nephrotic syndromes, they are using cyclophosphamide,
So it's
MMF.
a practical problem, but we don't have facilities to get it done more easily.
So I think it's time to call it a day. So a group photo, yes, that's a good idea. We can have a group photo. So just to, it's been a long day. It's almost 6 p.m. So I think almost I can steal at least 1/3 of the audience is still there. So rheumatology is really making people sit back and listen. And tomorrow, the session starts at 8:30 in the morning. 8:30, sir, no, sir. 8:30, there's a workshop, echocardiography workshop. I think a lot of students have registered for that workshop. The session starts from 10.